ব্যাস, ভাইরাসের আয়তন ব্যাস 8 থেকে 300 ন্যানোমিটার। গবাদি পশুর ফুট অ্যান্ড মাউথ ভাইরাস হচ্ছে সবচেয়ে ক্ষুদ্র ভাইরাস। এটি হলো 8 থেকে 12 ন্যানোমিটার। সম্প্রতি আবিষ্কৃত প্যান্ডোরা ভাইরাস সবচেয়ে বৃহত্তম। হচ্ছে পোলিও ভাইরাস, এটি 280 থেকে 300 ন্যানোমিটার। প্যান্ডোরা ভাইরাস। উদ্ভিদ ভাইরাস বৃহত্তম সাইট্রাস ট্রিস্টাজা ভাইরাস, এটি হলো 200 থেকে 300 ন্যানোমিটার। ভ্যাকসিনিয়া ভ্যারিওলা ভাইরাস 280 থেকে 300 ন্যানোমিটার। আর পোলিও ভাইরাস 280 থেকে 300 ন্যানোমিটার। সবচেয়ে ক্ষুদ্রতম ভাইরাস হলো স্যাটেলাইট টোবাকো নেক্রোসিস ভাইরাস। আর প্রাণী ভাইরাসের বৃহত্তম হলো গুটি বসন্তের ভিরিওলা ভাইরাস 350 ইন্টু 250 ইন্টু 100। আর ক্ষুদ্রতম হলো গবাদি পশুর ফুড অ্যান্ড মাউথ ভাইরাস 300 ন্যানোমিটার। ভাইরাসের বৈশিষ্ট্য। ভাইরাস দুটি স্বতন্ত্র দশা দেখা যায়, যেমন বহিঃকোষীয় দশা এবং অন্তঃকোষীয় দশা। ভাইরাস অকোষীয় জৈব কণা ও অতি আণুবীক্ষণিক 0.1 থেকে 0.3 মাইক্রোমিটার প্রোটোপ্লাজমবিহীন রাসায়নিক পদার্থ। এদের সাইটোপ্লাজম, কোষঝিল্লি ও কোষ প্রাচীর, রাইবোসোম, মাইটোকন্ড্রিয়া এসব নেই। এদের বিপাকীয় এনজাইম এবং পুষ্টিক্রিয়া নেই। ভাইরাসের জীবন কোষের সাহায্য ছাড়া সঠিকভাবে প্রজনন অক্ষম নয়। ব্যাকটেরিয়া রোধক ফিল্টার মাইক্রোফিল্টার ভাইরাস ফিল্টারযোগ্য নয়। ভাইরাসকে কেলাসিত করা যায়, সেন্ট্রিফিউজ করা যায়, ব্যাপন করা যায়, পানির সাথে মিশিয়ে সাসপেনশন তৈরি করা ও তরলীকরণ করা যায়। জীবকোষের বাইরে ভাইরাস রাসায়নিক কণার মতো নিষ্ক্রিয়। ভাইরাসের দৈহিক গঠন নেই এবং পরিবেশ উদ্দীপনায় সাড়া দেয় না। এদের মধ্যে কোনো শরীরবৃত্তীয় ক্রিয়া, শ্বসন, রেচন, চলন, বৃদ্ধি ইত্যাদি নেই। ভাইরাসের প্রোটিন ও নিউক্লিক অ্যাসিডের সমাহার মাত্র। ভাইরাস অ্যাসিড, ক্ষার ও লবণ প্রতিরোধে সক্ষম এবং অ্যান্টিবায়োটিক এদের দেহে কোনোরূপ প্রতিক্রিয়া সৃষ্টি করাতে পারে না। এরা তাপ সহনীয়, সহনশীল, অধিক সূর্যালোক কোনো ক্ষতি করতে পারে না। জীবীয় বৈশিষ্ট্য। পোষক কোষের অভ্যন্তরে সংখ্যা বৃদ্ধি করতে পারে। নতুন মূল ভাইরাসের বৈশিষ্ট্য বজায় থাকে। গাঠনিকভাবে ভাইরাসের নিউক্লিক অ্যাসিড, ডিএনএ, আরএনএ আছে। সুনির্দিষ্ট বাধ্যতামূলক পরজীবী, অন্তঃকোষীয় পরজীবী। ভাইরাসের পরিব্যক্তি ঘটাতে ও স্ট্রেইন প্রকরণ ভ্যারিয়েশন তৈরি করতে সক্ষম। জিনগত পুনর্বিন্যাস ও বংশগতি ও পুনঃসমন্বয় ঘটে। এদের অভিযোজন ও প্রতিরোধ ক্ষমতা আছে। নোভেল করোনা ভাইরাসের জিনোম ডিলিটেশন করতে দেখা যাচ্ছে, যা এরা সংক্রমণ ক্ষমতা হ্রাস করে। জিনোম ডিলিটেশন যা এর সংক্রমণ ক্ষমতা হ্রাস করে। এদের অভিযোজন প্রতিরোধ ক্ষমতা আছে। নোভেল করোনা ভাইরাসের জিনোমে ডিলিটেশন করতে দেখা যাচ্ছে, ডিলিশন করতে দেখা যাচ্ছে, যা এর সংক্রমণ ক্ষমতা হ্রাস করে। ভাইরাস লাইসোজোম ও আরও বিভিন্ন প্রকার এনজাইম সংশ্লেষণ করতে পারে। লাইসোজোম। ভাইরাসের গঠন। প্রতিটি ভাইরাস প্রধানত 3-4 অংশে বিভক্ত: নিউক্লিক অ্যাসিড, ক্যাপসিড, বহি আবরণ এবং এনজাইম। নিউক্লিক অ্যাসিড। ভাইরাসের নিউক্লিক অ্যাসিড নিউক্লিয়েট তুল্য বলা যেতে পারে। নিউক্লিক অ্যাসিড নিউক্লিয়েট তুল্য বলা যেতে পারে। এতে ডিএনএ ও আরএনএ সাধারণত একসাথে অবস্থান করে না। ইনফ্লুয়েঞ্জা ভাইরাসে ডিএনএ এবং আরএনএ উভয়ই থাকে। যেমন দুটি ভাইরাসের এক অণু নিউক্লিক অ্যাসিড থাকে, তবে কিছু ভাইরাসের একাধিক অণু নিউক্লিক অ্যাসিড থাকতে পারে। যেমন রিট্রোভাইরাস 2 অণু আরএনএ থাকে, তবে কিছু ভাইরাসের একাধিক নিউক্লিক অ্যাসিড থাকতে পারে। যেমন রিট্রোভাইরাসে 2 অণু আরএনএ থাকে। 2 অণু আরএনএ। সাধারণত উদ্ভিদ ভাইরাসে আরএনএ এবং প্রাণী ভাইরাসে ডিএনএ থাকে। উদ্ভিদ ভাইরাস হওয়া সত্ত্বেও ডালিয়ার ও ফুলকপির মোজাইক ভাইরাসে ডিএনএ থাকে। ডালিয়া ও ফুলকপির মোজাইক ভাইরাসে ডিএনএ থাকে। মানবদেহে ক্যান্সার সৃষ্টিকারী ডিএনএ ভাইরাসকে সাইমিয়ান ভাইরাস এবং আরএনএ ভাইরাসকে রিট্রোভাইরাস বলে। সাইমিয়ান ভাইরাস এবং রিট্রোভাইরাস, এদেরকে অঙ্কোজেনিক ভাইরাসও বলা হয়। এই ভাইরাসে ক্লিনিক্যাল অ্যাসিডের পরিমাণ 1 থেকে 50% পর্যন্ত হতে পারে। জেনেটিক দিয়ে এটি ক্যাপসিড, জৈবিক দিক দিয়ে এটি নিষ্ক্রিয়। ব্যাকটেরিয়া ছাড়া ক্যাপসিডের স্নেহ পদার্থ ও শ্বেতসার থাকতে পারে। প্রতিটি প্রোটিন অণুকে ক্যাপসোমিয়ার বলে। ক্যাপসিডের প্রোটিন অণু বিন্যাস ভাইরাসের আকার আকৃতি নিয়ন্ত্রণ করে। প্রোটিন অণু সজ্জিত হয় দণ্ডাকৃতি, হেলিক্স ও গোলাকৃতি হ্যালো পলিহেড্রন কাঠামো গঠন করে। প্রতিটি ভিডিওনে সর্বোচ্চ 2000 থেকে 2130টি ক্যাপসোমিয়ার থাকে। 2000 থেকে 2130টি। ফাই এক্স 174 ফাজে সবচেয়ে কম সংখ্যক ক্যাপসোমিয়ার মাত্র 21টি থাকে। ভেতরের বস্তুকে ডিএনএ এবং আরএনএ সুরক্ষা দেয়। ক্যাপসিড প্রোটিন অণু হওয়া সত্ত্বেও অ্যান্টিজেনিক বৈশিষ্ট্য আছে এবং পোষক কোষে প্রবেশ করে অ্যান্টিবডি উৎপাদন করে, সর্দি জ্বরে একটি হাঁচির উদ্রেক করে। ক্যাপসিড সর্দি জ্বরে হাঁচির উদ্রেক করে। বহিস্থ আবরণ এনভেলপের মোড়ক। ক্যাপসিডের বাহিরে লিপিড গঠিত অতিরিক্ত আবরণযুক্ত ভাইরাসকে লিপোভাইরাস বলে। আবরণের গঠনগত একককে প্যাপলোমিয়ার বলে, যেমন হার্পিস, ইনফ্লুয়েঞ্জা, এইচআইভি, করোনা, ভ্যাকসিনিয়া ইত্যাদি। ক্যাপসিডের বাইরে লিপিড গঠিত অতিরিক্ত আবরণযুক্ত ভাইরাসকে লিপোভাইরাস বলে। আবরণের গঠনগত একককে প্যাপলোমিয়ার বলে, যেমন হার্পিস, ইনফ্লুয়েঞ্জা, এইচআইভি, করোনা, ভ্যাকসিনিয়া। এনভেলপবিহীন ভাইরাসকে নগ্ন ভাইরাস বলে, যেমন টিএমভি। টিএমভি হলো একটি এনভেলপবিহীন নগ্ন ভাইরাস, টিএমভি। ক্যাপসিডের বাইরে লিপিড গঠিত অতিরিক্ত আবরণযুক্ত ভাইরাসকে লিপোভাইরাস বলে। আবরণের গঠনগত একককে প্যাপলোমিয়ার বলে, যেমন হার্পিস, ইনফ্লুয়েঞ্জা, এইচআইভি, করোনা ও ভ্যাকসিনিয়া ভাইরাস। হার্পিস, ইনফ্লুয়েঞ্জা, এইচআইভি, করোনা, ভ্যাকসিনিয়া ভাইরাস। এনভেলপবিহীন ভাইরাসকে নগ্ন ভাইরাস বলে, যেমন টিএমভি। আবরণের বহিঃপৃষ্ঠ মসৃণ অথবা স্পাইক কাঁটাযুক্ত হতে পারে, তবে প্রজাতিভেদে স্পাইকের সংখ্যা নির্দিষ্ট। স্পাইক গ্লাইকোপ্রোটিন নিয়ে গঠিত। কোনো ভাইরাসের স্পাইকগুলো হিমোলাইসিস হিমাগ্লুটিন ক্রিয়া করে থাকে। কোনো ভাইরাসে লিপিড, পলিস্যাকারাইড, তামা, বায়োটিন ও এনজাইম থাকে। ভাইরাসের দেহে সর্বদা এনজাইম থাকে না। ব্যতিক্রমগুলি হলো লাইসোজাইম, ব্যাকটেরিওফাজ। সর্বদা এনজাইম থাকে না। ব্যতিক্রমগুলি হলো লাইসোজাইম, ব্যাকটেরিওফাজ, নিউরামিনিডেজ, ইনফ্লুয়েঞ্জা ভাইরাস, রিভার্স ট্রান্সক্রিপ্টেজ, আরএনএ ডিএনএ তৈরি এইচআইভি এবং আরএনএ পলিমারেজ, আরএনএ ট্রান্সক্রিপ্টেজ ইত্যাদি। ভাইরাসে কোনটি থাকে? এটি হলো নিউক্লিক অ্যাসিড। সাইটোপ্লাজমও থাকে না, নিউক্লিয়াস থাকে না, মাইটোকন্ড্রিয়াও থাকে না। ভাইরাসের গঠনে কোন জোড়াটি সঠিক? এটি হলো প্রোটিন ও নিউক্লিক অ্যাসিড রয়েছে। শর্করা, অ্যামিনো অ্যাসিড, শর্করা, নিউক্লিক অ্যাসিড, প্রোটিন, অ্যামিনো অ্যাসিড সঠিক নয়, প্রোটিন ও নিউক্লিক অ্যাসিড রয়েছে। ভাইরাসের জন্য নিম্নের কোনটি সঠিক? এটি হলো পোষকের বাইরে নিষ্ক্রিয়, প্রকরণ সৃষ্টি করে না, আবাসস্থল মৃত কোষ, আবির্ভাব ক্রিয়া সংঘটিত হয়, সবগুলোই সঠিক নয়। ভাইরাসের প্রকারভেদ আকৃতি উদাহরণ: দণ্ডাকার, আলফা মোজাইক ভাইরাস, টিএমভি ভাইরাস, মাম্পস ভাইরাস। আর গোলাকার হলো পোলিও ভাইরাস, ডেঙ্গু ভাইরাস, এইচআইভি, টিআইভি, করোনা, টমেটোর বুশচিয়ান ভাইরাস। ঘন আকার, পাউরুটি আকার, হার্পিস ভাইরাস, ভ্যাকসিনিয়া ভাইরাস, অ্যাডিনো ভাইরাস। ব্যাঙাচি আকার, T2, T4, T6, ব্যাকটেরিওফাজ ভাইরাস। ডিম্বা আকার, ইনফ্লুয়েঞ্জা ভাইরাস। সিলিন্ড্রিক্যাল সূত্রাকার, ইবোলা, মোটর স্ট্রিক ভাইরাস, মেইন স্ট্রিক ভাইরাস ও লেটুস মোজাইক ভাইরাস। বুলেট আকার, র্যাবিডোভাইরাস। প্লেট আকৃতি, তামাকের নেক্রোসিস ভাইরাস। নিউক্লিক অ্যাসিডের ভিত্তিতে ডিএনএ: একসূত্রক পারভোভিরিডি গোত্রের ভাইরাস এবং M3 কোলিফাজ ভাইরাস, এবং দ্বিসূত্রক ভ্যাকসিনিয়া ভাইরাস, T2 ভাইরাস, টিআইভি, অ্যাডিনোহার্পিস সিমপ্লেক্স এবং ভেরিওলা। আরএনএ ভাইরাস: একসূত্রক আরএনএ, টিএমভি, এইচআইভি, ডেঙ্গু, পোলিও, মাম্পস, রেবিস, করোনা ভাইরাস। দ্বিসূত্রক আরএনএ, ভিরিডি গোত্রের ভাইরাস, ধানের বামন রোগ, রিও ভাইরাস। মনে রাখা সহজ। ডিএনএ ভাইরাস: টিপুর ভাই টিঙ্কু ভ্যানিলা হতে ফ্রান্সে এলো। টিআইভি, ভ্যারিওলা, T2, ভ্যাকসিনিয়া, হার্পিস, হেপাটাইটিস বি, ফোলকপির মোজাইক ভাইরাস, অ্যাডিনো ভাইরাস। পোষক দেহ অনুসারে প্রাণী ভাইরাস, হাম, পোলিও, এইচআইভি, ভ্যাকসিনি ইত্যাদি। উদ্ভিদ ভাইরাস, টিএমভি, বিওয়াইভি, বি নিয়ালো ভাইরাস। ব্যতিক্রম ফুলকপি ও ডালিয়ার মোজাইক ভাইরাস। আর ব্যাকটেরিওফাজ, ব্যাকটেরিয়া ধ্বংসকারী ভাইরাস, T2 ভাইরাস। সায়ানোফাজ ভাইরাস নীলাভ সবুজ শৈবালকে ধ্বংস করে, যেমন LPP এবং LPP1 এবং LPP2। ছত্রাক আক্রমণকারী ভাইরাস, যেমন PSV2 পিনিসিলিনকে আক্রমণ করে। বহিস্থ আবরণ অনুযায়ী ভাইরাস: বহিস্থ আবরণ অনুযায়ী নগ্ন ভাইরাস, TMV, T2। বহিস্থ আবরণ অনুযায়ী লিপোভাইরাস, ইনফ্লুয়েঞ্জা ভাইরাস, হার্পিস ভাইরাস, এইচআইভি, করোনা ভাইরাস, HBV ভাইরাস, নেমোনিক এইচআইভি। জননের প্রকৃতি অনুসারে লাইটিক ভাইরাস, T2, T3, T4 ভাইরাস। আর লাইসোজেনিক ভাইরাস, ল্যামডা ফাজ ভাইরাস। পোষক দেহের সংক্রমণ বংশবৃদ্ধির ধরন অনুসারে রিট্রোভাইরাস, এইচআইভি, করোনা ভাইরাস। ভেরি ভেরি ইম্পর্টেন্ট। ডিএনএ আরএনএ ভাইরাসের মধ্যে পার্থক্যের বিষয় ডিএনএ ভাইরাস এবং আরএনএ ভাইরাস। আকৃতি, এরা সাধারণত গোলাকার, ব্যাঙাচি আকার, পাউরুটি আকৃতি। আরএনএ ভাইরাস এরা সাধারণত দণ্ডাকার এবং ক্ষুদ্রাকার। ডিএনএ ভাইরাস, অধিকাংশ ডিএনএ ভাইরাস প্রাণীকে আক্রমণ করে, অধিকাংশ আরএনএ ভাইরাস উদ্ভিদকে আক্রমণ করে। নিউক্লিক অ্যাসিড ডিএনএ, নিউক্লিক অ্যাসিড আরএনএ। সূত্র, অধিকাংশ ভাইরাসের ডিএনএ দ্বিসূত্র, কিছু ক্ষেত্রে একসূত্রক, যেমন M3 কলিফাস ভাইরাস। আর আরএনএ ভাইরাস, অধিকাংশ ভাইরাসের আরএনএ একসূত্র, কিছু ক্ষেত্রে দ্বিসূত্রক, যেমন ধানের বামন ও রিও ভাইরাস। ফাজ, ব্যাকটেরিয়া ফাজ ডিএনএ ভাইরাস, সায়ানোফাজগুলো আরএনএ ভাইরাস। এনভেলপ সাধারণত থাকে না। প্রবেশের ধরন, এরা বাহক পতঙ্গ দ্বারা সৃষ্টি ক্ষত স্থানের মাধ্যমে পোষক দেহে প্রবেশ করে, সাধারণত এন্ডোসাইটোসিস প্রক্রিয়ায় পোষক দেহে প্রবেশ করে। টিএমবি ভাইরাস, পটেটো এক্স ভাইরাস, সুগার কেন মোজাইক ও টার্পিন মোজাইক ভাইরাস, আলফালফা মোজাইক ভাইরাস। রেবিস, মানুষের পোলিও, ডেঙ্গু, পিতজ্বর, মাম্পস, জিকা ভাইরাস, নিপা ভাইরাস। ইনফ্লুয়েঞ্জা বি ও এনসেফালাইটিক ভাইরাস। T2 ভাইরাস, ব্যাকটেরিয়া, ভেরিওলা, টিএমবি, এরিনো সিমপ্লেক্স ভাইরাস ইত্যাদি। প্রাণী হওয়া সত্ত্বেও আরএনএ ভাইরাসে বিদ্যমান জিকা ভাইরাস, পোলিও ভাইরাস, ইনফ্লুয়েঞ্জা ভাইরাস, এইচআইভি ভাইরাস, রেবিস ভাইরাস, রিও ভাইরাস এবং আরপো ভাইরাস। নিচের কোনটি ডিএনএ ভাইরাস? ডেঙ্গুও নয়, চিকুনগুনিয়াও নয়, টোবাকো মোজাইকও নয়, এটি হল হ্যাপাটাইটিস ডি, এটি ডিএনএ ভাইরাস। নিচের কোনটি আরএনএ ভাইরাসের উদাহরণ নয়? এটি হলো ভেরিওলা ভাইরাস। মাম্পস ভাইরাসও নয়, রেবিসও নয়, পোলিও নয়, এগুলো কোনোটাই আরএনএ ভাইরাস? এগুলো সবগুলোই আরএনএ ভাইরাস, শুধুমাত্র ভেরিওলা হলো ডিএনএ ভাইরাস। নিচের কোনটি ভাইরাসজনিত জ্বর নয়? ডেঙ্গুও নয়, চিকুনগুনিয়া নয়, ভাইরাসজনিত জ্বর নয়, অর্থাৎ ব্যাকটেরিয়া ঘটিত রোগ। ইনফ্লুয়েঞ্জা, চিকুনগুনিয়া, ডেঙ্গু সবগুলোই ভাইরাসজনিত, একমাত্র ব্যাকটেরিয়া জনিত হলো টাইফয়েড। কোনটি সমগোত্রীয় নয়? ইয়েলো ফিভার, ডেঙ্গু ফিভার আর ইনফ্লুয়েঞ্জা ফিভার। তার মধ্যে হলো টাইফয়েড ফিভার। ইয়েলো ফিভার, ডেঙ্গু ফিভার সবগুলি হলো ভাইরাস ঘটিত, আর এটা হলো ব্যাকটেরিয়া ঘটিত। কোন ভাইরাসটি ঘন আকার? এটি হলো ভ্যাকসিনিয়া। ভাইরাসের পরজীবিতা, পোষক কোষের কোনো ভাইরাস প্রোটিনের জন্য রিসেপ্টর সাইট থাকলে তবে ভাইরাসের পোষককে আক্রমণ করে। পোলিও ভাইরাস, পোষক ভাইরাস এবং পোষক কোষ। ঊর্ধ্বতন শ্বাসনালী, টিএমবি ভাইরাস এবং তামাক গাছ। ঠান্ডা লাগার ভাইরাস, শ্বাসতন্ত্র মিউকাস মেমব্রেন। হেপাটাইটিস ভাইরাস, যকৃত কোষ। ফাজ ভাইরাস, ব্যাকটেরিয়া কোষ। টিএমবি ভাইরাস, তামাক গাছ। এইচআইভি ভাইরাস, শ্বেত রক্তকণিকা। তাই এইচআইভি ভাইরাস আক্রমণ করে শ্বেত রক্তকণিকাকে। আর চিকেন পক্স ভাইরাস, ত্বক কোষ। T2 ভাইরাস, ইকোলাই। টিএমবি ভাইরাস, তামাক গাছ। আর ফাজ ভাইরাস, ব্যাকটেরিয়া। হেপাটাইটিস ভাইরাস, যকৃত ভাইরাস এবং পোলিও ভাইরাস, শ্বাসনালীতন্ত্র ভাইরাস। সাব ভাইরাল সত্তা, যে সকল সত্তাসমূহ ভাইরাস থেকে আকারে ছোট কিন্তু ভাইরাসের কোনো না কোনো বৈশিষ্ট্য বহন করে তাদের সাব ভাইরাল সত্তা বলে। ভিরিয়ন, নিউক্লিক অ্যাসিডকে ঘিরে অবস্থিত ক্যাপসিডের সমন্বয়ে গঠিত একটি সংক্রমণ ক্ষমতা সম্পন্ন ভাইরাসকে ভিরিয়ন বলে। প্রতিটি ভিরিয়নে 2000 থেকে 2130টি ক্যাপসিমিয়ার থাকে। যে সকল সত্তাসমূহ ভাইরাস থেকে আকারে ছোট কিন্তু ভাইরাসের কোনো বৈশিষ্ট্য বহন করে, আকারে ছোট ভাইরাসের কোনো না কোনো বৈশিষ্ট্য বহন করে, ভিরিয়ন। নিউক্লিক অ্যাসিড ঘিরে অবস্থিত ক্যাপসিডের সমন্বয়ে গঠিত সংক্রমণ ক্ষমতা সম্পন্ন ভাইরাসকে ভিরিয়ন বলে। ভিরিওয়েডস গঠন, এরা হলো সংক্রমণ একসূত্র বৃত্তাকার আরএনএ। এরা কয়েকশত নিউক্লিওটাইড দিয়ে গঠিত রোগ সৃষ্টিকারী সত্তার মধ্যে ক্ষুদ্রতম নিউক্লিয়াইডটি ক্ষুদ্রতম, কেবল উদ্ভিদ দেহে রোগ সৃষ্টি করতে পারে। নিউক্লিয়েটস। আর উদাহরণ, নারকেল গাছের ক্যাটাঙ্গুর সৃষ্টি করে হেপাটাইটিস ডি এর কারণেও ভিরিওয়েডস মনে করা হয়। গোল আলুর স্পিন্ডল টিউমার ও অ্যাভোকাডোর সানবিচ রোগ সৃষ্টি করে। PSTVD, পটেটো স্পিন্ডল টিউবার ভিরিওর প্রথম শনাক্তকারী ভিরিয়েন্টস। প্রিয়ন্স, এরা নিউক্লিক অ্যাসিডবিহীন প্রোটিন আবরণ, শুধুমাত্র প্রাণীদের রোগ সৃষ্টি করে। প্রিয়ন্স। মানুষের কেন্দ্রীয় স্নায়ুতন্ত্র পুরু এবং ক্রুটসফেলস এর রোগ সৃষ্টি করে। প্রিয়ন্স। ক্রুটসফেলস এর রোগ সৃষ্টি করে। ভেড়া ও ছাগলের স্কার্পি রোগে প্রিয়ন্সের জন্য হয়ে থাকে। ম্যাড কাউ রোগে প্রিয়ন্স সংক্রামকতা পাওয়া যায়। স্যাটেলাইট, কোনো নিউক্লিয়াস অ্যাসিড গঠিত সত্তা যা পোষক দেহের কোষের মাধ্যমে অন্য একটি ভাইরাস কোষের সাহায্যে প্রতিলিপি সৃষ্টি করে সক্ষম। যখন কোনো প্রোটিন আবরণ দ্বারা স্যাটেলাইট আবদ্ধ হয় তখন তাকে স্যাটেলাইট ভাইরাস বলে। 5 বিজ্ঞানী দি হ্যানলি ফাজ ভাইরাসের ব্যাকটেরিয়া নামকরণ করেন। ফাদ শব্দ গ্রিক কথা হল টু ইট বা ভক্ষণ করা। নিউক্লিক অ্যাসিড, সংক্রমণ ক্ষমতাবিহীন ভাইরাসকে নিউক্লিক অ্যাসিড বলে। ম্যাক্স ভাইরাস, কোনো ভাইরাসের ক্যাপসিড আবরণীকে একটি ঝিল্লি আস্তর থাকে, একে মিক্স ভাইরাস বলে। অস্ট্রেলিয়াতে খরগোশ নিয়ন্ত্রণে মিক্স ভাইরাস ব্যবহার করা হয়। মিক্স ভাইরাস নিচের কোনটিকে সংক্রমণ পূর্ণাঙ্গ ভাইরাস কণা বলে? এটি হলো বি, ভিরিয়ন। নিউক্লিকও বলে না, প্রিয়ন্সকেও বলে না, ভিরিয়য়েডসকেও বলে না। ভিরিয়ন, ভিরিয়য়েডস, প্রিয়ন্সের মধ্যে পার্থক্য বিষয় ভিরিয়ন, ভিরিয়য়েডস এবং প্রিয়ন্স। নিউক্লিয়ের বস্তু আরএনএ, ডিএনএ। ভিরিয়য়েডস আরএনএ থাকে কিন্তু ডিএনএ থাকে না। প্রিয়ন্স নিউক্লিক অ্যাসিড থাকে না। প্রোটিনের উপস্থিতি, এতে প্রোটিন থাকে, এতে প্রোটিন থাকে না, এতে শুধু প্রোটিন থাকে। প্রোটিন থাকে, এতে প্রোটিন থাকে না। ভিরিয়ন্সে প্রোটিন থাকে, ভিরিয়য়েডসে প্রোটিন থাকে না, এতে শুধু প্রোটিন থাকে। শুধু প্রোটিন থাকে প্রিয়ন্স। উদ্ভিদ ও প্রাণীদের রোগ সৃষ্টি করে, শুধু উদ্ভিদের রোগ সৃষ্টি করে এবং শুধু প্রাণীদের রোগ সৃষ্টি করে। ইমার্জিং ভাইরাস, আদি পোষক থেকে পরে নতুন পোষক প্রজাতির রোগ সৃষ্টিকারী ভাইরাসকে বলা হয় ইমার্জিং ভাইরাস। এইচআইভি এর প্রকৃত পোষক বানর, যা পরে মানুষের ছড়িয়ে পড়ে। ফ্লু বা ইনফ্লুয়েঞ্জা ভাইরাসের প্রকৃত পোষক পাখি, যা পরবর্তীতে মানুষের রোগ সৃষ্টি করে। ইমার্জিং ভাইরাস এইচআইভি এবং ইনফ্লুয়েঞ্জা ভাইরাসের প্রকৃত পোষক। উদাহরণ: এইচআইভি, সার্চ, নিল ভাইরাস, ইবোলা, ইনফ্লুয়েঞ্জা, নোভেল করোনা ভাইরাস ইত্যাদি। নাইস টু নো। অ্যান্ডেমিক, যেই জুনোটিক ব্যাধি একটি সংকীর্ণ অঞ্চল বা জনসংখ্যায় পাওয়া যায়, যেমন মধ্যপ্রাচ্য, এমিয়ার্স কোভ। এপিডেমিক, যে জেনেটিক ব্যাধি একটি বিস্তীর্ণ অঞ্চল জুড়ে বিস্তৃত, যেমন পশ্চিম আফ্রিকার ইবোলা ভাইরাস ডিজিজ, ইভিডি। অর্থাৎ এন্ডেমিক মধ্যপ্রাচ্যের মার্স কোভ, এটি জেনেটিক ব্যাধি সংকীর্ণ অঞ্চল জুড়ে জনসংখ্যায় পাওয়া যায়। এপিডেমিক, একটি জেনেটিক ব্যাধি যা বেশ বিস্তীর্ণ অঞ্চল জুড়ে বিস্তৃত, যেমন পশ্চিম আফ্রিকার। সো এন্ডেমিক, এপিডেমিক, প্যান্ডেমিক। বিস্তীর্ণ অঞ্চল জুড়ে, যেমন ইবোলা ভাইরাস এবং প্যান্ডেমিক, একটি জেনেটিক ব্যাধি বিশ্ব অঞ্চল দখল করে থাকে, যেমন কোভিড-19। আর কোনটি ভাইরাসের গঠন আকৃতি? এটি দণ্ডাকৃতি, সোজা ও ফাঁপা ভাইরাস। দৈর্ঘ্য, এর দৈর্ঘ্য প্রস্থের প্রায় 17 গুণ। টিএমভি এর দৈর্ঘ্য 280 থেকে 300 ন্যানোমিটার এবং 15 থেকে 18 ন্যানোমিটার। দণ্ডাকৃতি, সোজা ও ফাঁপা ভাইরাস। আণবিক ওজন 37 মিলিয়ন ডাল্টন প্রতিটি প্রোটিন। সব সাব ইউনিটের আণবিক ওজন 17,000 ডাল্টন। আরএনএ এর আণবিক ওজন 2.4 মিলিয়ন ডাল্টন। তাই আণবিক ওজন 37 মিলিয়ন ডাল্টন। তাই আণবিক ওজন হলো 37 মিলিয়ন ডাল্টন। আর রাসায়নিক গঠন: টোবাকো মোজাইক ভাইরাসের বারগেভিরি গোত্রের ভাইরাস। ডিএনএ এর প্রোটিন দিয়ে টিএমভি গঠিত। ডিএনএ এর সূত্রক 6500টি নিউক্লিওটাইড দ্বারা গঠিত। ডিএনএ এর প্যাচের মধ্যে চোঙাকৃতি গহ্বরের ব্যাস 20 আর্মস্ট্রং। ওজন হিসেবে শতকরা 95 ভাগই প্রোটিন ও 5 ভাগ আরএনএ। 95 ভাগই প্রোটিন ও 5 ভাগ আরএনএ। টিএমভিতে 2130 থেকে 2200টি ক্যাপসিমিয়া থাকে। প্রতিটি ক্যাপসিমিয়ার 158টি অ্যামিনো অ্যাসিড থাকে। টিএমভি তাপসহনীয় ভাইরাস এবং 30 মিনিটে 50 ডিগ্রি 120 ডিগ্রি ফারেনহাইট তাপ সহ্য করতে পারে। তামাক, টমেটো, মরিচ, শসা, শিম। অনেক ফুলসহ 9টি গোত্রের প্রায় 225 প্রজাতির উদ্ভিদ টিএমভি ভাইরাস দ্বারা আক্রান্ত হয়। মাস্ট নো। টি2 ব্যাকটেরিওফাজ একটি সর্বাধিক পরিচিত ভাইরাস। এর দৈহিক গঠন ও ক্ষুদ্রাকৃতি ব্যাঙাচি শুক্রাণুর মতো। এদের দেহে দুটি প্রধান অংশ ভাগ করা যায় আবিষ্কারক। আর এটি হলো টি2 ভাইরাস। বিজ্ঞানী টি এর নামে টুয়ার্ট আবিষ্কার করেছিলেন বলে টি2। বিজ্ঞানী ডিফ্রেড টুয়ার্ট। নামকরণ: ডি হেনলি ফেলিক্স টি2 এর ভাইরাসের নামকরণ অভিহিত করেন। বিজ্ঞানী টি টুয়ার্ট আবিষ্কার করেছেন। নামকরণ: বিজ্ঞানী হেনলি ফেলিক্স। টি2কে ব্যাকটেরিওফাজ নামকরণ করেছেন। এটি একটি ষড়ভুজ আকৃতি প্রিজমের মতো। ডিএনএ 60,000 জোড়া নিউক্লিওটাইড দিয়ে গঠিত এবং 150টি জিন থাকে। ডিএনএ অণুর পেঁচানো অবস্থান থাকে। এর দ্বিসূত্রক এবং মোট ওজনের 50%। ডিএনএ অণুর পেঁচানো অবস্থা থাকে দ্বিসূত্রক। ক্যাপসোমিয়ার 2000টি। ল্যাজ ও মাথা সংযোগস্থলে একটি কলার থাকে। নিচের প্রান্তে একটি বেস প্লেট এবং চারপাশে কয়েকটি 6টি স্পাইক, 6টি স্পর্শক তন্তু থাকে। স্পাইক স্পর্শক তন্তু দ্বারা এর পোষক ব্যাকটেরিয়া আক্রমণ করে। লেজের ভিতরে ডিএনএ থাকে না। টি2 ফাজের লেজে লাইসোজাইম নামক এনজাইম থাকে। টি2 ফাজের লেজে লাইসোজাইম নামক এনজাইম থাকে। আর ভাইরাসের বংশবৃদ্ধি, সংখ্যা বৃদ্ধি। লাইটিক চক্র বা ভিরুলেট ধাপ। ধাপ সাংগঠনিক স্থান, এক নজরে সংযুক্তি, অনুপ্রবেশ, সংশ্লেষণ, বহুবিভাজন এবং বিদীর্ণকরণ টিটু ভাইরাসের হয়। প্রতি 30 থেকে 40 মিনিটে প্রায় 300 থেকে 100 ফাজের সৃষ্টি হয়। লাইটিক চক্র এতে 5 ধাপে 6টি ধাপে সম্পন্ন হয়। মানুষের 6টি ধাপে সম্পন্ন হয়। ইকোলাই লাইটিক চক্র ধাপ 1, সূচনা, সংযুক্তি, পৃষ্ঠ লগ্নিভবন এবং টিটু ভাইরাসের ব্যাকটেরিয়া আক্রমণ করে থাকে। ধাপ 2 ফাজ, ডিএনএ ভাইরাসের প্রবেশ, লাইসোজাইম এনজাইমের কার্যকারিতা, ব্যাকটেরিয়া কোষ প্রাচীর সৃষ্টি হয় এবং ভাইরাসের সম্পূর্ণ ক্যাপসিড ব্যাকটেরিয়া কোষের বাইরে থাকে এবং গোস্ট এবং ডোনাট বলে, যাকে গোস্ট এবং ডোনাট বলে। অর্থাৎ পেনিট্রেশন প্রথমেই হলো অ্যাটাচমেন্ট, এরপরেই হলো পেনিট্রেশন, এরপরে হলো সিনথেসিস বা রেপ্লিকেশন, সংশ্লেষণ ও প্রতিলিপন। এই ধাপে কোষের আরএনএ পলিমারেজ ব্যবহার করে আরএনএ তৈরি করা হয়। পরবর্তীতে ডিএনএ পলিমারেজ এনজাইম দ্বারা ব্যাকটেরিয়া নিউক্লিওটাইডকে ব্যবহার করে নতুন ভাইরাল ডিএনএ সংশ্লেষণ করে। ফাজের কমপক্ষে 50টি জিন সক্রিয় হয়ে ব্যাকটেরিয়া রাইবোজোম ভাইরাসকে ক্যাপসিড বা কোষ প্রোটিন সংশ্লেষণ করে, অর্থাৎ ভাইরাসের প্রোটিন সংশ্লেষণ পোষক কোষে রাইবোজোম সংগঠিত হয়। বিভিন্ন দেহাংশ একত্রিত হয়ে অ্যাসেম্বল বলে, এটি ধাপ 4 অ্যাসেম্বল, এবং ধাপ 5 নতুন ভাইরাস সংযুক্তি বিদীর্ণকরণ, একে লাইসিস বলে। সংগঠন স্থান, টিটু ভাইরাস সিরিজযুক্ত ব্যাকটেরিয় ফাজ, সংযুক্তি, অনুপ্রবেশ, সমন্বয়, প্রতিলিপন এবং লাইটিক চক্রের প্রবেশ। সংযুক্তি, অনুপ্রবেশ, সমন্বয়, প্রতিলিপন এবং লাইটিক চক্র প্রবেশ। প্রয়োজনীয় তথ্য, ব্যাকটেরিয়া এবং ফাজের সংযুক্তি ডিএনএকে বলা হয় প্রোফাজ। প্রোফাজি ব্যাকটেরিয়া সুপ্ত অবস্থা। নিউক্লিয়ক এনজাইমের ব্যাকটেরিয়াকে ডিএনএ কেটে দেয়, নিউক্লিয়ক এনজাইম ডিএনএ কেটে দেয়। ইন্টিগ্রাল এনজাইম ভাইরাসের ডিএনএকে ইকোলের সাথে সংযুক্ত করে, তাই ব্যাকটেরিয়া সংযুক্ত ডিএনএকে বলা হয় প্রোফাজ। প্রোফাজি ব্যাকটেরিয়া সুপ্ত অবস্থা। নিউক্লিয়ক এনজাইম ভাইরাসের ডিএনএ কেটে দেয়, নিউক্লিয়াস এনজাইম ব্যাকটেরিয়া ডিএনএ ইকোলেকে ডিএনএ সংযুক্ত করে, তাই সংযুক্তি, অনুপ্রবেশ, প্রতিলিপন এবং লাইটিক চক্রের প্রবেশ। লাইসোজেনিক, লাইটিক এবং লাইসোজেনিক। সংগঠন স্থান, ইকোলাই ব্যাকটেরিয়া আক্রমণকারী, ল্যাম্ডা ফাজ, P1 ভাইরাস এবং M3 ফাজ ভাইরাস। নোট, পোষক ব্যাকটেরিয়া আক্রমণ করার পরে যে সময় পর্যন্ত পূর্ণাঙ্গ অবাধ্য ভাইরাস সৃষ্টি না হয় সেই পর্যন্ত কালকেই ইক্লিপস কাল বলে। কাল পর্যন্ত পূর্ণাঙ্গ ভাইরাস সৃষ্টি না সেই পর্যন্ত কালকেই ইক্লিপস কাল বলে। ভাইরাসের ল্যাজ থেকে লাইসোজাইম এনজাইম নিঃসৃত হয়, যা ব্যাকটেরিয়ার মিউকোপেপটাইড স্তরকে দ্রবীভূত করে সূক্ষ্ম নালী সৃষ্টি করে, যাকে এই প্রক্রিয়াকে ড্রিলিং বলে। লাইসোজেনিক ভাইরাস কেবল ব্যাকটেরিয়া ফাজে সীমাবদ্ধ থাকে না, প্রাণী ও মানুষকে আক্রমণ করতে পারে। হার্পিস সিমপ্লেক্স এমনই একটি ভাইরাস, জেনেটিক লাইসোজেনিক ভাইরাস ব্যাকটেরিয়া ফাজকে আক্রমণ করে না। হার্পিস সিমপ্লেক্স এটি মানুষকে আক্রমণ করতে পারে। হার্পিস সিমপ্লেক্স সিমপ্লেক্স ভাইরাস এমন একটি ভাইরাস, ব্যাকটেরিয়া ফাজে সীমাবদ্ধ থাকে না। বিগত বছরের প্রশ্নসমূহ, ভাইরাসের বংশবৃদ্ধিতে পোষকের কোন অঙ্গের প্রোটিন তৈরি হয়? এটি হলো সি, রাইবোজোমে প্রোটিন তৈরি হয়। ভাইরাসের পোষকের কোন অঙ্গে প্রোটিন তৈরি হয়? রাইবোজোমে প্রোটিন তৈরি হয়। মাইটোকন্ড্রিয়াও না, কোষ সাধারণত নিউক্লিয়াসও না। ভাইরাসের বংশবৃদ্ধিতে পোষকের কোন অঙ্গে প্রোটিন তৈরি হয়? রাইবোজোমে। লাইটিক চক্র ও লাইসোজেনিক চক্রের মধ্যে পার্থক্য। লাইটিক চক্র, লাইসোজেনিক চক্র জিনগত, সমগ্র ভাইরাস গঠন করে আর ভাইরাল ডিএনএ অণুর প্রতিলিপি সৃষ্টি হয়, কিন্তু সম্পূর্ণ ভাইরাস সৃষ্টি হয় না। লাইসোজেনিক, লাইটিক। পূর্ণাঙ্গ ভাইরাসের ব্যাকটেরিয়া থেকে বিলীন হয়, পূর্ণাঙ্গ ভাইরাস রূপে ব্যাকটেরিয়া থেকে বিলীন হয় না। লাইটিক চক্র একবার সম্পূর্ণ অনেকগুলো ভাইরাস সৃষ্টি হয়। লাইসোজেনিক চক্র একবার সম্পূর্ণ হলে কেবলমাত্র 2টি জিনোমযুক্ত ভাইরাস সৃষ্টি হয়। ভাইরাসের সংখ্যা বৃদ্ধি, ভাইরাসের সংখ্যা বৃদ্ধি ভাইরাস দ্বারা নিয়ন্ত্রিত হয়। ভাইরাসের ডিএনএ সংখ্যা বৃদ্ধি পোষক ব্যাকটেরিয়া দ্বারা নিয়ন্ত্রিত হয়। ভাইরাসের সংখ্যা বৃদ্ধি ভাইরাস দ্বারা নিয়ন্ত্রিত হয়। ভাইরাসের ডিএনএ সংখ্যা বৃদ্ধি পোষক ব্যাকটেরিয়া দ্বারা নিয়ন্ত্রিত হয়। প্রোফাজ গঠিত হয় না, গঠিত হয়। আক্রমণের তীব্রতা তীব্র বা ভিরুলেন্ট। পোষক কোষের মৃত্যু ঘটে না, তাই আমৃত্যু, মৃদু অবা টেম্পারেট। T2, T4, T6 ব্যাকটেরিওফাজ ভাইরাস, ল্যাম্ডা, P1 ফাজ ভাইরাস এবং M3 ভাইরাস। ভাইরাসের অপকারিতা। এইডস, HIV, ডেঙ্গু, ফ্ল্যাভিভাইরাস, ডেঙ্গি ভাইরাস, চিকুনগুনিয়া ভাইরাস, ইনফ্লুয়েঞ্জা, সোয়াইন ফ্লু ভাইরাস, সার্স, নাপ ভাইরাস, জলাতঙ্ক, রেবিস ভাইরাস, গুটি বসন্ত, ভেরিওলা ভাইরাস, চিকেন পক্স, ভাইরাল নিউমোনিয়া, অ্যাডিনো ভাইরাস, কোষের লাইসিস, ইবোলা ভাইরাস, সর্দি জ্বর, রাইনো ভাইরাস, হাম, রবিওলা ভাইরাস, ইনফ্লুয়েঞ্জা, পোলিও ভাইরাস, ইনফ্লুয়েঞ্জা ভাইরাস, হার্পিস সিমপ্লেক্স, বাতজ্বর ভাইরাল এবং এনএনসেফালিটিস ভাইরাস। ভাইরাসজনিত রোগ, মানুষের রোগ, ভাইরাসজনিত ক্যান্সার, লিভার ক্যান্সার, বার্কিট, লিম্ফোমা, T-cell lymphoma blood cancer, T-cell lymphoma and anogenital cancer, ক্যাপিস সার্কোমা এবং লিভার সিরোসিস করে হেপাটাইটিস বি এবং সি, অ্যানোজেনিটাল ক্যান্সার করে প্যাপিলোমা ওয়ার্ড ভাইরাস, টি-সেল ভাইরাস, লিউকোমিয়া ভাইরাস, আর ক্যাপোসি সার্কোমা হার্পিস সিমপ্লেক্স ভাইরাস এবং লিভার ক্যান্সার হেপাটাইটিস বি ভাইরাস, হেপাটাইটিস সি ভাইরাস, লিভার ক্যান্সার বি ভাইরাস, হেপাটাইটিস সি ভাইরাস। হাঁস মুরগি ও পাখি বার্ড ফ্লু, অভিয়ান ভাইরাস, ইনফ্লুয়েঞ্জা, শুকর সোয়াইন ফ্লু ভাইরাস, ভেড়া ছাগল মহিষ মুখক্ষত ভাইরাস এবং কুকুর বিড়ালের রেবিস ভাইরাস জলাতঙ্ক, সোয়াইন ফ্লু ভাইরাস, চিকেন পক্স ভাইরাস, জোস্টার ভাইরাস, রেশম পোকার এনপিভি ভাইরাস, গবাদি পশুর ভ্যাকসিনিয়া এবং বানরের মাঙ্কি পক্স ভাইরাস। ধানের তামাকে রয়েছে, টমেটো রয়েছে বুস্টিয়ান ভাইরাস এবং শিমের মোজাইক, ধানের টুংরো রোগ, গোলালুর মোজাইক ভাইরাস, পেঁপের লিফ কার্ল কোলোসিস এবং আলুর লিফ লোড এবং কলার বাঞ্চি টপ। বুস্টিয়ান প্রাণীদের রোগ, গো বসন্ত ভ্যাকসিনিয়া ভাইরাস, ইঁদুরের টিউমার পোলিওমা ভাইরাস, পা ও মুখের রোগ ফুট অ্যান্ড মাউথ ভাইরাস, সোয়াইন ফ্লু H1T1 এবং H5T1 ভাইরাস, ভ্যাকসিনিয়া ভাইরাস, পোলিওমা ভাইরাস, ফুট অ্যান্ড মাউথ ভাইরাস, সোয়াইন ফ্লু, ইনফ্লুয়েঞ্জা ভাইরাস। তাই ভ্যাকসিনিয়া ভাইরাস, পোলিওমা ভাইরাস এবং ফুট অ্যান্ড মাউথ ভাইরাস, ইনফ্লুয়েঞ্জা T1 T2 ভাইরাস। অণুজীবের রোগ, উপকারী অণুজীব ধ্বংস, ইকোলাই ব্যাকটেরিয়া ধ্বংস করে T2 ফাজ ভাইরাস। নাইট্রোজেন সংবন্ধকারী নীলাভ সবুজ শৈবাল ধ্বংস করে সায়ানোফাজ ভাইরাস। মদ শিল্পে ব্যবহৃত ইস্টকে ধ্বংস করে জাইমোফাজ ভাইরাস। তাই ইকোলাই ব্যাকটেরিয়াকে ধ্বংস করে T2 ফাজ ভাইরাস, T2 সংবন্ধকারী নীলাভ সবুজ শৈবালকে ধ্বংস করে সায়ানোফাজ ভাইরাস। মদ শিল্পে ব্যবহৃত ইস্টকে ধ্বংস করে জাইমোফাজ ভাইরাস, নীলাভ সবুজ শৈবালকে ধ্বংস করে সায়ানোফাজ ভাইরাস। আর বায়োটেরিজম সম্প্রতিকালে কিছু ভাইরাস যেমন মারবার্গ ভাইরাস, ইবোলা ভাইরাস ইত্যাদি জীবাণু সন্ত্রাসে বা জীবাণু অস্ত্র হিসেবে ব্যবহার কথা শোনা যাচ্ছে। মারবার্গ ভাইরাস, ইবোলা ভাইরাস, সায়ানোফাজ ভাইরাস এবং জাইমোফাজ ভাইরাস এবং সায়ানোফেজ ভাইরাস। মৎস্য ব্যবহৃত ইস্টকে ধ্বংস করে, নীলাভ সবুজ শৈবালকে ধ্বংস করে। মনে রাখা সহজ, ভাইরাস জনিত কয়েকটি রোগ। হায় দেশে বসন্ত মাস এলে ভাইরাস ইনফ্লুয়েঞ্জা ডেঙ্গু জ্বরে পেল। হায় দেশে বসন্ত মাস এলো, ভাইকে ইনফ্লুয়েঞ্জা ও ডেঙ্গু জ্বরে পেল। তাই এটি হলো হাম, হারপিস, বসন্ত, মাম্পস, এইডস, ভাইরাল হেপাটাইটিস, ইনফ্লুয়েঞ্জা, ডেঙ্গু, জলাতঙ্ক, পোলিও। নেক্সট কয়েকটি গুরুত্বপূর্ণ ভাইরাস। এইচআইভি, ইমিউনোডেফিসিয়েন্সি ভাইরাস আবিষ্কারক। এইচআইভি এবং এইডস, অ্যাকোয়ার্ড ইমিউনোডেফিসিয়েন্সি ভাইরাস। গুরুত্বপূর্ণ ভাইরাস। এইচআইভি, হিউম্যান ইমিউনোডেফিসিয়েন্সি ভাইরাস আবিষ্কারক। এইচআইভি দিয়ে এইডস, অ্যাকোয়ার্ড ইমিউনোডেফিসিয়েন্সি ভাইরাস। 1981 সালে ফরাসি বিজ্ঞানী বার সিনৌসি এবং লুক মাতনেউয়া সর্বপ্রথম এইডস রোগ শনাক্ত করেন। 1981 সালে সর্বপ্রথম বার সেনৌসি এবং লুক মাতনেউয়া সর্বপ্রথম শনাক্ত করেন। এই ভাইরাস মানুষের সাথে রক্তকণিকা, আরবিসি বা ম্যাক্রোফেজ টি লিম্ফোসাইটকে আক্রমণ করে ধ্বংস করে। গঠন, এইচআইভি ভাইরাসের গঠন আকৃতিক গোলাকার, ক্যাপসিডের বাইরে পুরু ফসফোলিপিড বাইলেয়ার দিয়ে গঠিত একটি আবরণ আছে যাতে অনেক গ্লাইকোলিপিড বিদ্যমান। তো এইচআইভি ভাইরাসের বৈশিষ্ট্য হলো এখানে গ্লাইকোপ্রোটিন বিদ্যমান, ফসফোলিপিড আছে যেখানে গ্লাইকোলিপিড বিদ্যমান। এর আবরণের উপর GP120 এবং GP141 নামক দুই ধরনের গ্লাইকোপ্রোটিন কাঁটার মতো যুক্ত থাকে। GP120 এবং GP141 নামক ভাইরাসের এই ধরনের প্রোটিন যুক্ত থাকে। GP120 ভাইরাসকে পোষক কোষে সংযুক্ত হতে সাহায্য করে। GP120 অন্য গ্লুকোপ্রোটিন এবং GP141 সাথে রাসায়নিকভাবে যুক্ত থাকে। করোনা ভাইরাস পরিচিতি, এটি করোনা ভাইরাস রূপে আরএনএ ভাইরাস। করোনা ভিরিডি গোত্রের দ্বিস্তরী লিপিড আবরণে বেষ্টিত, দেখতে সৌর কিরণের মুকুটের মতন। দ্বিতীয় বৃহত্তম আরএনএ ভাইরাস, এটি 27 এবং 33 কিলোবাইট আকৃতির অখণ্ডিত গোলাকার একসূত্র। ইমার্জিং ভাইরাস বা লিপোপ্রোটিন। মোট 4 প্রকার করোনা ভাইরাস আবিষ্কৃত হয়েছে, যার মধ্যে 3 প্রকার ভাইরাস জুনোটিক। সার্স সিভিয়ার অ্যাকিউট রেসপিরেটরি সিনড্রোম করোনা ভাইরাস 2003 সালে বাদুড় থেকে সংক্রমিত হয়। মার্সকোভ মিডল ইস্ট রেসপিরেটরি সিনড্রোম 2012 সালে সৌদি আরবের বানর থেকে উটের মাধ্যমে সংক্রমিত হয়। সৌদি আরবে বানর থেকে বাদুড় থেকে উটের মাধ্যমে সংক্রমিত হয়। SARS-CoV-2 সিভিয়ার অ্যাকিউট রেসপিরেটরি সিনড্রোম করোনা ভাইরাস 2019 সালে বাদুড় বা সামুদ্রিক বা বন্য প্রাণী থেকে সংক্রমিত শনাক্তকরণ 2019 সালের 31 ডিসেম্বর চীনের উহান শহরে, আর 8 মার্চ 2020 সালে বাংলাদেশে প্রথম শনাক্তকরণ। কোভিড-19কে প্যান্ডেমিক অর্থাৎ বৈশ্বিক মহামারী হিসেবে 11 মার্চ 2020 সালে ঘোষণা করা হয়েছে। 11 মার্চ 2020 সালে ঘোষণা করা হয়েছে। শনাক্তকরণ 2019 সালের 31 ডিসেম্বর চীনের উহান শহরে। 2019 সালের 31 ডিসেম্বর চীনের উহান শহরে। 8 মার্চ 2020 সালে বাংলাদেশে প্রথম শনাক্ত হয় করোনা ভাইরাস এবং ডিজিজ করোনা ভাইরাস। শক্তিকাল 5 দিন, 2 থেকে 14 দিন কিংবা 5 দিন। দেহে প্রবেশে 5 থেকে 7 দিনের মধ্যে উপসর্গ দেখা দেয়। রোগের লক্ষণ: প্রাথমিক উপসর্গ শুকনো জ্বর, শুকনো কাশি, সর্দি, শ্বাসকষ্ট, শ্বসন স্বল্পতা, এছাড়াও সর্দি, স্বাদ ও গন্ধহীনতা, নাক ও ঘন তরল সর্দিযুক্ত বমি ভাব হওয়া, গলা ব্যথা, মাথা ব্যথা, দুর্বল বোধ, অবসাদ, পাতলা পায়খানা, এমনকি মাংসপেশিতে ব্যথা। শিশু, বয়স্ক এবং পূর্ব থেকে ডায়াবেটিস, কিডনি, হার্টের রোগী সহজে নিউমোনিয়া হতে দেখা যায়। গুরুতর পর্যায়ে নিউমোনিয়া, ব্রঙ্কাইটিস, বুকের অব্যাহত ব্যথা, চাপ, দিশেহারা ভাব, জেগে ওঠা বা জেগে থাকতে অক্ষমতা, ঠোঁট ও অংশুলের ত্বকে ফ্যাকাশে ধূসর ও নীল রঙের হয়ে যাওয়া, একাধিক অঙ্গের বৈকল্য, এমনকি মৃত্যু। রোগের লক্ষণ: প্রাথমিক পর্যায়ে প্রধান লক্ষণ: জ্বর, শুকনো কাশি, শ্বাসকষ্ট, শ্বসন ক্ষমতা, এছাড়াও সর্দি, স্বাদ, গন্ধহীনতা, নাক ওখানে পাতলা সর্দিযুক্ত বমি ভাব হওয়া, গলা ব্যথা, মাথা ব্যথা, দুর্বল বোধ, অবসাদ, পাতলা পায়খানা, এমনকি মাংসপেশিতে ব্যথা হওয়া। শিশু, প্রাপ্তবয়স্ক, পূর্ব থেকে ডায়াবেটিস, কিডনি, হার্টের রোগী সহজেই নিউমোনিয়া হতে দেখা যায়। গুরুতর পর্যায়ে নিউমোনিয়া, ব্রঙ্কাইটিস, বুকে অব্যাহত ব্যথা, চাপ, দিশেহারা ভাব, জেগে উঠতে বা জেগে থাকতে অক্ষমতা, ঠোঁট ও আঙুলের ত্বকে ফ্যাকাশে হওয়া, আঙুলের ত্বক ফ্যাকাশে ধূসর নীল হয়ে যাওয়া। আর কীভাবে ছড়ায়? এয়ার ড্রপলেট: সংক্রমক ব্যক্তি নাক ও মুখের মিউকাসক্ষরণ, চোখের পানি, হাঁচি, কাশি, বাতাস সংস্পর্শ ও নিষ্কাশনের মাধ্যমে রোগটি ছড়ায়। আক্রমণাঙ্গ শ্বসনতন্ত্র রোগ নির্ণয়: RT-CPR চেস্ট এক্স-রে, RT-CPR এবং চেস্ট এক্স-রে। চিকিৎসা উপসর্গ এমন অনুযায়ী: অক্সিজেন, প্যারাসিটামল, অ্যাভিগান, রেমডেসিভির, ইন্টারফেরন, আলফা-2B এবং রেভিপিরাভির। মুমূর্ষু রোগীর ক্ষেত্রে প্লাজমা থেরাপি, ভ্যাকসিন ও করোনা ভ্যাকচিন ও অ্যাভিফ্ল্যাভিন, ডেক্সমেথাসোন ইত্যাদি, কোভিড-19 বুস্টার ডোজ ইত্যাদি। রোগী ও সন্দেহজনক ব্যক্তি থেকে দূরে থাকা, জনসংগম এড়িয়ে চলা, সমফলে ঘরে থাকা, অপরিষ্কার হাতে নাক, মুখ, চোখে স্পর্শ না করা, কারোর সাথে বিশেষ করে আক্রান্ত ব্যক্তির সাথে হ্যান্ডশেক বা কোলাকুলি না করা, গণপরিবহন লিফট ব্যবহার না করা, পশুপাখির সংস্পর্শ এড়িয়ে চলা, বারবার শাওয়ার পানি থেকে 20 সেকেন্ড ধরে হাত ধোয়া, অন্য ব্যক্তিতে কমপক্ষে 3 ফুট দূরে থাকা, উন্নত মানের মাস্ক ব্যবহার করা। 40% পর্যন্ত সংক্রমণ কমাতে পারে। একজন ব্যক্তি রোগী থেকে 2-3 জন রোগী সংক্রমণ ঘটে। বর্ণনা: ইবোলা ভাইরাস। কঙ্গো নদীর ইবোলা ভাইরাসের অনুসারে এই ভাইরাসের নামকরণ করা হয়। ইবোলা ভাইরাসের আক্রমণ দেহকোষে লাইসিস ফেটে যায়। এই ভাইরাসের ফলে সৃষ্ট রোগ সাধারণত লক্ষণগুলি হলো তীব্র জ্বর, মাথা, পেশি ও শিশুতে ব্যথা, দেহের কোষ ফেটে যাওয়া এবং রক্তক্ষরণ একটি ছোঁয়াচে রোগ। সংস্পর্শনের মাধ্যমে নতুন ব্যক্তি আক্রান্ত হয় বা আক্রান্ত হওয়া 1 থেকে 2 দিনের মধ্যে রোগীতে লক্ষণ প্রকাশ পায়। নিপা ভাইরাস, প্যারাসিডিভাইরাস গোত্রের একটি RNA ভাইরাস, বাহক বাদুড়। সংক্রমণ মাধ্যম কাঁচা খেজুরের রস। নিপা ভাইরাস, এই আক্রমণে আক্রান্ত শ্বসন ব্যক্তি সার্স রোগীর মৃত্যু ঘটে। জিকা ভাইরাস একটি ভাইরাস, RNA ভাইরাস, এইডস ইজিপ্টি এবং এইডস অ্যাবোপিটাস। উগান্ডার জিকা ফরেস্টে বসবাসকারী রেসুস বানরের দেহে এই ভাইরাস প্রথম ধরা পড়ে। উগান্ডায় ভাইরাস অর্থাৎ জিকা, উগান্ডায় ভাষায় জিকা অর্থ ওভারগোন। এই ভাইরাসের আক্রমণে সামান্য জ্বর, জয়েন্টে ব্যথা, চোখ লাল হওয়া, মাংসপেশিতে ব্যথা, মাথা ব্যথা, দেহে ফুসকুড়ি ওঠে ইত্যাদি উপসর্গ দেখাতে গর্ভবতী মাকে আক্রমণ হলে নবজাতক মাইক্রোসেফালি হয়। এটি ছোঁয়াচে রোগ নয়। 2016 সালে মার্চ মাসে বাংলাদেশ চট্টগ্রাম জেলায় 67 বছর বয়সী এক মহিলার রক্তে জিকা ভাইরাস সংক্রমণ পাওয়া গিয়েছে। দক্ষিণ আমেরিকার দেশগুলোকে মহামারী আকারে ছড়িয়ে পড়েছে ভাইরাসটি। চিকন অর্থ মোচড়ানো, এটি RNA ভাইরাস, এইডস ইজিপ্টি এবং এইডস অ্যালবোপিক্টাস। ভাইরাসের প্রথম আবিষ্কৃত 1952 সালে আফ্রিকার তানজানিয়ায় বা বাংলাদেশে 2008 সালে রোগটি ধরা পড়ে। রোগের লক্ষণ: রোগ উপসর্গ লক্ষণ অবস্থা সংক্রমণ মশারা কমানোর 4 থেকে 7 দিনের মধ্যে হঠাৎ করে তীব্র জ্বর হয়, সেই সাথে শরীরে অস্বস্তি, ব্যথা অনুভূত হয়, উচ্চতর জ্বর, জয়েন্টে ব্যথা, শরীরে র্যাশ ওঠা, মাথা ব্যথা, বমিভাব, দুর্বলতা ইত্যাদি। জ্বর কমে গেলেও ব্যথা 3 থেকে 4 মাস থাকতে পারে। বার্ড ফ্লু, এভিয়ান ইনফ্লুয়েঞ্জা, C5H1, হেমাগ্লুটিনিন টাইপ 1 এবং নিউরামিডিস টাইপ 1 ভাইরাসের আক্রমণে হাঁস মুরগিতে বার্ড ফ্লু নামক মারাত্মক রোগ সৃষ্টি হয় এবং পোলট্রি শিল্পকে ধ্বংস করে। সোয়াইন ফ্লু ইনফ্লুয়েঞ্জা দ্বারা সৃষ্টি হয়। সোয়াইন ফ্লু ভাইরাসের সাবটাইপ H5N1 এবং H1N1 গ্লুটামিন টাইপ 1 এবং নিউরোমিথিন টাইপ 1 এর কারণে ব্লাড ফ্লু হয়ে থাকে। আক্রান্ত ব্যক্তি গলা, মাংসপেশিতে ব্যথা এবং পেশিতে খিঁচুনি, জ্বর 100 ডিগ্রি বলতে বেশি, কফ ও স্লেমা বের হয় এবং ঠান্ডা জ্বর সহ থাকে 2 থেকে 3 দিন। কারো 10 দিন শ্বাসকষ্ট, অনিদ্রা, সর্দি কাশি লেগে থাকা ইত্যাদি মানুষ জ্বর, শুকরের রোগ আক্রান্ত হয়। নিচের কোন ভাইরাসের উপকারী কাজ? এটি হলো ফুলের পাপড়িতে ছাপ দেওয়া, খরগোশে প্রজনন বৃদ্ধি করা, সমুদ্র অনুসংস করা, শুধুমাত্র জলবৃষ্টিতে থাকা, এগুলো নয়। কোন উদ্ভিদ দেহে রোগ সৃষ্টিকারী ভাইরাস? এটি হলো টুমরা ভাইরাস, উদ্ভিদ দেহে রোগ সৃষ্টিকারী ভাইরাস। নিচের কোন রোগটি ভাইরাস দ্বারা হয়? এটি হলো পোলিও ভাইরাস দ্বারা হয়। জিকা ভাইরাসের বাহক কোনটি? এটি হলো এইডস মশকি। এইডস মশকি জিকা ভাইরাসের বাহক। তাই নিচের কোনটি ভাইরাসের উপকারী কাজ? এটি হলো ফুলের পাপড়িতে ছাপ দেওয়া। কোনটি উদ্ভিদ দেহে রোগ সৃষ্টিকারী ভাইরাস? এটি হলো টুমরা ভাইরাস, উদ্ভিদ দেহে রোগ সৃষ্টিকারী ভাইরাস। ইয়েলো ফিভারও না, ফ্লাই ভাইরাসও না। নিজের কোন রোগটি ভাইরাস দ্বারা আক্রান্ত হয়? ডিপথেরিয়া, কলেরা, টাইফয়েড। এটি হলো পোলিও ভাইরাস দ্বারা হয়, এটি হলো পোলিও ভাইরাস দ্বারা হয়। জিকা ভাইরাসের বাহক কোনটি? এইডস মশকি। জিকা ভাইরাসের বাহক হলো এডিস মশকি। সোয়াইন ফ্লু রোগের জন্য দায়ী ভাইরাস কোনটি? এটি হলো H1N1। টুমরা ভাইরাস কোন গাছকে আক্রমণ করে? এটি হলো ধান গাছকে আক্রমণ করে। এইডস নির্মূল কোন ভাইরাস দিয়ে সংক্রমিত হয়? এটি হলো HIV দ্বারা সংক্রমিত হয়। Nutrition and vitamin. Nutrition definition. Nutrition is chemical constitute of food necessary to sustain growth and hormonal functions of body. Types of nutrients based on daily requirement. Macronutrients, major nutrients that body needs relatively a large amount. Some of protein provide fuel for energy. Micronutrients, nutrients that body need in much smaller amount. So nutrients is the chemical constitute of food necessary to sustain growth and function of the body. Based on dispensability, essential nutrients and non-essential nutrients. And then we will find food and its definition. Food is ingestible substance composed of nutrients that sustain hunger and can be utilized in the body to support growth and maintenance. Types of food. Arm. The arm is the part of the upper limb between the shoulder and the elbow. The bone of the upper arm, the humerus, articulates above the scapula to form the shoulder joint and below the radius and ulna. From the elbow joint, the humerus is almost entirely covered by muscles. The primary neurovascular bundle of arm is located on the medial side of the arm, hence protected by limb, which it serves. It consists of brachial artery with the venae communicates, basalic vein and medial nerve. Since the arm is termed brachium in Latin, most of its structures are named accordingly. For example, biceps brachii, coracobrachialis, triceps brachii, and brachial vessels, etc. Since the arm is termed brachium in Latin, most of the structures are named accordingly. The following bony landmarks. The greater tubercle of the humerus can be felt just below the lateral of the apicorn, deep to the deltoid, with the arm lying by the side of the trunk. It forms the most lateral bony point of the shoulder region. Median epicondyle of the humerus. It is the prominent bony projection felt on the median side of the elbow. The projection is best seen and felt in the mid-reflex elbow. Lateral epicondyle of the humerus. It can be felt in the upper part of the depression on the posterior lateral aspect of the humerus extended below. Medial and lateral supracondylar ridges. This can be felt on the lower 1/4 of the arm as the superior continue the medial lateral epicondyle respectively. Deltoid muscles. It forms the rounded counter of the shoulder, which becomes prominent on the abduct of the arm. It covers the upper half of the humerus anteriorly, laterally, and posteriorly, and its supex is attached to the lateral side of the middle of the humerus on the deltoid tuberosity. It forms the rounded contour of the arm. It covers the upper half of the humerus anteriorly, laterally, and posteriorly. Its apex is attached to the lateral side of the middle of the humerus on deltoid tuberosity. Biceps muscle. It forms a conspicuous bulge on the front of the arm, which becomes prominent on flexing of the elbow. Its tendon can be felt on form of the elbow. Brachial artery flexations. These can be felt in front of the elbow, just medial to the tendon of the biceps muscle. Can be felt on the elbow, on the just on the elbow biceps. Ulnar nerve. It can be rolled by the medial finger in the groove behind the medial epicondyle of the humerus. Superficial veins in the front of the elbow. Cephalic, basalic, and medial cubital veins. Cephalic, basalic, and medial cubital veins. These become visible when they are distended by applying tight pressure around the arm and flexing and extending the elbow within a few times with clenched fist. Head of the radius. It can be felt on the depression on the posterior aspect of the elbow, just distal to the lateral epicondyle. The rotation of the hand at the radius can be felt by supinating and pronating the forearm. Olecranon process of ulna, proximal part of the ulna. It is readily palpable on the back elbow between the medial and the lateral epicondyles. Compartment of the arm. The deep fossa encloses the arm like a sleeve. The two intermuscular septa on the medial side and on the lateral side extends inward, form the superficial sleeves, and get attached to the medial and lateral supracondylar regions of the humerus. Respectively, these septa and the fascia sleeves divide into acromion and posterior compartments. Each compartment has its own muscle, nerve, and artery. Note 12. Some structures, however, pierce the intermuscular septa to shift from a compartment of another. Namely, the ulnar nerve, the superior ulnar collateral artery, pierce the medial intermuscular septum to enter into the posterior compartment. The medial nerve and the radial collateral artery pierce the lateral intermuscular septum to enter the anterior compartment. Anterior compartment of the arm. The contents of the anterior compartment of the arm are biceps brachii, brachialis, coracobrachialis, neuromuscular nerve, brachial artery, and basalic vein. In addition to the above structures, the following large nerves also pass through the anterior compartment of the arm: medial nerve, ulnar nerve, radial nerve, biceps brachii. The biceps brachii muscle arises from the scapula on two heads, long and short. Then there is the insertion, relation, nerve supply, action, and clinical testing of biceps brachii. Then there is coracobrachialis, origin, insertion, nerve supply, action. And then there is brachialis, origin, insertion, nerve supply, action. Then there is musculocutaneous nerve and branches and distributions. Then there is the brachial artery, origin and course. Brachial artery, and there are the branches of the brachial artery. And then the clinical correlation of brachial artery. And then there is the anterior anastomosis around the elbow. Then there is the median nerve, ulnar nerve, and radial nerve, and all of their branches. And there is the cubital fossa and boundaries and contents. And then there is the posterior compartment of the arm, muscles, nerves, and artery. Then there is the triceps brachii, origin, insertion, nerve supply, and action. Then there is the radial nerve, profunda brachii and branches. The median nerve, nerves of other than the musculocutaneous nerve passing through the arm. Origin, course, and termination. The median nerve arises from the lateral and the medial course of the brachial plexus. Medial and lateral course of the brachial plexus in the axilla and descend down on the front of the arm. It is closely related to the brachial artery throughout its courses in arm. Initially, it lies lateral to the brachial artery, but across over it medially to the mid-arm. As a result, the cubital fossa lies medial to the brachial artery. It is superficially located except the elbow where it is crossed by the bicipital aponeurosis. Note 12. The relationship of the medial nerve with the brachial artery in the arm is as follows. The upper part, it is lateral to the artery. The middle part, it crosses in front of the artery from the lateral to the medial side, medial part. The lower part, it is the medial to the artery and up to the elbow in the lower part. Branches. In the arm, the medial nerve gives rise to the following branches. Nerve to the pronator teres just above the elbow, vasomotor nerve to the brachial artery, and articular branch to the elbow joint just below the elbow. Ulnar nerve. The ulnar nerve. The ulnar nerve arises from the medial cord of the brachial plexus of the axilla. It then runs downward the medial side of the arm, medial to the brachial artery, up to the insertion of the brachialis. Here it pierces the medial intermuscular septum along the superior ulnar collateral artery to enter the posterior compartment of the arm. At the elbow, the ulnar nerve passes behind the medial epicondyle of the humerus where it can be easily palpated. The ulnar nerve does not give any branch to the arm. In clinical funny bone, the ulnar, it is neither funny nor a bone, but named given part of the ulnar nerve behind the medial epicondyle of the humerus. This is because the medial epicondyle of the humerus not spun against the head of the object. It is felt a tingling and numbing along the medial side of the hand. Note well, funny bone is a nickname to ulnar nerve behind medial epicondyle of the humerus because of funny feeling it gets after medial epicondyle hits the hard object. Radial nerve of the arm. The radial nerve arises from the posterior cord of the brachial plexus of the axilla. In the arm, the nerve first lies posterior to the brachial artery. Then it winds around the back of the arm and enters the radial spiral groove of the humerus between the lateral and the medial sides of the abdomen by profunda brachial artery. At the lower end of the spinal groove, that pierces the lateral intermuscular septum and enters the interior compartment of the arm. Here it continues out downward in front of the elbow, cubital fossa between the brachialis and the coracobrachialis muscles. Then at a variable point it divides into two terminal brachioles. The sensory branch, the superficial radial nerve, and the sensory branch and motor branch. The deep radial nerve lateral disappears into substance and supinator muscle just below the elbow, passes between the superficial and deep layers of the supinator, enter the posterior compartment of the forearm, and now called as the posterior interosseous nerve. Here it runs downward on the posterior aspect of the interosseous membrane up to the wrist, where it terminates by forming a pseudoganglion. Branches. Radial nerve. The axilla nerves to the long medial head of the triceps, posterior cutaneous nerve of the arm, and the spinal groove. Nerves to the lateral and the medial head of the triceps, nerves to the anconus, lower lateral cutaneous nerve of the arm, posterior cutaneous nerve of the forearm. The anterior compartments of the arm, nerves and brachialis, brachioradialis, and extensor carpi radialis longus. Anterior branch of the elbow, deep radial nerve and superficial radial nerve. The radial nerve is commonly injured in the radial groove due to the various reasons. For example, fracture of the shaft of the humerus. For detailed chapter C. It leads to wrist drop. The radial nerve commonly injured radial groove. Wrist drop. Sensory loss of the narrow strip of the skin at the back of the forearm. Tingling and burning sensation on the back of the hand, including thumb, index finger, and middle finger. Cuboidal fossa. The cuboidal fossa is a triangular hollow in front of the elbow. Its base is horizontal and directed upward. Cuboidal fossa, where the apex is directed downward. It corresponds homologous to the lower half of the popliteal fossa, the lower limb. popliteal fossa, cubital fossa, popliteal fossa. Borders and laterally, median border of the brachialis muscle laterally. Medially, lateral border of the pronator teres muscle medially. Medially to the laterally, median border of the brachialis muscle and the lateral border of the pronator teres muscle. And imagine a horizontal line joining front of the two epicondyles of the humerus. Apex meets the point of the lateral and the medial boundaries. Here the brachialis overlaps the pronator teres. That is formed by the muscles brachialis in the upper part and supinator in the lower part. It is formed from the deep fascia of the forearm, reinforced on the median side of the bicipital aponeurosis. The superficial of the deep fossa lies. Superficial fossa is skin node. The superficial fossa contains medial cubital vein connecting the cephalic and basilic veins median to the lateral cutaneous nerve of the forearm. The lateral cutaneous nerve lies along the medial group of the cephalic vein, and the medial cutaneous nerve along the long cephalic vein contains. The cubital fossa is actually a narrow space and therefore contains displayed only if the elbow is extended and its margins are pulled apart. The contents of the cubital fossa from the medial to lateral sides are as follows. Median nerve. It leaves the fossa by passing between the two heads of the pronator teres. Brachial artery. It terminates the fossa of the level of the neck and radius is radial. So median nerve and then brachial artery. The brachial artery it terminates in the fossa and level of the neck and radius by dividing into the radial and the ulnar arteries. The radial artery is superficial and leaves the fossa at the apex. The ulnar artery is deep and passes deep to the pronator teres, bicipital tendon. It passes backward laterally attends radial artery. So the median nerve and the brachial artery and the biceps brachii and the superficial branch. Median artery, brachial artery, biceps brachii, tendon of the biceps brachii and the superficial branch of the radial nerve. Radial nerve. The radial nerve, it lies at the gap of the brachialis medially and brachyradialis laterally. It lies between the brachialis medially and brachyradialis laterally. It is the level of lateral epicondyle. It divides into two terminal branches. A superficial branch called the superficial radial nerve and a deep branch called the deep radial nerve. The latter disappears in the substance of the supinator muscle. The superficial radial nerve passes downward in front of the forearm, entered the cover the brachioradialis. The contents of the cubital fossa form the middle of the lateral side of the bimnemonic MBBS. Median nerve, brachial artery, biceps tendon, superficial radial nerve. Median nerve, MBBS, brachial artery and biceps tendon, superficial medial nerve. Clinical significance of the cubital fossa. The knowledge of anatomy of the cubital fossa is clinically important for the following reasons. Venipuncture of the cubital vein. The venipuncture is a clinical method of pierce vein by needle, either intravenous injection or remove of blood during a laboratory test. The most common site for venipuncture is cubital fossa, as it houses the three special veins, cephalic, medial and cubital veins. Out of this, median cubital vein is most preferred. The median cubital vein is the vein of choice. Median cubital vein. It is because it is most prominent vein in the body, tends to remain stationary for being connected to the deep vein of the prefatory vein, does not usually collapse during shock, lies more superficially and not accompanied by a nerve, hence skin over it is less sensitive, Hence, when a puncture is less painful, overlaying bicipital aponeurosis acts as a hard platform. When the elbow is extended, the pronator underlying median nerve and the brachial artery from injury. Brachial artery is the region easily located middle to the biceps tendon and occultated universally for hearing Korokov sounds of the recording of blood pressure manually. The Korokov sounds, the brachial artery. The to deal with fractures of the elbow, supracondylar fracture of the humerus, the contents of the cubital fossa, especially the brachial artery and the medial nerve, are vulnerable. In supracondylar fracture of the humerus, the contents of the cubital fossa, particularly median nerve and brachial artery, are likely to get injured. The contents of the cubital fossa, particularly median nerve and brachial artery, are likely to get injured. In supracondylar fracture of the humerus, the contents of the brachial fossa, particularly medial nerve and brachial artery, are likely to get injured. In supracondylar fracture of the humerus. Chapter 11. Hand. The hand is the distal part of the segment of the upper limb. It is a complex and highly evolved anatomic structure that provides primary touch and input on the brain and enables the humans to perform complex fine motor tasks by the way of free movements and power of grip, precision grip, handling, piercing, pinching, etc. The hand is a man's greatest physical asset. It has enabled him to use various tools that his brain has invented. Therefore, a better understanding of this structure and this function is essential. Everything that the doctors do to the hand should be aimed at restoring and maintaining the function. The movements of the hand occur primarily at the wrist joint or radiocarpal joint formed by the articulation of the radius and the first row of carpal bones. Scaphoid, lunate, right ventral. The hand consists of 4 functional units, namely carpus, thumb, index finger, and a unit of middle ring and little fingers. The carpal first provides a stabilizing platform for the 3 mobile units. The hand contains carpal bones, metacarpal bones, and phalanges. Normally, the term wrist joint to carpal region consisting of 8 carpal bones and lie between the forearm of the hand but in general usage the wrist refers to the distal end of the forearm just proximal to the distal end of the radius of the ulna around the wrist where the wristwatch is worn. Palmar aspect of the hand, surface landmarks, tubercle of the scaphoid. It can be felt on the base of the ulnar eminence just lateral to the tendon of the flexor carpi radialis. It is located deep to the carpal part of the distal transverse crease of wrist, tubercle crest of trapezium. It can be felt deep palpation, lateral and a tubercle of a scaphoid and pisiform bone. It can be felt at the base of hypothecal eminence medially. It lies deep to the medial end of the distal transverse crease of wrist, hook of hammer. It can be felt at the fingers breadth distal to the pisiform bone. Skin of the palm. The skin of the palm presents the following characteristic features. It is thick to withstand wear and tear during work. It is richly supplied by sweat glands but contains no hair and sebaceous glands. It is immobile as it is firmly attached to the underlying palmar aponeurosis. It presents several longitudinal and transverse creases where the skin firmly binds to the deep fossa. To improve the grip, the skin of the palm enriches and far forward and devoid of greasy sebaceous glands. Flexion creases of the wrist, palm, and fingers. Flexion creases of the wrist. The power aspect of the wrist presents two transverse flexion creases: proximal transverse wrist crease and distal transverse wrist crease. So arch, whorl, loop, and composite. Arch, whorl, loop, and composite. Superficial fascia of the palm. Superficial fascia of the palm is made up of the dense fibrous bands that anchor the skin to the deep fascia of the palm. The superficial fascia of the palm represents two important features. It contains a subcutaneous muscle, the palmaris brevis, on the ulnar side of the palm, which probably helps to improve grip. The thickness to form the superficial transverse metacarpal ligament that stretches across the root of the finger over the distal nerves and muscles. Palmaris brevis muscle. It is the subcutaneous muscle and especially fascia of the medial part of the palm. Morphologically, it represents the panniculus carnosus origin from the flexor reticulum and palmar aponeurosis. Insertion into the skin along the medial border of the hand. Nerve supply. Superficial branches of the ulnar nerve. Action. When an object is grabbed tightly in hand, it causes the weakening of the mid palmar skin and helps to prevent the ulnar displacement of the hypothelial eminence. Deep fascia of the palm. The deep fascia of the palm aspect and the hip is specialized to perform structures: flexor reticulum, palmar aponeurosis, fibrous flexor sheath of digits. So palmar aponeurosis, flexor reticulum, and fibrous sheaths of digits. Flexor reticulum. It is a strong fibrous band that formed by the thickening of the deep fascia in front of the carpus res. It lodges the anterior concavity of the carpus and converts it into an osseofibrous tunnel called the carpal tunnel to pass inflow the tunnel of digits. The reticular shape trolley of the size of the postage stamp. It has two surfaces and four borders. Attachment medially. It is attached to the pisiform hook of the hamate, laterally attached to the tubercle, the staped process of the trapezium. Note 12. On either side, the flexor reticulum gives a slip of superficial slip. On the medial side, a volar capsular ligament is attached to the pisiform bone. The ulnar nerve vessels pass deep to the slip. A deep slip on the lateral side of the attachment to the median tip of the groove of the trapezium, covering the into the osseofibrous tunnel for passage of the tunnel of the FCR. Relations. Superficial structures passes superficial to the flexor reticulum. From the medial to the lateral side, there are ulnar nerve, ulnar artery, and then palmar cutaneous branch of the ulnar nerve, tendon of palmaris longus, palmar-cutaneous branch of the medial nerve, and superficial branch of the medial artery. Structures passing deep to the reticulum through the tunnel are as follows: tendon flexor of digitorum superficialis, digitorum profundus, and tendon flexor pollicis longus. Median nerve. Note well. The compression of the median nerve in carpal tunnel is called the carpal tunnel syndrome. For details, see page 174. The tendons of fingers are enclosed in a synovial sheath called ulnar bursa. The tendon of flexor pollicis longus is on the radial side of the enclosed in a separate synovial sheath called the radial bursa. The tendon of FCR passes through the separate canal in the lateral part of the flexor reticulum. Palmar aponeurosis. The deep fascia of the palm is thin over the actia and hypothenar eminence, and thick on the central part of the palm where it forms the palmar aponeurosis. The power aponeurosis is a strong, well-defined central part of the deep fossa of the covers the long flexor tendon and superficial power arch. All flexor it is triangular in shape. There are mainly of longitudinal fibers and a few transverse fibers inserting the former. Its apex is directed proximally towards the wrist and its base is directed towards the root of the fingers. Features: the palmar aponeurosis presents the following features: apex, base, medial border, lateral border. Apex. It is the narrow proximal end of the palmar aponeurosis which blends with the flexor reticulum. Its superficial fibers are continuous with the tendon palmaris longus. Base. It is the broad distal end of the palmar aponeurosis just proximal to the head of the metacarpals. The base divides into four longitudinal strips and each of the medial four digits. Each strip further divides into two strips that runs into the fibrous sheath of the corresponding digits. The digits of the nerve and the vessels tendrils of the emerge through the interval between the four longitudinal slips. Medial border. The medial border of the aponeurosis contains with the deep fossa covering the hypothenar muscles and gives origin to the palmaris brevis. The median palmar septum extends inward to edge the fifth metacarpal. The lateral edge of the aponeurosis is continuous with the deep fossa covering the thinner muscles. The lateral palmar septum extends inward from this edge to the first metacarpal. So features: medial and lateral. The intermediate palmar septum extends inward to near the oblique and third metacarpal. Functions: helps to improve the grip of the hand by fixing the skin, protects the underlying tendon, nerves, and vessels. Morphologically, palmar aponeurosis presents the degenerated tendon of the palmaris longus muscle. Palmaris longus. So, palmaris longus muscle. And now intrinsic muscles of the hand. Intrinsic muscles of the hand. Intrinsic small muscles of the hand. There are short muscles which origin an insertion on the hand within the territory of the hand. They are responsible for skilled movements of the hand, also help in the achieving the proper grip. There are 20 intrinsic muscles of the hand. They have a small motor enhancements. They can act with precision to carry out skilled movements. The intrinsic muscles of the hand are arranged in the following groups: thinner muscles, abductor muscles, hypothinnar muscles, ventricles, and interossei. Thinner muscles. They are three in number, namely abductor pollicis brevis, flexor pollicis brevis, and opponents. Abductor pollicis brevis, flexor pollicis brevis, and opponents. Opponents. Opponents pollicis. Relationship: abductor pollicis brevis is lie laterally. Flexor pollicis brevis lies medially. And opponent's pollicis lies deep between the two muscles. Features: they form the thinner eminence of the palm of the hand on the radial side of the thumb and base of the first digit. They are chief responsible for the opposition of the thumb. All of them are supplied by the recurrent branch of the medial nerve. C6 and T1. Note 12. The actions of the thinner muscles are indicated by their names of some events. However, they all are involved in opposition, providing pinch-like grip when the thumb is in an index finger. Hypothinnar muscles. They are also three in number, namely abductor digitis minimi, flexor digitis minimi, and opponens digitis minimi. And relationship abductor digitis minimi. Digitis minimi is lies medially, flexor digitis minimi lies laterally, flexor digitis minimi lies laterally, and opponent's hand above two muscles features. They are formed by the hypothenar eminence of the palm of the hand. Muscular bulge of the ulnar side of the palm acts as a base of the first digit. All of them are supplied by the deep branch of the ulnar nerve. The origin, insertion, and action of the thenar and hypothenar muscles are presented in table 7.1. Note well, the flexor pollicis brevis has dual nerve supply, superficial head by the medial nerve and deep head by the deep branch of the ulnar nerve. Flexor pollicis brevis. Tendon of the insertion of the flexor digiti minimi along with the abductor digiti minimi and the median side of the base of the first phalanges contain a sesamoid bone. And the base of the first phalange and the digiti minimi. Tendons of the insertion of the flexor digiti minimi along with the abductor digits of minimi of the medial side bone and adductor pollicis muscle. Origin. Oblique band arises from the anterior aspect of the capitate bone and base of the second and third metacarpal bones. So, abductor pollicis origin from the anterior aspect of the capitate bone, and base of the second and base of the second and third metacarpal bones. So capitate bone and second and third metacarpal bones forming a crescent shape. Transverse head arises from the ridge of the distal two hands of the anterior surface of the shaft of the third metacarpal. Insertion into the medial side of the base of the proximal phalanges of the thumb. So it starts from the capitate and 3 or 4 metacarpal, and then on the transverse head of the ridge of the distal two, and insertion onto the medial side of the base of the proximal phalange of the thumb. Proximal phalange of the thumb. Nerve supply by the C4 and T1, C8 and T1 actions. Abductor of the thumb to provide power to the grip. Adduction of the thumb. Note well the tendons of insertion of the adductor pollicis on the medial side of the base and the proximal phalanges of the thumb contain sesamoid bone. The adductor pollicis sesamoid bone. The deep palmar arch and the deep branch of the ulnar nerve passes between the two heads of the adductor pollicis. Short note: endothelium. The endothelium is a special type of epithelium that acts as a semi-permeable barrier between the internal compartments of the blood plasma and the intestinal tissue fluid. Endothelial cells, especially those of arteries, contain unique, very small, elongated vesicles, walls, wearable palate bodies, which contain selectin and von Willebrand factor involved in blood coagulation. So endothelium are the type of epithelium that acts as semi-permeable barrier between the two internal compartments, the blood plasma and the interstitial fluid. Endothelial cells, especially those of arteries, contain unique, very small, elongated vesicles. Functions: endothelium is highly differentiated to mediate and actively monitor the bidirectional exchange of small molecules and restrict the transport of some molecules. Besides the role of exchange between blood and tissue, endothelial cells perform several other functions, including production of vasoactive factors that affect the vascular tone, such as nitric oxide, other endothelin and vasoconstriction agents, and conversion of circulating angiotensin 1 to angiotensin 2. So endothelium also works in angiotensin 1, converting angiotensin to angiotensin 2. Capillaries are more dilated and tortuous than capillaries. They are found in liver, spleen, bone marrow, hypophysis cerebri, suprarenal glands, and other places. From bone marrow, hypophysis cerebri. Each sinusoid is lined by certain capillary cells. They permit considerable exchange of metabolites in their walls. Difference between sinusoids and capillaries. Sinusoid capillaries. Large may be 30 to 40 micrometers in diameter, small about 7 to 8 micrometers in diameter. Lumen irregular tortuous are capillary irregular. Discontinuous may be fenestrated, continuous and fenestrated. Capillary. Phagocytosis present, absent. Incomplete, complete. Wall thinner, thicker. Connection always makes connection between some types of vessels, makes connection between arterioles and venules. Some type of vessel, arterioles, venules. Velocity of flow very slow and rapid. Velocity of flow very slow. Sinusoid are capillary rapid. Large about 100 nanometer in diameter, small about 20 to 60 nanometer. Liver, spleen, bone marrow, hypophysis cerebri, cerebral glands, and other. All of the body. Name the factor responsible for venous return. Factor responsible for venous return are pumping action of the left ventricle, amount of blood permitted by the arterioles in the capillary bed, the condition of the right atrium and ventricle, massage action of the skeletal, massage action of the massage of the skeletal, negative intrathoracic pressure that situates on the diaphragm near venous valves, transmits pulsation of the arteries, and gravity. Forearm. The specific learning objective. After studying this chapter, the student should be able to describe the important muscle groups of the anterior aspect of the forearm with attachments, nerve supply, and actions. Describe the origin, insertion, nerve supply actions. Special features of flexor digitorum profundus. Identify and describe the flexor reticulum with its attachments. Describe the compartments of deep extensor reticulum. Write short notes on radial artery on the forearm, ulnar artery and forearm, posterior interosseous nerve and vessels, and dorsal pulse. Enumerate the specific muscles on the front of the forearm. The structures lying in the wrist, structures on the suicidal cut on the radial side of the wrist, and deep muscles on the back of the forearm. Identify that describe origin, course and relations, branches, termination of the important nerves and vessels of the forearm. Describe extensor and expansor information. Identify and describe the important muscle groups of dorsal forearm with attachments and nerve supply. The forearm extends from the elbow to the wrist and has two bones that are tied together by a thin fibrous band known as interosseous membrane. The head of the radius is the proximal end of the forearm. There is a proximal end of the forearm, whereas the head of the ulna is the radius end of the forearm. The radius and the ulna are both their ends articulate with each other in form of the superior and inferior radioulnar joints. All important movements of the supinator and pronator of the forearm occur at these joints. The upper ends of the radius and the ulna articulate with the lower ends of the humerus to form the elbow joint. The lower end of the radius articulates with the carpal bone wrist joints. The main purpose of the movements of the forearm at the elbow and the radioulnar joint is to place the hand at the described place to execute the force of the shoulder and the arm into a desired action. The muscle nerves and the vessels are present both in front and back of the forearm. Surface landmarks on the front of the forearm. Medial and lateral epicondyle of the humerus can be easily felt at the elbow. The medial epicondyle is more prominent than the lateral epicondyle. Medial lateral epicondyle. Medial epicondyle of the forearm. The medial epicondyle is more prominent than the lateral epicondyle. The ulnar nerves can be rolled behind the medial epicondyle. The ulnar nerves can be rolled behind the medial epicondyle. Tendons of the biceps brachii can easily be palpated in front of the elbow. The pulsations of the brachial artery can be felt just medial to the tendon. Head of the radius and olecranon process of the ulna have been described on page 91. Head of the ulna forms a rounded elevation on the surface on the medial side of the anterior aspect of the wrist. Pisiform bone can be felt on the median side of the base of hypothelial eminence, pisiform bone, whereas the tendon of flexor carpi ulnaris muscle ends. On the back of the forearm, olecranon process of the ulna is the most prominent bone. Olecranon process of the ulna is the elevation of the back of the elbow in the middle. In an extended elbow, the tip of the olecranon process lies on a horizontal line with two epicondyle of the humerus. And in flex elbow, the 3 points join to form an equilateral triangle. Posterior border of the ulna, the subcutaneous through the length. It can be felt on the longitudinal furrow of the back of the forearm with the flexed elbow. It separates the flexor and the extensor muscles of the forearm. Posterior border of the ulna. And then styloid process of the radius and ulna can be easily felt on the lateral and the medial side of the wrist respectively. The styloid process of the radius is located about 1.25 centimeters on distally. The styloid process of the radius is located also more distally. The styloid process of radius and ulna can easily be felt on the middle side of the wrist respectively. And the styloid process of the radius can be felt in the proximal part on anatomical snip box. The styloid process of the radius. The styloid process of the ulna can be felt on the posterior aspect of the wrist, about 1 centimeter above the styloid process of radius. On the wrist. Dorsal tubercle of the radius can be palpated on that posterior aspect of the distal end of the radius in line with the cleft between the index and the middle finger. Tendons and flexor carpi radialis and palmaris longus and flexor carpi ulnaris can be identified on the front of the wrist when the fist hand is flexed against resistance. Pulsations of brachial, radial, and ulnar arteries can be felt on the front of the forearm. Transverse creases on the front of the wrist. Proximal transverse creases lie at the level of the wrist joint. Proximal creases. Distal creases correspond to the proximal border of the flexor reticulum. Fascial compartment of the forearm. The forearm is closed in sheath of the deep fascia of the forearm. Anterior brachial fascia is attached to the posterior subcutaneous border of the ulna from the deep surface of the fascia. The forearm is enclosed in sheath of the deep fascia of the forearm. It is attached to the posterior subcutaneous border of the ulna from the deep surface of the fascia. Septa passes between the muscles and some of them reach at the bone. The deep fossa together with the interosseous membrane and fibrous intermuscular septa divides the forearm into several compartments, each having its own muscles, nerves, and blood supplies. Classically, the forearm is divided into two compartments, anterior compartment and posterior compartment. So we see the elbow, the radius, and the ulna, the interosseous membrane, and the wrist. The framework of arm. Approaches surface landmarks on the front and in the back of the forearm. In the front, lateral epicondyle, medial epicondyle. Lateral epicondyle, medial epicondyle, and then styloid process, and then medial process, pisiform bone. So on the here there is the styloid process of the radius, and then here is the styloid process of ulna and the pisiform bone. Olecranon process, triangular subcutaneous area of the olecranon process, posterior border of the ulna, styloid process of ulna, Lister's tubercle, and then styloid process of radius. The lateral intermuscular septum interosseous membrane of the deep fossa attached to the posterior border of the ulna. The anterior compartment continues with the structure on the front of the forearm, and posterior compartment contains the structure of the back of the forearm. The deep fascia over the flexor muscle tendons as they pass in front of the wrist. It is especially thickened on the front of flexor reticulum. For details, see page 140. Similarly, on the back of the distal forearm, just approximately to the hand, it is especially thickened to form the extensor reticulum hand. It is especially thickened extensor reticulum. Both the flexor and the extensor reticulum remain the long distal tendon of the posterior during hand movements and prevent them from bow standing. Reticulum. Both the flexor and the extensor reticulum retain the long distal tendons. Both the flexor and the extensor reticulum remain in the long distal tendons in the posterior during hand movements and prevent them from bow swinging. Anterior compartment in front of the forearm. Arteries in front of the forearm. The arteries in front of the forearm are ulnar and radial arteries. They mainly supply blood to the hand through the superficial and deep palmar artery arches. The blood supplied to the forearm is mainly derived from the anterior and the posterior interosseous arteries. The terminal branches of the common interosseous artery and branch of the ulnar artery. So the blood supply to the forearm is mainly divided from the anterior and posterior interosseous arteries. The terminal branches of the common interosseous artery and the branch of the ulnar artery. So the brachial artery and the deep branch of the radial nerve, the superficial radial nerve, and the deep palmar arch, superficial palmar arch, ulnar artery, and then ulnar nerve, medial epicondyle humerus, medial nerve, and the ulnar nerve. So the arteries of the front of the forearm are ulnar and radial arteries. They mainly supply blood to the hand through the superficial and deep palmar arteries. The blood supply to the forearm is mainly derived from the anterior and the posterior interosseous arteries and the terminal branches of the common interosseous artery, a branch of the ulnar artery. The ulnar artery is the largest terminal branch of the brachial artery, ulnar artery. It begins in the cubital fossa at the level of the neck of the radius on 1 cm distal to the flexor crease of the elbow. It runs downward and reaches the medial side of the forearm, midway between the elbow of the wrist. In the upper 1/3 of the forearm, the course is oblique downward and medially, but in the lower 2/3 it is vertical. About 2.5 cm distal to the elbow, it is crossed by median nerve and median to the lateral side. The ulnar nerve lies median to the distal 2/3 of the artery. At wrist, it enters the palm by passing in front of the flexor reticulum lateral to the ulnar nerve and pisiform bone. It terminates the hand by dividing into the superficial and the deep branches, ulnar nerve. Superficial and deep branches. The superficial branch, the continuous of the artery, forms the superficial palmar arch, which anastomoses the superficial palmar branch of the radial artery. Relations. The upper part of its course, it lies deep to the superficial flexor muscles. In the lower part of its course, it becomes superficial and lies between the tendon of flexor carpi ulnaris and flexor digitorum superficialis, and details as follows. Anterior. The upper part of the ulnar artery is covered by 5 superficial muscles and forearm, namely pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor carpi ulnaris. The lower part of the ulnar artery is covered only by skin and superficial deep fossa. Posterior. So the ulna is covered by pronator teres, flexor digitorum flexor digitorum, flexor carpi ulnaris, flexor digitorum superficialis, flexor carpi radialis, flexor carpi ulnaris, flexor carpi radialis, flexor carpi ulnaris, palmaris longus, flexor carpi radialis, flexor digitorum superficialis. The lower part of the ulnar artery is covered only by the skin and the superficial deep fossa. The lower part of the ulna is covered only by the skin and the superficial deep fossa. Posterior. Only the origin of the ulnar artery lies on the brachialis. Only on the origin of the ulnar artery lies on the brachialis, while in the remaining whole part of its course lies in the flexor digitorum profundus. Only the origin of the ulnar artery lies on the brachialis. Posterior. Anterior and now posterior. Median. Ulnar nerve, flexor carpi ulnaris, and lateral flexor digitorum superficialis. Branches. Muscular branches. The muscular arteries, anterior and posterior ulnar recurrent arteries. Anterior and posterior ulnar recurrent arteries takes part in the anastomosis around the elbow joint. Common interosseous artery that arises on the upper part of the ulnar artery after a very short course at the upper border of the interosseous membrane. It divides into the anterior and the posterior interosseous arteries. Palmar and dorsal ulnar carpal branches that takes part in formation of the palmar dorsal carpal arches. Terminal branches of the two. The superficial branch continues as the superficial palmar arch, while the smaller deep branch joins the deep palmar arch. Aberrant ulnar artery. About 3% of individuals, the brachial artery divides into terminal branches up to the arm. Aberrant ulnar artery. About 3% of individuals, the brachial artery divides into terminal branches high up in the arm. Therefore, the ulnar artery may rise high in the arm and passes superficial to the flexor muscle of the forearm and termed as a superficial ulnar artery. The variation should always be kept in mind while withdrawing blood samples and giving intravenous injections. Because of its superficial ulnar artery is mistaken for a vein, it may be damaged and produce bleeding. Further, it can irritate drug is injured into the aberrant artery as the result of can be fatal. Anterior interosseous artery. It is a branch of the common interosseous artery. It, along with the posterior interosseous artery, is the main source of blood supply of the forearm. Anterior interosseous artery. So, anterior interosseous artery. Forearm. The anterior interosseous artery descends on the front of the interosseous membrane to accompany with the anterior interosseous nerve, a branch of the median nerve. It pierces the member of the upper border of the pronator quadratus to enter into the posterior compartment of the forearm, where it anastomoses with the posterior interosseous artery and travels underneath the extensor reticulum to interosseous artery to reach the dorsal aspect of the disjoint and dorsal carpal arch. Radial artery. Course, origin and termination. The radial artery is the smaller terminal branch of the brachial artery. The radial artery is the smaller terminal branch of the brachial artery, radial artery. It begins at the cuboidal fossa. Cuboidal fossa at the level of the neck of the radius. It passes downward to the wrist joint, lateral to convexity. In the upper part, it lies beneath the brachialis on the deep muscle of the forearm, then between the tendons of the brachialis and flexor carpi radialis in long forearm. At wrist, it lies at the anterior surface of the radialis lateral to the tendon of the flexor carpi radialis, and it is covered by skin and fascia. The superficial radial never lies lateral to the middle one-third of the radial artery. The superficial radial never lies lateral to the medial one-third of the radial artery. The radial artery leaves the forearm by winding around the lateral aspect of the wrist to reach the anastomotical snub box, the posterior surface of the hand. Its further course in hand is described on page 157. Relations. Anterior. The upper part of the radial artery is overlapped by the brachialis, while the lower part of the covered only by skin by superficial and deep fossa. Posterior. The radial artery from above downward lies on the following structures: biceps tendons, supinator pronoteres, and flexor digitorum superficialis. These structures together form the bed of the radial artery. The radial artery is quite superficial through its whole course as compared to the ulnar artery. Branches of the forearm. Muscular branch. To to the lateral muscles of the forearm. Radial recurrent artery arises from the cubital fossa, takes place in the formation of the arteries and anastomosis around the elbow joint. Palmar carpal branch arises near the wrist and anastomosis with the palmar carpal branch of the ulnar artery. Superficial palmar branches arises just above the wrist and enters the palmar of the hand, passing in the front of the flexor reticulum. It joins the terminal part of the ulnar artery and completes the superficial palmar arch. Clinical correlation: radial artery is normally used to take pulse and increasingly being used to main normally takes pulse and increasingly being used as a main portal of interventional radiology. Cardiography and autography. Angiography. Examination of the radial pulse. It is felt on the radial side of the front of the wrist, where the radial artery lies on the front anterior surface of the distal end of the radius and covered only by skin and fossa. At this site, the radial artery lies between the tendon of flexor carpi radialis medially and the tendon of brachialis laterally. While examination the radial pulse, the thumb should not be caused and has its own pulse, which may be mistaken for the patient's pulse. The thumb should not be used because it has its own pulse. The thumb should not be used. Is for examination of the pulse rate. The radial pulse is commonly used for examination of the pulse rate. Nerves of the forearm. The nerves of the forearm are median, radial, and ulnar. The radial and the ulnar nerves and their names are indicating along the radial and the ulnar margins of the forearm outside the radial and ulnar arteries. The median nerve, according its name, runs on the medial region of the forearm. Median nerves of the forearm. The median nerve is the principal nerve of the front of the forearm and supplies all the muscles of the front of the forearm except the median half of the flexor digitorum profundus, flexor carpi ulnaris, which are supplied by the ulnar nerve. The median nerve is the principal nerve of the forearm and supplies all the muscles of the forearm except for the median nerve, except for the flexor digitorum, median nerve, profundus, and flexor carpi ulnaris. The median nerve leaves the cubital fossa by passing between the two heads of the pronator teres. Leaves the cubital pronator teres. Here it crosses the ulnar artery from the median to the lateral side, from which it separates by the deep head of the pronator teres. When along with the ulnar artery, it passes beneath and deep to the fibrous arch of joining the two heads, flexor digitorum superficialis, and runs down to muscle on the surface of the flexor digitorum profundus. At the wrist, about 5 cm proximal to the flexor reticulum, the median nerve emerges from the behind lateral border of the flexor digitorum superficialis and lies behind the tendon of the palmaris longus. Note that in front of the wrist, the median nerve, the median nerves become superficial, lying between the tendon of the flexor digitorum superficialis medial and flexor carpi ulnaris laterally. It is covered only partially by the tendon of palmaris longus. The tendon nerve enters the palmar of the head by passing deep to the flexor reticulum through the carpal tunnel. Branches. As muscular branch, it is a cubital fossa of the pronator teres and flexor carpi radialis and flexor palmaris longus and flexor digitorum superficialis. It is the elbow and the proximal radioulnar joint. Anterior interossseous nerve arises from the upper part of the forearm and down to the anterior surface of interossseous membrane between the flexor pollicis longus and flexor digitalis flexor profundus. It passes deep to the corona and the quadratus and ends in the anterior surface of the corpus. It supplies the flexor pollicis longus and lateral half of the flexor digitorum profundus and pronator quadratus. It also provides articular tweaks in the distal radioulnar wrist joint. Palmar cutaneous branch rises about 5 cm above the wrist joint and passes forward in front of the flexor reticulum to supply the skin over the thinner eminence and the central part of the palm. Ulnar nerve, forearm. The ulnar nerve enters the forearm by passing through the gap between the two heads of the flexor carpi ulnaris. and runs down to the medial side of the forearm from flexor carpi ulnaris and flexor digitorum profundus. It enters the palm of the hand by passing front of the flexor reticulum lateral to the pisiform bone. In the distal two-thirds of the forearm, the ulnar artery is lateral to the ulnar nerve. Branches. Muscular branches of the flexor carpi ulnaris and medial half of the flexor digitorum profundus. Articular branches of the elbow joint. Palmar and cutaneous branch. It arises in the middle of the forearm and supplies the skin over the hypothelial eminence. It sometimes supplies the palmaris brevis. Dorsal cutaneous branch. It arises distal third of the forearm. It passes medially between the tendon of flexor carpi ulnaris and tendon of the flexor digitorum profundus. Radial nerve of the forearm. The radial nerve enters the cubital fossa by descending between the brachialis and the branchialis muscle. It, front of the lateral epicondyle, divides into the terminal branches, the deep superficial. The deep and the radial nerves wind around the neck and radius between the two heads of the supinator and the further teres quadratus on the posterior intercostal nerve. The superficial nerve and the radial superficial nerve are the main continuous of the radial nerve. It runs downward under the copper and brachioradialis on the lateral end of the radial artery. And then the relationship of the nerve and the arteries in front of the arm. Nice auntie never allows nuisance. Nerve, artery, nerve, nerve, artery, nerve, artery, nerve. Nerve, artery, nerve, artery, nerve. This is the relationship between nerve and arteries. Clinical correlation. Surgical side of the forearm. The lateral side of the anterior aspect of the forearm is considered to be the safe side of the anterior aspect of the lateral side of the anterior aspect. An anterior aspect of the forearm is considered to be the safe side by surgeons because the branches of the median nerve, the main nerve in front of the forearm, and the mostly directed medially to supply the muscles in front of the forearm. The major nerves of the lateral side is the superficial radial. The major nerve of the lateral side is the superficial radial nerve. It is only sensory branch of the radial nerve and runs deep to the brachialis muscle in the proximal forearm. The major nerve on the lateral side of the superficial radial nerve. Relation structures in the front. The structures lying in the front of the conventional wrist from the lateral to the medial side are as follows. Radial artery, tendon of the flexor carpi ulnaris. Structures from the lateral to the medial side are radial artery, tendon of flexor carpi radialis, median nerve, and then flexor palmaris longus, and then flexor digitorum superficialis, ulnar nerve, ulnar artery, flexor carpi ulnaris. So the median nerve and the tendon of carpi ulnaris, tendon of flexor carpi radialis, ulnar nerve, ulnar artery, flexor digitorum superficialis, ulnar ulnaris. Median nerve is a very superficial in front of the wrist and lies along the lateral edge of the tendon of the palmaris longus. Median nerve is very superficial in front of the wrist. Median nerve lies deep to tendon of the palmaris longus. Deep to the tendon of the palmaris longus, median nerve. Suicidal cuts of the wrist. A deep laceration on the radial side of the wrist. A deep laceration on the radial side of the wrist, as in suicidal attempt, may be cut of the structures are released. The sides, medial sides, radial artery, the tendon of flexor carpi radialis, median nerve, tendon palmaris longus, and flexor digitorum superficialis. A deep laceration of the ulnar side of the wrist, as suicide attempt. Ulnar side of the wrist. Structures from the medial to lateral side are flexor carpi ulnaris, ulnar nerve, ulnar artery. Note 12. None of the deep muscles of the back of the forearm cross the elbow joint. All of them arise from the radius, ulna, and interosseous membrane. None of the deep muscles of the back cross the elbow joint. All of them are supplied by the posterior interosseous nerve. All of them are supplied by the posterior interosseous nerve. Extensor reticulum. The deep fossa on the back of the wrist is thickened to form the oblique fibrous band called the extensor. The deep fossa on the back of the wrist is thickened to form the oblique band of the extensor reticulum. It is directed downward and medially about 2 centimeters broad vertically. Attachments. The medial end of the extensor reticulum is attached to the styloid process of ulna. The median end of the extensor reticulum, styloid process of ulna, and the pisiform bone. Extensor reticulum. Extensor reticulum. Flexor reticulum. Extensor reticulum. Extensor reticulum. It is the deep fossa of the wrist taken from the oblique reticulum directed downwards medially 2 centimeters. And the attachment is attached to the styloid process of ulna and then triquetral and pisiform. Triquetral and pisiform. The lateral side is attached to the lower part of the anterior border of the radius compartments. The space deep to the extensor reticulum is divided into 6 compartments by 5 septa, extending from the reticulum to dorsal aspects of the lower end of the radius and ulna. The compartments are numbered 1 to 5 and lateral to the medial side. The structures passing through the compartments are listed table. As the tendon passes across the dorsum of the wrist, they are enclosed within the synovial sheath. Synovial tendon sheaths are reduced friction and extensor radius as they pass through the osseous membrane. The compartments under the extensor reticulum functions. It holds the extensor reticulum in place at the back of the wrist joint and prevents their bowstringing when the hand is extended on the wrist joint. So compartment 1, 2, 3, 4, 5, 6. Abductor pollicis longus, extensor pollicis brevis. The extensor alaris exustorum minimi. Posterior interoserous nerve. Origin and course. The posterior interoserous nerve, terminal branch of the radial nerve, motor and chief branch of the forearm. It is the motor and the chief nerve of the back of the forearm, interosseus. It is the motor and the chief nerve. Is the motor and the chief nerve of the back of the arm. It begins at the cuboidal fossa as one of the 2 terminal branches of the radial nerve at the level of the lateral epicondyle of the humerus. It levels at the cuboidal fossa by winding around the lateral side of the neck and the radius and substance of the supinator. After emerging from the supinator, it runs to the fascia plane between the superficial and the deep extensor muscles. At the lower border of the extensor pollicis brevis passes the extensor pollicis longus. Muscular branch passing through the supinator and then articular branches. All the muscles of the back of the forearm are supplied by the posterior interosseous nerve except the brachialis, extensor carpi radialis longus and anquanus, which are supplied by the radial nerve directly. Posterior interosseous nerve syndrome. It occurs when the posterior interosseous nerve is entrapped in the arcade of horse, which is a fibrous band between the head of the supinator muscle. Arcade of horse. The posterior interosseous nerve passes deep to the arcade into the radial tunnel between the heads of the superficial and deep, the supinator muscle. Clinically, it presents a pain and the weakness of the forearm, causing difficulty in pulling, pushing, and grabbing. The posterior interosseous nerve is a deep terminal branch of the radial nerve. During the surgical expansion of the leaf and radius, in the fracture proximal end of the radius, since external pollicis radialis longus, it is a separated wrist drop does not occur. Some authorities think that deep terminal branch of the radial nerve is termed as the posterior interosseous nerve only after emerging from the supinator muscle. Posterior interosseous artery. Posterior interosseous artery is a smaller terminal branch of the common interosseous artery from the ulnar artery. It begins in the cuboidal fossa, enters the back of the form by passing through the gap between the oblique cord and the upper margin of the interosseous membrane. From here, it passes between the supinator and the abductor pollicis longus and run to the posterior interosseous nerve. It is the lower part of the forearm. It becomes marked, reduced, and ends by anastomosing with the anterior interosseious artery. In the lower part of the forearm, the anterior interosseious artery enters the back of the forearm by piercing the interosseious membrane above the pronotor quadratus, supply 1/4 the back of the forearm. The posterior interosseious artery in the cuboidal fossa gives the interosseious recurrent artery. The posterior interosseious artery in the cuboidal fossa. Posterior interosseious artery in the cuboidal fossa gives the anterosseious recurrent artery. Takes a part of the formation of the anastomosing around the elbow joint. Brachialis, which lies the back of the forearm. Flexor carpi ulnaris, which is supplied by both the ulnar medial nerve. The flexor, all the flexor muscles of the forearm and the elbow lie on the forearm except lie on the front of the forearm. All the flexor muscles except brachialis, which lies at the back of the forearm. And now all the superficial flexors of the forearm supply the median nerve except flexor carpi ulnaris, which is supplied by the ulnar nerve. The most powerful and the most bulky muscle of the forearm is flexor digitorum profundus, and deepest muscle of the forearm is pronotor quadratus. Deepest artery of the forearm is artery interosseious artery. Principal nerve of the front of the forearm, median nerve. Safe side of the anterior aspect of the surgeon's lateral side of the forearm. Most superficial muscle along the brachial side of the forearm, brachioradialis. Lister tubercle dorsal radius. Chief of the forearm, posterior interosseious nerves. All the muscles of the back of the forearm are extensor except brachioradialis, which is a flexor of the forearm. All the muscles of the back of the forearm are extensor except the brachialis, which is an extensor flexor of the forearm. Commonest site of palpitation, radial artery in wrist joint. Commonest palpitation are radial artery at the wrist joint. Commonest site of palpitation. And chief blood supply artery, ulnar artery. Chief blood supply. Commonest chief blood supply artery, ulnar artery. Forms of the radial 3 tendon of flexor radialis, median nerve, and tendon of the tamaris longus. Tendon of flexor digitorum superficialis. Radial artery, ulnar nerve. Radial artery, tendon of flexor carpi radialis longus, median nerve. Radial artery. Radial artery, the radial pulse is felt at the wrist site. Chapter 7. Innervation, venous drainage, and lymphatic drainage of the upper limb. Innervation, cutaneous innervation. The knowledge of cutaneous innervation is essential during physical examination of the patient. The sensory testing of the skin of the upper limb is performed whenever a damage of nerves arising from C3 to T1s spiral segments is suspected. Light touch on the pinprick or the main sensation tested routinely, but the temperature, 2-point discrimination, and vibration are also tested in special cases. The area of anesthesia and paresthesia are mapped out and matched with the dermatomal distribution. The compression of the nerve roots of spinal nerves arises from C3 to C2 spiral segments due to spondylitis. Pain is referred to respective dermatomes. Cutaneous nerves of the upper limb. The cutaneous nerves of the upper limb are derived from the ventral rami of the spinal nerves, derived from C3 to C2 spinal segments. These nerves are derived from the ventral rami, not dorsal but ventral rami, because the upper limb but develops from ventral half of the body, opposite the C3 and C2 spinal segments. During dissection, the cutaneous nerves are seen to arise from the three sources. For example, cervical plexus, brachial plexus, and then intercostobrachial nerve. The cutaneous nerves carry sensation of pain, touch, temperature, and pressure. In addition, they carry sympathetic fibers which supply sweat glands, dermal arterioles and erector pili muscles. Carry and erector muscles. The effect of sympathetic stimulation of the skin therefore is vasomotor, and pilomotor respectively. The area of the skin supplied by a single spinal nerve segment is called dermatome. The cutaneous nerve contains fibers from more than one spinal nerve, and each spinal nerves provide fibers to more than one cutaneous nerve. As a result, the skin areas supplied by the cutaneous nerves do not correspond with dermatomes. Cutaneous nerve supply in different regions of the upper limb as follows: pectoral region above the secondary. This region is supplied by the supraclavicular nerves C3 and C4, and below the secondary rib by the intercostal nerves by T2 and T6. Axilla. The axilla of the armpit is supplied by interocostobrachial nerve T2 and a small branch of T3. Shoulder. Upper half of the glenoid is supplied by the lateral supraclavicular nerve. Lower half of the deltoid region is supplied by the upper lateral cutaneous nerve of the arm, which is cutaneous branch of the axillary arm. Brachium. Upper medial part of the arm is supplied by the interocostobrachial nerve derived from the second intercostal. Second medial part of the arm is supplied by the median cutaneous nerve of the arm from the medial cord of the brachial plexus. Upper lateral half of the arm is supplied by the upper lateral cutaneous nerve of the arm and axillary nerve. The lower lateral half of the arm is supplied by the lower lateral cutaneous nerve of the arm C5 and C6 from radial nerve. Posterior aspect of the arm is supplied by the posterior cutaneous nerve of the arm C5 from radial nerve. Forearm. Anterobrachium is supplied by the medial, lateral and posterior cutaneous nerves and derived from the medial, lateral and posterior cords of the brachial plexus respectively. Medial side of the forearm is supplied by the medial cutaneous nerve of the forearm from the medial cord of the brachial plexus. It becomes cutaneous halfway down the arm along the basilic vein. Lateral side of the forearm is supplied by the lateral cutaneous nerve of the forearm C5 and C6 from the musculocutaneous nerve, a branch from the lateral cord of the brachial plexus. It is the continuation of the musculocutaneous nerve. It emerges at the lateral border of the biceps and divides into anterior and posterior branches. Posterior side of the forearm is supplied by the posterior cutaneous nerve of the forearm. From radial nerve, a branch from the posterior cord of the brachial plexus. It runs down the posterior aspect of the forearm up to the wrist. Hand. Palm of the hand. Lateral 2/3 of the palm is supplied by the palmar cutaneous branch of the medial nerve. Medial 1/3 of the palm is supplied by the palmar cutaneous branch of the ulnar nerve. Dorsum of the hand. Hand. The palm of the hand, lateral 2/3 of the palm is supplied by the posterior cutaneous branch of the medial nerve. Medial 1/3 of the palm is supplied by the palmar cutaneous branch of the ulnar nerve. Dorsum of the hand. Lateral 2/3 of the dorsum hand is supplied by the superficial terminal branch of the radial nerve. Medial 1/3 of the dorsal arm of the hand is supplied by the dorsal branch of the cutaneous branch of the ulnar nerve. Digits. Palmar aspect on the lateral 31/2 digits and then dorsal aspect up to the distal half of the medial phalanges, including nail beds, are supplied by the digital branches of the medial nerve. Palmar aspects of the median 11 by 2 digits and their dorsal aspects up to the dorsal half of the middle phalanges by the palmar digital branches of the ulnar nerve. Dorsal aspect of the lateral 31 by 2 digits up to the proximal half of the middle phalanges are supplied by the digital branch of the radial nerve except the nail beds. Dorsal aspect of the median 11 by 2 digits up to their middle phalanges are supplied by the digital branches of the ulnar nerve. Dermatome supplied by our upper limb. As already mentioned, the area of the skin supplied by a single spinal nerve is called dermatome. In the trunk, the arrangements of the dermatomes is simple, typical, because a spinal nerve supplying do not form plexus and are arranged segmentally. A typical dermatome extends on the side of the trunk from the anterior median line to the posterior median line. In the limbs, the arrangement of the dermatomes is compatible because of the rotation of the limbs during their development. It becomes further complicated because the spinal nerve supplied from the plexus. During development, before rotation, each limb has proximal and proximal borders with former being directed downwards the head. The digits along the paraxial border are thumb in the upper limb and big toe in the lower limb. During rotation of the limbs, the upper limbs are rotated laterally, and as a result, proxial borders and the thumb lies on the lateral side. In the lower limb rotates laterally, and the lower limb rotates laterally. As a result, and the lower limb rotates medially. Therefore, the proxial border of the toe lies on the medial side. Consequently, the dermatomes are arranged consecutively downwards on the lateral side of the upper limb and upwards the medial side of the upper limb. To be surprised, the dermatomes of the upper limb are arranged in numerical sequences as follows: from the shoulder to the thumb, along the paraxial border C3 to C6 spinal segments, from the thumb to the little finger, from the shoulder to the thumb, C3 to C6, and then from that little finger with a posterior border C8 to T2 segments, and then the thumb and the little finger, from the thumb to the little finger C6 to C8 segments. Clinical correlation. Significance of the dermatomes, as discussed to be in the beginning. The understanding of dermatome arranged on the upper limb is clinically important because the physicians commonly test the integrity of the spinal segments from the C3 to C2 by performing the sensory examinations of for touch, weighing, temperature. This is so because the sensory loss of the skin allowing injuries to the cord conforms to the dermatomes area and segments. So the nipple segment is T4, tip of the shoulder is C4, lateral side of the arm C5, lateral side of the forearm C6, thumb C6, hand and the middle 3 digits C7, little finger C8, medial side of the forearm C8, medial side of the arm T1 and axilla T2. Note 12. Overlapping of the adjacent dermatomes. The students must remember that there is a varying degree of overlaying of adjacent dermatomes. Consequently, the area of sensory loss following a damage to the cord segment is always less than the area of distribution of the dermatomes. Students must remember that there is a varying degree of overlap of adjacent dermatomes. Consequently, the area of sensory loss following the damage to the cord segment is always less than the area of the distribution of the dermatomes. Consequently, the area of sensory loss following the damage of the cords is always less than the area of sensory loss distribution of dermatomes. The area of sensory loss. মাদার কেন আমি লাভ করি না? অণুজীব বার্ডস আই ভিউ এক পৃষ্ঠায় পুরো অর্থায় গুরুত্বপূর্ণ তথ্যাবলী। বৈশিষ্ট্য জীব ও জড়জীব। ভাইরাসের বৈশিষ্ট্য জীবীয় বৈশিষ্ট্য। ভাইরাস অকোষীয়, পোষক দেহের বাইরে বংশবৃদ্ধি করতে পারে না, দেহের কোনো বিভাগ প্রক্রিয়া ঘটে না, ভাইরাসকে পানিতে মেশানো যায়। জীবীয় প্রোটিন আবরণী অ্যান্টিজেনিক, দেহে নিউক্লিয়াস থাকে, পোষক দেহে অভ্যন্তরে বংশবৃদ্ধি করতে পারে, ভাইরাসের মিউটেশন ঘটে ও নতুন ভ্যারিয়েশন সৃষ্টি হয়। ভাইরাস গঠন। ক্যাপসিড, নিউক্লিক অ্যাসিড ও এনভেলাপ। প্যাপলোমিয়ার, লিপোভাইরাস, স্পাইক, নগ্নোভাইরাস, এনজাইম। লাইসোজাইম, নিউরোমিনিটেজ, পলিমারেজ, ট্রান্সক্রিপ্টেজ, রিভার্স ট্রান্সক্রিপ্টেজ। বৈশিষ্ট্যর গঠন। এরপরে প্রকারভেদ। আকার অনুযায়ী, নিউক্লিক অ্যাসিড ধরন অনুযায়ী। আকার অনুযায়ী দণ্ডা আকার, টিএমভি, মামস, গোলাকার, পোলিও, ডেঙ্গু, এইচআইভি, টিআইভি। ঘনক্ষেত্র আকার, ভ্যাকসিনিয়া, হার্পিস, ব্যাঙাচি আকার, T2, T4, T6। ডিম্ব আকার, ইনফ্লুয়েঞ্জা, সূত্রাকার, ইবোলা, স্ট্রিং ভাইরাস। নিউক্লিক গঠন অনুযায়ী ডিএনএ ভাইরাস, T2, টিআইভি, ভ্যারিওলা, একসূত্রক, কলিফ্লাওয়ার, দ্বিসূত্রক। নিউক্লিক অ্যাসিড ধরন অনুযায়ী আরএনএ ভাইরাস, টিএমভি, এইচআইভি, মামস, একসূত্রক, টিএমভি, দ্বিসূত্রক। রিও ভাইরাস, ধানের বামন রোগ ভাইরাস। আর গুরুত্ব, উপকারী, প্রতিরোধক তৈরি, বসন্ত, পোলিও, প্লেগ, টাইফয়েড, জলাতঙ্ক। ওষুধ হিসেবে টাইফয়েড, কলেরা, রক্ত আমাশয় রোগ। আর অপকারী, মানুষের রোগ সৃষ্টিকারী, ইনফ্লুয়েঞ্জা, পোলিও, হাম, বসন্ত, ডেঙ্গু, ভ্যারিওলা, হেপাটাইটিস, জলাতঙ্ক, হার্পিস, এইডস। উদ্ভিদের রোগ সৃষ্টিকারী, পেঁপের রিং স্পট, তামাকের মোজাইক রোগ ও ধানের টুংরো রোগ। আর পোষক দেহের অনুযায়ী উদ্ভিদ ভাইরাস, প্রাণী সায়ানো ভাইরাস, উদ্ভিদ ভাইরাস, টিএমভি, প্রাণী ভাইরাস, এইচআইভি, সায়ানো ভাইরাস, LPP2, ব্যাকটেরিয়া ভাইরাস, T2। জননের প্রকৃতি অনুযায়ী লাইটিক ভাইরাস, লাইসোজেনিক ভাইরাস। ব্যাকটেরিয়াফাজের মধ্যে আবার গঠন ও জীবনচক্র, লাইটিক, লাইসোজেনিক। ব্যাকটেরিয়া, এগুলো সবাই ভাইরাস ছিল, এরপর ব্যাকটেরিয়া। গুরুত্ব, বৈশিষ্ট্য, গঠন, জনন, প্রকারভেদ। উপকারী চিকিৎসা ক্ষেত্রে অ্যান্টিবায়োটিক উৎপন্ন প্রতিষেধক, টিকা। কৃষিক্ষেত্র, শিল্পক্ষেত্র, মানব জীবনে অপকারী, মানুষের রোগ সৃষ্টি, গবাদি পশুর রোগ সৃষ্টি, উদ্ভিদের রোগ সৃষ্টি, খাদ্য পচন বিক্রিয়া ও পানি দূষণ। দলবদ্ধ বসবাস, আদি নিউক্লিয়াসযুক্ত প্রোটোপ্লাজমের রাইবোজোম ও মেসোজোম উপস্থিত, সুগঠিত কোষ প্রাচীর, পরভোজী, কিছু স্বভোজী, প্রতিকূল পরিবেশে অ্যান্ডোস্পোর গঠন। গঠন, ক্যাপসুল, কোষ প্রাচীর, কোষঝিল্লি, সাইটোপ্লাজম, নিউক্লিয়য়েড, ফ্লাজেলা, পিলি ও প্লাজমিড। জনন, দ্বিবিভাজন, মূকুলোদ্গম, খণ্ডায়ন ও শাখা উৎপাদন। অযৌন জনন, গনিডিয়া, অ্যান্ডোস্পোর। যৌন জনন, কনজুগেশন, ট্রান্সডাকশন অ্যান্ড ট্রান্সফরমেশন। আকৃতি, কক্কাস ও বেসিলাস, স্পাইরেজিলাম, রঞ্জনভিত্তি, গ্রাম পজিটিভ এবং গ্রাম নেগেটিভ, মনোট্রিকাস এবং অ্যাম্ফিট্রিকাস। ম্যালেরিয়া, জীবনচক্র, অযৌন চক্র বা হ্যাপাটিক সাইজোগনি, এইথ্রোসাইটিক সাইজোগনি এবং যৌন চক্র, মশকের দেহে। অযৌন চক্র, স্পোরোজয়েড, ক্রিপ্টোজয়েড, সাইজন্ট, ক্রিপ্টোমেরোজয়েড, মেটাক্রিপ্টোমেরোজয়েড। এরিথ্রোসাইটিক সাইজোগনি, ট্রোফোজয়েড, সিগনেট রিং, অ্যামিবয়েড, ট্রোফোজয়েড, সাইজন্ট ও মেরোজয়েড। আর যৌন চক্র, মশকের দেহে গ্যামেটোগনি, স্পার্মাটোজেনেসিস, নিষেক, উওকিনেট, উওসিস্ট এবং স্পোরোগনি। পরজীবীর নাম, সৃষ্ট রোগ, জ্বরের প্রকৃতি, সুপ্তাবস্থা প্রভৃতি। ম্যালিগন্যান্ট ম্যালেরিয়া, বিনাইন টার্সিয়ান ম্যালেরিয়া, মাইল্ড টার্সিয়ান ম্যালেরিয়া, কোয়াটার্ন ম্যালেরিয়া। সুপ্তাবস্থা, সর্বোচ্চ গড় ও বিস্তৃতি, জলের প্রকৃতি। আর এক্ষেত্রে জনুক্রম, হ্যাপ্লয়েড জনুক্রম এবং ডিপ্লয়েড জনুক্রম। হ্যাপ্লয়েড জনুক্রম স্পোরোজয়েড, ক্রিপ্টোজয়েড, ট্রোফোজয়েড, সাইজন্ট, মেরোজয়েড, গ্যামিটোসাইট। আর ডিপ্লয়েড জনু জাইগোট, উকিনেট এবং উওসিস্ট। ভাইরাস, ব্যাকটেরিয়া, ছত্রাক ও প্রোটোজোয়া প্রভৃতি ব্যাকটেরিওপস এর অন্তর্ভুক্ত। জীব বিজ্ঞানের যে শাখায় অণুজীব সম্বন্ধে আলোচনা করা হয় সে শাখাকে অণুজীব তত্ত্ব, মাইক্রোবায়োলজি বলা হয়। অ্যান্টোনিও ভন লিউয়েনহুককে মাইক্রোবায়োলজির জনক বলা হয়। ভাইরাস, নাইস টু নো। ভাইরাস হলো নিউক্লিক অ্যাসিড ও প্রোটিন নিয়ে গঠিত অকোষীয় অতি আণুবীক্ষণিক বাধ্যতামূলক পরজীবী বস্তু যা জীবদেহের অভ্যন্তরে সক্রিয় হয়ে রোগ সৃষ্টি করে কিন্তু জীবদেহের বাইরে নিষ্ক্রিয় অবস্থায় বিরাজ করে। ভাইরাসের একটি ল্যাটিন শব্দ যার অর্থ বিষ বা বিষাক্ত তরল। ইডি রাইবিকির মতে ভাইরাস জীবন প্রারম্ভিক অণুজীব। ডাব্লিউ.এম. স্ট্যানলিকে ভাইরোলজির জনক বলা হয়। সাধারণ তথ্যসমূহ: 1948 সালে হোমস ব্যাকটেরিয়া আক্রমণকারী ভাইরাসকে ফ্যাগোজিন, উদ্ভিদ আক্রমণকারী ভাইরাসকে ফ্যাগোফাজিন এবং প্রাণী আক্রমণকারী ভাইরাসকে জুওফাজিন নামকরণ করেন। এক চামচ সমুদ্রের পানিতে 1 মিলিয়ন ভাইরাস থাকে। এ পর্যন্ত প্রায় 5,000 ধরনের ভাইরাসের বর্ণনা করা হয়েছে। ভাইরাস আবিষ্কারের ইতিহাস, নাইস টু নো। বিজ্ঞানী চার্লস অ্যাংক্লোস ভাইরাসের অস্তিত্ব অনুধাবন করেন। এডওয়ার্ড জেনার প্রথম ভাইরাসজনিত জলাবসতির কথা উল্লেখ করেন, গুটিবসতি টিকা আবিষ্কার করেন। তার মানে এডওয়ার্ড জেনার সর্বপ্রথম ভাইরাসের গুরুত্ব অনুধাবন করেন, আর এডওয়ার্ড জেনার সর্বপ্রথম ভাইরাসজনিত রোগ উল্লেখ করেন, গুটিবসতি টিকা আবিষ্কার করেন। অ্যাডলফ মায়ের তামাক পাতা ছোপ দাগ মোজাইকে উল্লেখ করেন। দিমিত্রি ইভানোভস্কি ভাইরাসের আবিষ্কারক। দিমিত্রি ইভানোভস্কি ভাইরাস নামকরণ করেন এবং মোজাইক রোগকে টিএমবি উল্লেখ করেন। ডাব্লিউ.এম. স্ট্যানলি তামাককে মোজাইক পৃথককরণে ক্যালাসিত করেন। পিডি এবং বাইডেন ভাইরাস রাসায়নিক প্রকৃতি বর্ণনা করেন। গ্যালো এইডস রোগের নামকরণ এইচআইভি আবিষ্কার করেন। এইডস রোগের কারণ এইচআইভি আবিষ্কার করেন। বামবার্গ হেপাটাইটিস বি ভাইরাস আবিষ্কার করেন। হার্ভে জে ওয়াল্টার নীরবঘাতক ব্যাধি হেপাটাইটিস সি আবিষ্কার করেন। ওয়াল্টার রিড মানবদেহে পিতজ্বর আবিষ্কার করেন। সাফারম্যান অ্যান্ড মরিস সাফার ভাইরাস আবিষ্কার করেন। লোভ ভাইরাসই বক্তব্য। সেল লোভ ভাইরাসই অণুজীব ও মধ্যবর্তী একটি বস্তু। ব্যানাল অ্যান্ড ফ্র্যাঙ্কোচ কালাসিত ভাইরাসের এক্সট্রা চিত্র গ্রহণ করেন। রোসাল্যান্ড ফ্র্যাঙ্কলিন ভাইরাসের পূর্ণাঙ্গ গঠন আবিষ্কার করেন। হাওয়ার্ড টেরিন রেট্রোভাইরাস আবিষ্কার করেন। আর্নস্ট অ্যান্ড ম্যাক্সওয়েল ইলেকট্রন অণুবীক্ষণ যন্ত্রের সাহায্যে ভাইরাসের প্রথম চিত্র গ্রহণ করেন। Note 12. Overlapping adjacent dermatomes. The students must remember that there is a varying degree of overlapping of adjacent dermatomes. Consequently, the area of sensory loss following a damage to the cord segment is always less than the area of distribution of the dermatomes. Motor innervation. The embryological muscle mass and muscle derived from it are innervated by a single segment of a spiral cord and a spiral nerve called myotome. Most of the muscles of the upper limb are made of more than one myotome, hence innervated by multiple spinal segments. Hence, multiple spinal segments are involved in producing movements of the upper limb. The details are described on the individual muscles. Note 12. The intrinsic muscles of the hand are derived from single myotome. Intrinsic muscles. Venous drainage of the upper limb. They drain the deoxygenated blood from the hand, forearm and arm. The veins draining the upper limb as well as elsewhere in the body are divided into two sets of groups, superficial and deep. Both groups of veins are interconnected with one another. The superficial veins are located in the superficial fossa and are easily accessible. Being easily accessible, they are frequently used by the clinicians for venipuncture. The deep veins lie between the two deep fossa and run through muscles and accompany arteries as vein communicants. Superficial veins. Introduction. The knowledge of superficial veins of upper limbs is utmost important in medical importance, as they are commonly used for venipuncture for giving intravenous injections and taking out blood for performing various clinical tests. General features. Superficial veins have the general features. They lie in an superficial fossa, subcutaneous fossa, They have tendency of run away from the pressure point, hence they are absent in the palm, first fist area, along the ulnar border of the forearm and back of the elbow, supporting borders of the upper limb. For this reason, they course spirally from the posterior to the anterior surface of the upper limb. They join the arm two major superficial veins. One runs along the paraxial cephalic border and the other along the postaxial caudal border of the limb. The paraxial vein, cephalic vein, is longer than the postaxial vein, basilic vein, but the postaxial basilic vein drains more efficiently. The head of the long cephalic vein is greatly relieved as a good amount of blood is transferred to the efficient basilic vein by the median cubital vein communicating channels. Both cephalic and basilic veins originate from the dorsal vein arch network on the dormitum of the hand. Superficial veins are accompanied by the cubital nerves and superficial lymphatics. Listing of veins. The superficial veins comprises dorsal venous arch, cephalic vein, basilic vein, medial cubital vein, median vein of the forearm. Listing of veins. Dorsal venous arch. The dorsal venous arch is a network of veins on the dorsal of the hand. It presents the irregular arrangement of the veins, usually with the transverse element, which lies 2 to 3 centimeters proximal to the head of the metacarpals. Tributaries. The tributaries of the dorsal veins are, then there is cephalic vein, basilic vein, median cubital vein, and medial vein of the forearm. Common venous patterns in front of the elbow: H-shaped pattern and M-shaped pattern. And now clinical correlation: venipuncture of the cubital fossa, hemodialysis, cardiac catheterization, cephalojugular communications. Deep veins. Vena communicates with the radial and the ulnar arteries. Vena communicates with the smaller veins, axillary veins. Lymphatic drainage of the upper limb. Lymph veins, superficial lymph vessels. And now note well and deep lymph vessels. So superficial lymph vessels and deep lymph vessels. Lymphangitis and lymphedema. And then lymph nodes, superficial lymph nodes, delta pectoral node or infracollicular nodes. প্রাচীন বাংলার ইতিহাস। বাঙালি জাতির উৎপত্তি। আজ থেকে প্রায় 6 থেকে 7,000 বছর পূর্বে বিভিন্ন জাতি বর্ণের মিশ্রণে সৃষ্টি হয় সমগ্র বাঙালি জাতি। সমগ্র বাঙালি থেকে বিভাজন করা যায় প্রাক-আর্য এবং প্রাক-আর্য অর্থাৎ অনার্য এবং আর্য জনগোষ্ঠী। প্রাক-আর্য বা অনার্য জনগোষ্ঠী মূলত নেগ্রিটো, অস্ট্রিক, দ্রাবিড় ও প্রোটো-চীনীয় বা মঙ্গোলীয় এই 4 শাখায় বিভক্ত ছিল। নেগ্রিটো, অস্ট্রীয়, দ্রাবিড়, চীনীয় সংমিশ্র বাঙালি জাতি। নেগ্রিটো এই ভূখণ্ডের প্রথম জনগোষ্ঠী হচ্ছে নেগ্রিটো, যারা প্রায় 20,000 বছর পূর্বে আফ্রিকা হতে বাংলাদেশ ভূখণ্ডে আগমন করেন। বর্তমান অবস্থা আসামের নাগা জাতি, বাংলাদেশ সুন্দরবন অঞ্চল, যশোর ও ময়মনসিংহ জেলা। বাঙালি জাতি নেগ্রিটো, অস্ট্রীয় অর্থাৎ নিষাদ, দ্রাবিড় এবং প্রোটো-চীনীয়। প্রাক আর্য, অনার্য, নরগোষ্ঠী। আর্য নরগোষ্ঠী প্রায় 1500 অব্দ ভারতবর্ষ প্রবেশ করে। সংকর বাঙালি জাতি। আর অস্ট্রীয় জাতি থেকে বাঙালি জাতি প্রধানত গড়ে উঠেছে বলে মনে করা হয়। এরা নিষাদ জাতি নামে পরিচিত। প্রায় 5,000 বছর পূর্বে, তাই সবচেয়ে প্রাচীন জনগোষ্ঠী হচ্ছে নেগ্রিটো। প্রায় 5,000 বছর পূর্বে ইন্দো চীন থেকে আসাম হয়ে বাংলাদেশে প্রবেশ করে। পরবর্তীতে নেগ্রিটো এই ভূখণ্ডের মধ্যে উৎখাত করে বসতি স্থাপন করে। বাংলার আদি জনগোষ্ঠী অস্ট্রীয় ভাষাভাষী ছিল। নৃতাত্ত্বিকভাবে বাংলাদেশে প্রধানত আদি অস্ট্রেলীয় নরগোষ্ঠী অন্তর্ভুক্ত। দ্রাবিড় সভ্যতায় উন্নত বলে দ্রাবিড় জাতি অস্ট্রিকদের ওপর আধিপত্য বিস্তার করে। প্রায় 4,000 বছর পূর্বে খাইবার গিরিপথ দিয়ে দক্ষিণ ভারত থেকে এই ভূখণ্ডে আসে দ্রাবিড় জাতি। এরা মূলত সিন্ধু সভ্যতার সৃষ্ট। অবস্থান দক্ষিণ ভারতের তামিল, তেলেগু, কন্নড় ইত্যাদি অঞ্চল জনগণ। খ্রিস্টপূর্ব 200 অব্দে চীন ও তিব্বত হতে বাংলা ভূখণ্ডে প্রবেশ করে। বাংলার প্রাচীন জনপদ। Injuries of the radial nerve. The radial nerve may be injured in three sites: in the axilla, in the spiral groove, and at the elbow. So at the axilla, at the spiral groove, and at the elbow. Injury of the radial nerve of the axilla. In the axilla, the radial nerve may be injured by the pressure of the upper end, Creutz's pulse, upper end. Characteristic features of such cases will be follows: motor loss, extensor of the elbow due to paralysis of the triceps, loss of extension of wrist drop due to paralysis of extension. This causes wrist drop due to the unopposed action of flexor muscle of the forearm, flexor muscles of the forearm, flexor muscles of the forearm. Loss of extension of the digits due to the paralysis of extensor digitorum, extensor index, extensor digiti minimi, extensor digiti minimi, and the extensor pollicis longus. Loss of supination in the extension elbow because of the supinator muscle brachialis paralyzed. So loss of supinator sensory carpi, supinator, loss of supinator external elbow, supination brachialis are paralyzed, and supinator becomes possible reflex elbow by the action of biceps brachii. Supinator brachialis are paralyzed, but the supination becomes possible because of the biceps brachii. Sensory loss of a small area of the skin over the posterior surface of the lower part of the arm. Sensory loss of the nervous stream of the back of the forearm. Sensory loss of the lateral part of the dorsal of the hand, based on the thumb and dorsal surface of the lateral third of the dorsal phalanges. More often there is isolated sensory loss on the dorsum of the hand at the base of the thumb. Dorsum of the hand at the base of the thumb. Radial. Injury of the radial nerve at the radial spinal groove. The radial nerve may be injured due to midshaft fracture of the humerus, in inversely wrong placed intramuscular injection. So first cause is the fracture of the humerus, also wrongly placed intramuscular injection, direct pressure on the radial nerve, drunken falling asleep of the arm of the Saturday night paralysis. Injury in the radial nerve occurs most commonly in the distal part of the groove beyond the origin of the nerve and triceps of the cutaneous nerve. Characteristic clinical features in such case will be motor loss, loss of extension of the wrist joint, wrist drop, loss of supination when the arm is extended, sensory loss when the restriction only variable a small area over the dorsum of the hand, and first and the second metacarpals. Extension of the elbow is possible in the lesion, but may be little weak because nerve or the long head of the triceps arises in the axilla before the lesion. Isolated sensory loss. Injury of the radial nerve elbow. Radial nerve syndrome. It is an entrapment neuropathy by the deep branch of the elbow. The compression of the radial nerve may be caused by the following fractures: fibrous band which can tether the radial nerve of the radiohumeral joint, sharp tendinous margin of the extensor carpi radialis brevis, leaves of vessels of the radial recurrent artery, arcade of Frost. The arcade of Frost, a fibrous epineuritic proximal edge of the superficial part of the supinator muscle. Characteristic clinical is a loss of sensory wrist joint, wrist drop, pain over the extension of the forearm. Injury of the median nerve. The lesion of the median nerve may occur at the following sites: at the elbow, at the mid-forearm, at the wrist. The elbow, at the mid-forearm, and at the wrist. The carpal tunnel. Injury of the median nerve elbow. The elbow is the median nerve can be injured due to supracondylar fracture of the humerus. The applied and tight rocket during the venipuncture and entrapment of the nerve between the heads of the pronator teres under the fibrous arch. Two heads of the flexor digitorum superficialis. Characteristic clinical features in such cases will be as follows: will be as follows. Forearm kept in supine position. Forearm kept in supine position due to the paralysis of pronator teres or pronator quadratus. Raised flexion of weak due to paralysis of the flexion of the forearm except the medial half of the flexor digitorum profundus and flexor carpi ulnaris. Abduction of the wrist due to the paralysis of flexor carpi radialis and unstopped action of flexor carpi ulnaris and medial flexor digitorum profundus. No flexion is possible at the interphalangeal joints in the index and the middle fingers. Index and the middle fingers. Index and the middle fingers. These fingers lead to the loss of flexion of proximal interphalangeal and distal interphalangeal joints. The ring and the little fingers can be flexed. Position of the nerve supplied to the median half of the flexor digitorum profundus. The benediction of deformity is classified an ulnar claw hand, where the medial two digits are extended at MCP joints. Metacarpophalangeal joints are flexed at proximal interphalangeal joints and distal interphalangeal due to paralysis of the median lumbricals. Medial lumbricals. Interossei due to injury of the ulnar nerve because it resembles the hand gesture of a pope. Interossei due to ulnar nerves. Interossei because it resembles the hand gesture of a pope. Ulnar nerve because it resembles the hand gesture of a pope Christian priest giving his blessings of the papal benedictus. Historically, Saint Peter had suffered from ulnar claw hand. He continued to give his blessings on the followers by his stretched ulnar claw hand, hence the name Benedict hand. Loss of flexion of the terminal phalanx of the thumb due to the paralysis of flexor pollicis longus. Eighth thumb deformity. In the thinner eminence, the flattened and the thumb lies adducted due to the paralysis of muscle thinner eminence of the pronominal abductor pollicis respectively. Loss of sensation in the lateral half of the palm and lateral one digits, and also on the dorsal aspect of the same digits. Injury of the median nerve and the midform. Thumb deformity in which the thumb eminence is flattened and thumb lies on the detached and then lies adducted. Line is adducted due to paralysis of muscle. Now the injury of the median nerve and deformity. The injury of the median nerve at the midform results in pointing index finger. In the deformity, the injury of the middle nerve and the midforearm and pointing index finger due to the paralysis of the radial head of the injury of the medial head due to the paralysis of the radial head of the flexor digitorum superficialis. Flexor digitorum superficialis muscle. The contains tendons of the radial nerve flexor digitorum superficialis muscle. Digitorum superficialis muscle contains the tendon of the index finger. Flexor digitorum superficialis. The continuous tendon of index finger. Other signs and symptoms remains the other dose of the other and the distal and the wrist. The wrist, the median nerve, the palmar calcaneus nerve may be injured by the proximal to the flexor reticulum deep by the lacerated wounds, cut injury, and the example of suicidal cuts. The characteristic clinical features such as follows: eighth thumb deformity due to the paralysis of the eminence of the nerve, lesion of the part of the promontories and the figure. The median nerve is injured in the carpal tunnel due to the compression of the proceeding. The median nerve is injured in the capital tunnel due to the compression of the produce of the clinical condition called capital tunnel syndrome. The capital tunnel is formed by the anterior. Capital tunnel is formed. The median nerve is injured and the capital tunnel is formed by the flexor reticulum. The tunnel is tightly packed with 9 long flexor tendons. Fingers and thumb of the surrounding synovial seats and median nerve. The median nerve gets compressed in the tunnel due to the narrowing follow number of the pathological conditions such as tenosynovitis of the flexor tendon and myxedema tenosynovitis of the flexor tendon, idiopathic myxedema, deficiency of retention of fluid in pregnancy, flexure dislocation of the lunate bone, and osteoarthritis of the wrist. Characteristic clinical features of the carpal tunnel syndrome are as follows. Characteristic clinical features of the carpal tunnel syndrome are as follows. Feeling of burning pain in the pin head needles, long sensory digitation of the medial nerve, and especially at the night. There is no sensory loss over the linear eminence because skin over the linear eminence is supplied by the palmar cutaneous branch of the medial nerve, which passes superficial to the reticulum. Weakness of the thenar muscles. Eighth thumb deformity may occur at the left ventricle due to the paralysis of the thenar muscles. Phalanx test. In phalanx test, reflection both wrists against each other for 1 minute produces patient's syndrome. Phalanx test against each other for 1 minute produces the patient's symptoms. Positive tunnels sign. Phalanx test. So the characteristic features of the carpal tunnel syndrome are as follows. Feeling burning sensation syndrome, positive Fannel's test and Fannel's test reduced vascularity of the nerve. So Phalanx test and tunnels, this is done to the fracture of the median nerve. The signs of the symptoms of the carpal tunnel syndrome are dramatically relieved by the decomposition of the tunnel by giving a longitudinal insertion of the through the flexor reticulum. The signs of the syndrome of carpal tunnel syndrome is dramatically relieved by depressing the tunnel, by decompressing the tunnel by giving a longitudinal insertion through the flexor reticulum. Injury through the ulnar nerve. The ulnar nerve is commonly injured in two sides, elbow and the wrist. Injury of the elbow may occur due to fracture, dislocation of the medial epicondyle and cubital tunnel syndrome. So there is the carpal tunnel syndrome, cubital tunnel syndrome, also the arcade of the Frost. Injury of the ulnar tunnel. The injury of the ulnar tunnel of the elbow may occur due to fracture of the dislocated medial condyle, thickening of the fibrous loop of the cubital tunnel, and compression between the two heads of the flexor carpi ulnaris muscle, and valgus deformity of the elbow. Characteristic features of the as follows. Atrophy and flattening of the hypothalamic eminence. So atrophy and flattening of the hypothalamic eminence. Claw hand deformity, mane and greffe. Claw hand deformity and affecting ring fingers. The first phalanges and the face fingers extended the middle and the distal phalanges fixed. It is not a true claw hand. Loss of abduction of the phalanges. Extending the hyponear eminence and insertion space of the dorsum due to the atrophy of the interosseous muscle respectively. Loss of abduction of the thumb. Loss of sensation over the palmar and the dorsal surface of the radial third of the hand and the medial finger. Card test. For men, sign are positive. Injury of the ulnar nerve at wrist. The ulnar nerve at wrist joint due to superficial position of the ulnar nerve at the site makes it vulnerable to cuts and wounds. The superficial position of the ulnar nerve at the site makes it vulnerable to cuts and wounds. An injury of the ulnar nerve. So the cubital tunnel syndrome. Thickening of the fibrous loop of the cubital tunnel syndrome. Ulnar claw. Cubital tunnel syndrome. An injury of the ulnar nerve at the ulnar knees. Superficial position of the ulnar nerve makes the vulnerable to wounds. Compression of the Guyon's canal, the tunnel. Characteristic features. Deformity affecting the ring fingers and more profound ulnar because flexor digital profundus is paralyzed. Therefore, there is a marked of the distal interphalangeal joints. Atrophy of the flattening of the hypothalamic eminence. Loss of abduction and adduction of the fingers. Card test and forearm sign position. Card test for palmar interossei. Asks the patient to grab a piece of paper firmly between the side of the adjacent fingers. When the examining doctor pulls the card and the paper of the interossei are acting, the paper will be firmly held in position in some resistance on the felt on the withdraw. Card test of the palmar interossei. Foreman's signing test. This is the test done as the sensory paralysis of the abductor pollicis. Give the patient a thin book and Foreman's test and card test. Give the patient a thin book and grasp between thumb and the family. If the adductor pollicis are healthy, The thumbs will be strength and will reside at the source of the median nerve. Standard partial longest. Complete claw hand. Claw hand. Combined the lesions of the median and the ulnar nerve. Elbow causes through complete claw hand. Combination of the medial and the ulnar nerve. Combination of the medial and the ulnar nerve causes through claw hand. Claw hand. Combination of the two claw hand. Hyperextension of the wrist and metacarpopharyngeal joints. Flexion of the interphalangeal joints. Nerve. Radial nerve, median nerve and ulnar nerve. Radial nerve. Posterior cord of the brachial plexus. Median and lateral cord of the brachial plexus. Medial cord of the brachial plexus. So a median nerve is the median and the lateral cord of the brachial plexus. Ulnar nerve, median cord of the brachial plexus and posterior cord of the brachial plexus. So posterior and the median and lateral, and then median. T5 to T1, T5 to T1, T8 to T1 ulnar nerve. So radial nerve T5 to T1, median nerve T5 to T1. Motor innervation supplies all the muscles of the arm and the forearm, and muscles of the back of the forearm, supplies all the muscle front of the forearm except flexor carpi ulnaris and medial half of the flexor digitorum profundus. Flexor digitorum profundus. Muscle of the further thinner eminence or two lambricals. One half of the muscle. Sensory posterior surface of the dorsal. Posterior of the 2/3 of the digits. So hand and the lateral 2/3 of the digits. Dorsal aspect with lateral 2/3 of the digit. And hand of the lateral 2/3 including dorsal tips. The medial 2/3 of the fingers. Medial 2/3 of the fingers. Dorsal fingers and medial 2/3 of the fingers. Ulnar nerve. Medial 2/3 of fingers. Wrist drop, ape thumb deformity and ulnar claw hand. So ape thumb deformity, ulnar claw hand and wrist drop. The features are three principal nerves, radial, medial and ulnar, of the upper summarized in table 13.1. The autonomous sensory area is the part of the dermentum that has no overlap from the adjacent nerves. The autonomous sensory areas of the hand are used to test the integrity of the nerves, supplying the ulnar, radial and radial. The autonomous sensory areas of the radial, medial, ulnar nerves are as shown. The segment of the innervation of the muscles of the upper limb. The knowledge of the segment of the values and the importance of digital of the injuries to the nerves of the spiral cord from which they arise. The segmental innervation of the muscle of the upper limb given on table 13.3. There are based on the clinical data observed by Klocher. So segmental innervations of the muscles of the upper limb. Segmental muscular innervations. So muscular innervated, deltoid, and then muscular deltoid supraspinatus. Pectoralis major, cystic external flexor of the wrist, long flexor of the finger, and a small muscle of the hand. The largest nerve of the radial nerve. The loss of sensory of the radial nerve, thumb and the other fingers. Carpal tunnel, most common site of injury. Carpal tunnel, most peripheral neuropathy of the upper limb. Carpal tunnel syndrome. Most of the carpal tunnel syndrome. Tenosynovitis of flexor tendons. Tenosynovitis. The commonest site of the nerve injury, at the elbow where the lies behind the medial epicondyle. Elbow. Relief pressure, compression of the elbow. Spinal groove, median nerve. Leber's nerve is the medial nerve. Musician's nerve is the ulnar nerve. Leber's nerve is the median nerve. Leber's nerve is the ulnar nerve. Spiral groove, eye of the hand of the peripheral, medial nerve of the hand. Here, carpal tunnel syndrome. The carpal tunnel is bounded by posterior carpal bones, median nerve, and then due to accumulation of tissue fluid and the pump of the action of the muscular right. Of compression test, blood pressure and arm pressure, pain and paraesthesia of the aggregated. So the ulnar nerve. The ulnar nerve arises from the axilla from the medial cord of the brachial plexus. From T8 to T1, it receives the contribution from the ventral ramus of the T7. Also contributes the ventral ramus of the T7. The T7 fibers of the ulnar nerve supply the flexor carpi ulnaris. So T7, flexor carpi ulnaris. Flexor carpi ulnaris. In the axilla, the nerve lies median to the third part of the axillary artery. In the axilla, the nerve lies median to the third part of the axillary artery. In the median, in the axilla, the nerve lies median to the third part of the axillary artery between the axilla and the vein. In the axilla, it lies medial to the third part of the axillary artery. So the radial nerve is posterior to the third part, it is medial to the third part. Medial to third part of the arterial artery, enters the arm and the main neurovascular bundle and runs distally along the medial side of the brachial artery, up to the mid-arm level of the insertion of the coracobrachialis. The groove covers in the tunnel called cubital tunnel. So the radial tunnel and the cubital tunnel in the medial epicondyle, the arm, posterior compartment of the arm, and coracobrachialis and the middle arm at a level of the insertion of the coracobrachialis, where it pierces the median intermuscular septum to enter into the posterior compartment of the arm, turn towards the back of the medial epicondyle, and cubital tunnel by fibrous extension between the medial epicondyle and olecranon process. The ulnar nerve crosses the ulnar lateral ligament on the floor of the tunnel. Along the ulnar collateral ligament of the tunnel, the ulnar nerve does not give any branches to the axilla and the arm. The nerves enter the coracobrachialis, the posterior compartment by piercing the fossa and cubital tunnel, and the ulnar nerve does not give it from the axilla and the arm. The nerve enters the forearm by passing between the two heads of the flexor carpi ulnaris. In the upper third of the forearm, it runs along the ventrically downwards in the index finger into the downwards of the flexor ulnaris. Upper third of the ulnar is almost vertically downwards for carpi ulnaris. In the lower tooth of the forearm, it becomes superficial and lateral to the flexor carpi ulnaris. The part course in ulnar nerve and ulnar disc together. So in this part of the course, the ulnar nerve and the artery descends together. Artery being the lateral side of the nerve. In the forearm, it gives off the branches. Proximal forearm gives musculocutaneous branch. Proximal to the forearm gives musculocutaneous branch and flexor carpi ulnaris. In the forearm, it gives off the following branches: the proximal forearm, the muscular branch to flexor carpi ulnaris, medial half of the flexor digitorum profundus, and the mid forearm gives the palmar cutaneous branch. Palmar cutaneous branch enters the profundum of the flexor reticulum to provide sensory nervation skin of the hypothelial eminence. The distal forearm above 5 cm proximal to the wrist gives of the dorsal cutaneous branch, which provides sensory innervation to the skin of the medial third of the dorsum and the hand of the radial 1/3 of the finger. The ulnar nerve enters the palm by passing superficial to the flexor reticulum, lying just lateral to the pisiform. Here the ulnar nerve is covered by a facial band over capital ligament. The space under the facial band is termed ulnar tunnel. The face are volars. The ulnar nerve is covered by the facial band, volars carpal ligament. The space under the facial known as ulnar tunnel. Just distal to the pisiform, the ulnar nerves gives into the terminal superficial and deep branches. The superficial terminal branch supplies the palmaris brevis. The superficial terminal branch provides the palmaris brevis and sensory innervation of the skin of the 1/3 of the finger, half of the finger. The deep terminal branch enters the Guyon's canal. Pisohamet channel. The Guyon's canal. Pisohamet tunnel. Guyon's canal. Deep under the pisohamet ligament. Under the pisohamet extended from the border. Pisohamet border and the hook. The hametal laterally within the of the palmar artery and arch, and with the subcutaneous erection of the pollice which it supplies. The deep branch of the ulnar nerve is purely motor. It supplies this. purely motor and supplies the intrinsic muscles of the hand. Purely motor and the intrinsic muscles of the hand, except the muscles of the thenar eminence, the first two lumbricals. The ulnar nerve is most often referred as the nerve of the fine movements, musician nerves, because it innervates the most of the intrinsic muscles and of the hand and are involved in the fine, intricate hand movements as required by musicians while playing musical instruments. The ulnar nerve behind the radial epicondyle of the humerus is termed funny bone because the medial nerve of the elbow hits the surface, tingling occurs sensation of the side of the hand. The motor and the sensory distribution of the ulnar nerve is given on the box below. Median nerve. The median nerve arises from the brachial plexus, axillary by the two roots, lateral and the medial. The lateral root C5, C6, and C7 arises from the lateral cord of the brachial plexus, and the medial root arises from the medial cord of the brachial plexus. The medial root crosses in front of the third part of the axillary artery to unite with the lateral root of the lateral root in a Y-shaped manner, while the front or on the lateral side of the artery to form the medial nerve. So the root value of the medial nerve is C5, C6, C7, C8, T1. In the axillary, the median nerve lies on the lateral side of the third part. On the median nerve lies on the lateral side of the third part of the axillary, so lateral side. Posterior side, lateral side, medial side. Enters the artery and then lower border of the teres minor border. In the arm, initially the medial nerve lies lateral to the brachial artery, and then crosses in front of the artery from the lateral to the medial side of the artery of the mid-humerus. After crossing, it runs downward under the cubital fossa. In the cubital fossa, the median nerve lies median to the brachial artery of the tendon of the biceps brachii, and here it is covered by the bicipital aponeurosis, which separates it from the medial cubital vein. Bicipital aponeurosis by the median cubital median cubital vein. In the cubital fossa, it gives the muscular branch on the medial side to supply all the superficial muscles of the forearm, flexor carpi radialis, flexor carpi radialis, flexor carpi radialis. So then the cubital fossa gives muscular branch on the side of the superficial muscle. The median nerve leaves the cubital fossa by passing between the anterior flexor carpi and the superficial plexus, muscular branch of medial nerve. All the superficial plexures of the mid forearm and carpi radialis, palmaris longus, and flexor digitorum, carpi ulnaris, median nerve of the flexor carpi ulnaris, superficial flexor muscles, flexor pronator teres, and then palmaris longus and digitorum superficialis. Main nerves leave the cubital fossa passing. The main nerve leaves the cubital fossa passing between the two heads of the pronator teres. At this point gives off anterior interosseous nerve. So its point gives off the anterior interosseous nerve. The anterior interosseous nerve is a purely motor and supplies 2/3 of the muscles and supplies 2/3 of the deep muscles. Interosseous nerve. Flexor pollicis longus, flexor digitorum profundus, lateral half of the flexor pollicis profundus, and pronator quadratus. In the forearm, the median nerve passes the median nerve downward behind the tendon of the arch bridge behind the head of the flexor digitorum superficialis and runs deep to the flexor digitorum superficialis, about 5 cm. Flexor digitorum superficialis 5 cm proximal to the flexor reticulum. The median nerve emerges from the lateral side of the flexor digitorum superficialis and becomes superficial, lying lateral to the lateral tendon of flexor digitorum superficialis. Flexor digitorum posterior tendon of the palmaris longus and posterior to the tendon of palmaris longus. Digitorum superficialis lateral. In the mid forearm, it gives the muscular branch of the head of the flexor digitorum superficialis and gives off the rise to tendon of the index finger. The superficial which gives tendon of the index finger. Before entering the carpal tunnel, it gives off the pulpocutaneous branch of the reticulum supply the skin over the eminence of the palm. The median nerve enters the median by passing through the carpal tunnel, which lies deep in the flexor reticulum. In the palm, medial nerve is distributed at the border of the reticulum and divides into lateral and medial divisions. Lateral divisions give a recurrent branch. Lateral divisions give a recurrent branch. Lateral division, recurrent branch, which curves up, supplying the nerve of the thinner muscles, and exterior muscles, except the deep branch of the flexor pollicis brevis. Flexor pollicis brevis. Thinner muscles, flexor pollicis brevis. Flexor pollicis brevis. And a deep branch of the flexor pollicis muscle, except the deep branch of the brevis, in them divides into the three palmar diseases of the median division of the two palmar disease of the nerve. The median division gives off two palmar disease, also gives palmar disease of the nerve. Sensory innervation of the skin of the palmar aspect of the lateral third of the including nail beds and the skin of the medial phalanges. First and second labricals. The median nerve is also termed Leber's nerve because required labors, dragging around and lifting weight, etc., are performed by the flexor forearm of the median nerve. It is also termed eye of the hand or peripheral eye. Because it provides sensory innervations of the pulp of the thumb and the index finger, used to see thickness and texture of the cloth, and are also used for perforating fine movements. Examples: buttoning a coat. Overview of the motor sensor distributions of the medial nerve and summarized in table box below. Specific learning objectives. After studying this, the student should be able to describe origin, course, distribution of the radial nerve, median nerve, and ulnar nerve, give the anatomical basis of cerebral night paralysis or the wrist drop, right nerves and axillary nerve, musculocutaneous nerve, and ulnar nerve of the hand. Give anatomical basis of the extensor elbow possible of the radial nerve. Give the anatomical basis of extension of the elbow. How is possible on the radial nerve, spinal groove, carpal tunnel syndrome, and complete claw hand. Both ulnar and medial nerve. The nerve supply of the upper limb is provided by the brachial plexus. The five major limbs are axillary nerve, musculocutaneous nerve, radial nerve, medial nerve, and ulnar nerve. The study of the five major nerves of the upper limb should be studied thoroughly and carefully because of their frequent involvement in various injuries and peripheral neuropathies. Axillary nerve arises from the posterior cord of the brachial plexus. It provides motor innervations to deltoid and teres minor muscles. And sends innervation to the shoulder joint and the skin over the lower lateral part of the shoulder. Regimental bridge area, lower lateral part of the shoulder. The brachial of the axillary nerve are shown on fourth table. Musculocutaneous arises from the lateral cord of the brachial plexus. It provides motor innervations to the muscles. Musculocutaneous nerves. Front of the arm and sensory innervation of the skin is lateral aspect of the forearm. The overview of the motor lateral cord of the brachial plexus. So this is also posterior cord. So the axillary nerve is posterior cord. Axillary nerve is posterior cord. The musculocutaneous is lateral cord. The medial is ulnar, and the mediolateral is medial, and the radial is also lateral. Nerve of the innervation lateral aspect of forearm. Overview of the motor sensory innervation muscular nerve given page below. Motors of the biceps brachii, coracoid brachialis, and brachialis. Cutaneous sensory nerves, lateral aspect of the forearm. Musculocutaneous innervations of the arm is purely motor, while the forearm is purely sensory. Musculocutaneous innervation of the arm is purely motor, where the forearm is purely sensory. Arm is purely motor, but the forearm is purely sensory. Radial nerve. The radial nerve is the continuation of the posterior cord of the brachial plexus in the axilla, the largest nerve of the upper limb and the largest branch of the brachial plexus. The largest nerve of the upper limb and the largest of the brachial plexus. It carries the fibers from root C5. It carries fibers from all the roots, root 5, 6, 7, 8, and T1 of the brachial plexus. T1 fiber is not constant. In the axilla, the radial nerve lies posterior to the third part of the axillary artery, anterior and anterior to the muscles, the posterior wall of the axilla. In the axilla, it gives off the following three branches: posterior cutaneous nerve of the arm, sensory innervations of the skin and back of the arm by the elbow. Is it posterior of the third part of the axillary artery and anterior of the axilla gives off the following three branches: the posterior cutaneous nerve, posterior cutaneous nerve, sensory innervation, and nerve to the long head of the triceps, medial head of the triceps, and the axilla, medial head of the triceps. On the arm, the radial nerve enters into the arm on the lower border of the teres minor. Enters the arm on the lower border of the teres major. Lower border of the teres major. It passes between the long and the medial heads of the triceps. Between the long and the medial head of the triceps, enter the lower triangular space through which the reaches the spiral groove along the profunda brachii artery, with the profunda brachii artery. Spiral groove which reaches the spiral groove of the profunda brachii artery. Radial nerve is a spiral groove lies at the direct contact with the humerus. Boundaries of the spiral: anteriorly 1/3 of the shaft of the humerus, anteriorly 1/3 of the humerus, origin of the lateral aspect of the triceps on the medial head of the triceps, posteriorly fibers lateral to the long head of the triceps. In the spiral groove, it gives off the following 5 branches: lower lateral cutaneous nerve of the arm, posterior cutaneous nerve of the lower lateral artery. The spiral groove gives off the following branches: lower lateral cutaneous nerve, posterior cutaneous nerve, lower lateral cutaneous nerve, posterior cutaneous of the forearm, middle of the shaft, and nerves of the lateral head of the triceps, medial of the triceps, and also anconus. Middle of the triceps, head of the triceps, middle of the triceps, and also anconus. At the lower end of the spiral groove, the radial nerve pierces the lateral intermuscular septum of the arm and enters the interior compartment of the arm. At the lower, the radial nerve. So now the ulnar nerve pierces the anterior, the posterior. The medial nerve crosses the brachial artery to go into the anterior side. Lower by the intermuscular septum cubital by medial nerve of the triceps. Then the lower triceps anconus. At the lower end, the spiral groove, the radial nerve pierces the lateral intermuscular septum of the arm and enters the anterior compartment of the arm. Here it first descends between the brachialis and the brachioradialis, and then between the brachial extensor carpi radialis longus before entering the cubital fossa. In the anterior compartment of the arm above the lateral epicondyle, it gives off the following branches: nerves of the brachioradialis, and nerves to the carpi radialis longus. On the forearm, the radial nerve enters in the forearm by passing to the anterior epicondyle and anterior lateral epicondyle. Entering to the anterior lateral epicondyle. At the level of the lateral epicondyle, the humerus, that terminates the dividing into superficial and deep branches of the lateral. The deep branch is motor. And the cubital fossa supplies the two muscles, namely extensor carpi radialis brevis and supinator. If the cubital fossa, it supplies the two muscles, namely cubital extensor carpi radialis brevis, extensor carpi radialis brevis, and supinator. After supplying the two muscles passing through the subcutaneous supinator, so the extensor carpi radialis brevis, deep branch of the cubital fossa, supplies the two muscles. After entering the muscles through the posterior compartment of the forearm, posterior intercostal supplies all the supplying the muscles through the subcutaneous, through the substance of supinator enters through the substance of the supinator. Posterior intercostal nerve supplies all the extensor muscles of the forearm, gives particular branches of the distal ulnar region. The superficial branch of the radial nerve is sensory. Motor nerve is sensory. It runs downward over the supinator, pronator teres. Supinator and pronator teres. And the medial nerve. And pronator flaccid superficie deep to the brachialis, about one-third of the way to the forearm. It passes posteriorly, emerging from the under the tendon of the brachioradialis, similar to the styloid process. The radial and then passes over the tendon of the anatomical snubbones, superficial branch, where the terminates in the cutaneous branch, which provides sensory nervation of the skin in the lateral part of the dorsal hand and dorsal part of the lateral one, the distal proximal nail undulates, superficial branch. Electrocardiogram. Define ECG. Draw and label a normal tracing of ECG. Write down the significant different ways of ECG. Write a label the normal ECG with the interpretation. Trace and label a typical ECG. What are the information we get from ECG? Interrupt the different waves and intervals of normal ECG. Short, give principles of ECG. ECG electrocardiogram. ECG is the graphical representation of electrical activity of heart, which is recorded from the skin by placing a suitable electrode on the surface of the body with the help of electrocardiograph. Principle of ECG. The body fluids are good conductor because the body is a volume conductor. Heart is surrounded by electrolyte solution. As a result, any electrical changes occur in the heart during cardiac cycle are being spread through the electrolyte solution to the surface of the body. That's why these changes can be recorded by placing suitable electrodes on certain reference points on the surface of the body. This is the principle of ECG, a normal ECG tracing. Interpretation of ECG is composed of both depolarization and repolarization. ECG waves, duration, features, events in the heart during wave. Wave, P wave, duration 0.1 second. Features, it is the first upward deflation. It is small and constant. Events in the heart during wave. Atrial depolarization. So in the P wave there is atrial depolarization. Q wave, it is a downward deflection. It is small, negative and inconspicuous. Septal depolarization. So the P wave is atrial depolarization. Q wave, septal depolarization. R wave, apical left ventricular depolarization. S wave, posterior basal left ventricular depolarization. Left ventricular depolarization. T wave, ventricular repolarization. So T wave is ventricular repolarization. It is the first upward deflection of a small and constant. It is downward deflected. It is a small, negative and often conspicuous. It is an upward deflection of the most constant and conspicuous wave having the tallest amplitude. It is a downward deflection. It is an upward deflection. ECG intervals. P R interval. Normal duration 0.18. Events in the heart during interval. Atrial depolarization and conduction through AV node. Atrial depolarization through AV node. Atrial depolarization and conduction through AV node. QRS complex. QRS complex. Ventricular depolarization and atrial repolarization. So ventricular depolarization intervals. Ventricular depolarization and conduction through AV node. And conduction through AV node, atrioventricular node. Ventricular depolarization and atrial repolarization. QT. It is ventricular depolarization plus ventricular repolarization. Ventricular depolarization are ventricular Q and T. Ventricular repolarization ST. It is ventricular repolarization. What are indications importance of ECG? Indications importance of ECG. The ECG is used to assess cardiac rhythm and conduction. It provides information about chamber size and the main test used to assess the myocardial ischemia and infarction. Physiological. A normal heart rate can be counted. Condition of the heart can be detected. Condition of the heart can be detected. Physiological. Normal heart rate can be counted. Condition of the heart can be detected. Clinical. ECG gives variable information, diagnostic and prognostic, about cardiac arrhythmia and conduction defeat, myocardial infarction, atrial ventricular hypertrophy, and electrolyte imbalance. So, cardiac arrhythmias, conduction defeat, myocardial infarction, atrial ventricular hypertrophy, and electrical imbalance. Hypertrophy means an increase in the size of the cell. Hyperplasia means the increase of number of cells. What is dropped beat? In second degree heart block, not all the atrial impulses reach the ventricle. At times, every second beat of the ventricle is dropped. In second degree heart block, not all the atrial impulses reach the ventricle. At second degree heart block, not all the atrial impulses reach the at second degree heart block, not all the atrial impulses reach the ventricle. In times, every second beat of the ventricle is dropped, so that 2:1 rhythm develops in the heart, with the beating twice for a single beat of the ventricles. With the beating twice for the ventricle. Sometimes only rhythms such as 3:2 or 3:1 also develop. This drop of beat in the ventricle is known as dropped beats. Mention the effect of hyperkalemia and second degree heart block on ECG. What the changes do you expect in the ECG hyperkalemia? Hyperkalemia is a very dangerous and potentially lethal condition because of its effects on the heart. As the plasma potassium level rises, the first changes in the ECG is the appearance of tall peaked T waves. Tall peaked T waves. Manifestation of altered repolarization at higher potassium levels. Paralysis of atrial and prolongation of the QRS complex occurs. Ventricular arrhythmias can develop. The resting membrane potential of the muscle fibers decreases as the extracellular potassium concentrations increase. The fibers eventually become unexcitable and the heart stops diastole. Peaked T waves and heart diastoles. So the ECG changes are appearance of tall peak T waves, wide QRS complex, absent P waves. Normal tracing. Plasma potassium 4 to 5.5 milliequivalent per liter. PR interval 0.16 second. QRS interval 0.06 second. QT interval 0.4 second. Normal and assumed heart rate is 60. High normal tracing. Hyperkalemia. Plasma potassium is minus 0.7 milliequivalent per liter. The PR and the QRS intervals are within normal limits. Very tall, slender peak T waves are now present. Hyperkalemia. Plasma potassium 8.5 milliequivalent per liter. There is no evidence of atrial activity. The QRS complex is broad and slanted over QRS interval has widened 0.2 seconds. The T waves remain tall and slender. Further elevation of the plasma potassium level may result in ventricular tachycardia or ventricular fibrillation. Effects of hypokalemia. Long QT interval, prolonged PR interval, ST depression, flattened T wave and T innervations, prominent U wave. Hyperkalemia and hypokalemia where the potassium is plus minus 2.3.5 milliequivalent per liter and plasma or plus minus 2.5 milliequivalent per liter. Effects of second degree heart block on ECG. There will be an atrial P wave but no QRST wave, and it is said that there are dropped beats on the ventricles. What is a PR interval? What are the informations we get from PR interval? The time between the beginning of the P wave and the beginning of the QRS complex is called PR interval. PR interval indicates the atrial depolarization and conduction through AV node. Duration of a more PR interval is 0.18 second or 0.16 second. Importance of PR interval. The PR interval decreases in length with faster heartbeat and increases with slower heartbeat. The prolonged PR interval indicates that the conduction time from the atrial ventricle is increased. PR interval is a heart beating at a normal rate. Indicates first degree with complete heart block. PR interval from 0.25 second to 0.41 second indicates second degree of heart block. Shorter PR interval indicates that the impulse arises from AV node. What are the information we get from PR intervals? It is the distance between the two recessive R waves. Importance. The rate of heartbeat can be determined easily from an ECG because the heart rate is reciprocal of the time interval between two successive heartbeats, the RR interval. If the interval between two beats as estimated from the time calibration lines in 1 second, the heart rate is 60 beats per minute. The normal interval between the two successive QRS complexes in an adult is about 0.83 seconds, which is a heart rate of 60 or 0.83 times per minute or 72 beats per minute. Nice to know. The standard 12 lead ECG bipolar leads. First lead right atrium and left arm, right arm and left arm. Lead second right arm and left leg, and lead 3 left arm and left leg. This is bipolar limb leads. Augmented unipolar limb leads. AVR right arm, AVL left arm, AVF left foot, unipolar chest leads. Precordial leads. V1 fourth intercostal space at the right border of the sternum. V2 fourth intercostal space at the right border of the sternum. M2 midpoint between V2 and V4. V4 fourth intercostal space at the left midclavicular line. V5 fourth intercostal space at the left anterior axillary line. V5 fifth intercostal space at the left mid-axillary line. V1 and V2 reflects the right ventricle. V3 and V4 reflects the interventricular septum. V6 and V7 reflects the left ventricle. Short note: a Troven's triangle. The first step for circulation of mean QRS vector or equilateral triangle is drawn on a plain paper. This equilateral triangle represents an Troven's triangle. It is an imaginary equilateral triangle on the chest with the points representing the standard bipolar limb leads. On the right and the left arm and the left leg leads. On the right arm, right and left arm, and on the left leg. This equilateral triangle represents the Troven's triangle. It is an imaginary equilateral triangle on the chest with the points representing the standard bipolar limb leads on the right and the left arm and the left leg. The heart is presumed to lie on the center of the Troven's triangle. From the midpoint of each side, the perpendicular line is drawn towards the center. The meeting point of the perpendicular lines represent the center of electrical activity in the heart. On each side of a triangle, the amplitudes of QRS complex is plotted from the midpoint towards the positive point of the lead. For example, the midpoint of QRS complex is lead is 1 to 10 millimeter, and in the lead it is 2. It is 17 nanometer. In the triangle, upper side represents lead 1, and in this lead the left is positive. So a 10 millimeter line is drawn on the upside from the midpoint towards the left positive. This 10 millimeter decreases along the axis of the lead 1 is called projected vector for lead 1. In the same way, the projected vector for lead 2 is drawn on the right side of the triangle. From the positive end of the right project vector, another perpendicular line is drawn towards the interior of the triangle. Now a arrow is drawn between the center of the electrical activity and the meeting point of the perpendicular lines from the positive end of the projected vectors. This arrow shows the vector. The narrow head is drawn towards the positive end, for example, for I downwards. The degree and the length of the narrow are measured. The degree denotes the direction of the vector and the length denotes magnitude. What is Anthrop's law? In the ECG, for the standard limb leads, the potential of any waves or complex in lead 2 is equal to the sum of the potential of lead 1 and 3. When RR interval is 15 millimeter in ECG tracing, what will be the heart rate? So heart rate 1500, a small square between R and RR interval 15. So 1500 by 15 is 100. What is heart rate? The number of beats per minute is called a heart rate. Heart rate in different ages: 40 to 100, 40 to 100, 70, 140 to 150, fetus 140 to 150, 130, 140, newborn, and 80 to 121, 75 to 80, less than 50, less than 50, 150, 150, average 135. List the factors affecting heart rate. Factors affecting heart rate: decreased activity of the atrial bioreceptors, decreased activity of the decreased activity of the atrial bioreceptors, increased activity of the atrial bioreceptors, and increased activity of the decreased activity of the vessels, and increased activity of the stress receptors. Decreased activity of the atrial stress receptors. Increased activity, decreased activity. Inspiration, excitement, anger. Increased activity of atrial receptors, expiration, fear, grief, stimulation of pain fiber and terminal nerve. Most painful stimuli: hypoxia, exercise, thyroid hormones, fever. Increased intracranial pressure. Intrinsic rate of heart 110 beats per minute. Maximum effective rate 180 beats per minute. What do you mean by most effective heart rate? Cardiac output increases with the increase of heart rate, and cardiac output maximum when the heart rate is 180 beats per minute. Further increase of heart rate causes decreased cardiac output. Decreased cardiac output. Maximum heart rate. Reflex that regulate heart rate. Decreases heart rate. Baroreceptor decreases heart rate. Chemoreceptor decreases heart rate. Decreases heart rate. Chemoreceptor decreases heart rate. Brain reflex increases heart rate. Cushing reflex decreases heart rate. So decrease heart rate, increase heart rate, and decrease heart rate. Cushing effect decrease heart rate, decrease heart rate, but the brain reflex increase heart rate. Baroreceptor reflex. Atrial pressure, atrial baroreceptor. Atrial pressure বাড়লে atrial baroreceptor stimulate হয়, signals the medulla advance cardioinhibitory center and parasympathetic diagnostic heart rate কমে. atrial pressure বাড়লে heart rate কমে. Baroreceptor medullary glossopharyngeal vagus nerve. Medullary glossopharyngeal and vagus nerve. Yes, chemoreceptor reflex. Atrial pressure. Chemoreceptor reflex. Atrial pressure. Blood flow to the chemoreceptor in the carotid and aortic bodies. Chemoreflex, atrial pressure decrease হলে blood flow decrease, ফলে oxygen decrease হয়, chemoreceptor decrease. Increase heart rate, heart rate, heart rate. Increase heart rate, increase heart rate. তোদের কোনটা 2 আর 6? 2 আর 6? পাঁচটা কেউ একসাথে নেয়? আমার দুইটা 2 আর 6। Decrease and chemoreceptor decrease heart rate bradycardia, decrease heart rate bradycardia, chemoreceptor decrease heart rate. तो पूरा काट दे देखो तो देखना decrease heart rate chemoreceptor bradycardia are bend reflex when the initial heart rate is low, so heart rate increases. রিসেপ্টর সবগুলো হার্ট রেটকে কমায়, তবে ব্রেইন ব্রিজ রিফ্লেক্স হার্ট রেটকে বাড়ায়। কুশিং রিফ্লেক্স শুধুমাত্র ব্রেইন ব্রিজ রিফ্লেক্স হার্ট রেটকে বাড়ায়। কীভাবে বাড়ায়? when the initial heart rate is low, blood stimulates the atria and the heart and increases the atrial pressure. The blood accumulates in the atrial venous pressure and stimulates the nerve ending of the walls of the atrium and the vena cava. Venous pressure increase হয়, afferent fibers ascend in the vagus and the medulla oblongata. Afferent fibers terminate into the nucleus of tractus solitarius. The terminate into the nucleus of tractus solitarius. Connector neutrons inhibit the dorsal nucleus of the vagus, parasympathetic. Connector neurons inhibit the dorsal nucleus of the vagus, parasympathetic. Inhibits the parasympathetic fiber, vagus parasympathetic. Inhibits the vagus parasympathetic activity, and reticulospinal fibers stimulate the thoracic symptoms, outflow of the heart. Reticulospinal fibers. So when the Cushing reflex affects by intracranial pressure, blood flow to the medulla, pressure, vasomotor center, and then semi-atrial pressure, improved blood flow, and baroreceptor is stimulated and decreased heart rate. So this decreased systemic arterial pressure with reflex bradycardia is called Cushing effect because it is described by Cushing. Short note, Cushing reaction. It is a special type of central nervous system ischemic response that results from increased pressure CF around the brain, cerebrospinal fluid. It is a special type of central nervous system ischemic response. Ischemic pressure resulting from the cerebrospinal fluid around the brain and the cranial cord. Cerebrospinal fluid resulting from the cerebrospinal fluid. Cerebrospinal fluid. When intracranial pressure is increased, the blood supply of the brain is decreased and the reflex increases. When the intracranial pressure increases, the blood supply of the brain is decreased and the reflex increases systemic arterial pressure. Cushing reaction. When the intraatrial pressure is increased, the blood supply of the brain is decreased. This reflex causes systemic arterial pressure to restore. Increase the intraatrial pressure. Intracranial pressure increased. The reflex causes systemic arterial pressure for Cushing reflex. Importance of Cushing reflex. Cushing reflex helps in protect the vital center of the brain. The Cushing reflex helps in protect the vital center of the brain from loss of nutrition, even if the intracranial pressure is high enough to compress the cerebral arteries. Loss of nutrition. If ever the intracranial pressure rises high enough to compress the cerebral artery. Brain beach reflex. The straight right atrium innervates. The right atrium innervates the nervous reflex of the brain beach reflex. This effect is described in the brain beach reflex. Increases heart rate. Tractus solitarius. What do you mean tachycardia? The term tachycardia means first heart rate, usually defined as the adult person as a faster than 100 beats per minute. Exercise, emotion. Pathological can mean fever, 1 degree Fahrenheit causes 10 heartbeat, hemorrhagic shock, also anemia, heart failure, toxic control of the heart, weakness of the myocardium, also drugs and eochroma, newborn child, digestive food, pregnancy, etc. And now what is arrhythmia? An arrhythmia is a disturbance of the electrical activity of the heart. Arrhythmia means abnormal rhythm of the heart. For instance, sometimes the beat of the heart is not coordinate with the beat of the ventricles, so that the atria no longer functions as a primer pumps of the ventricles. Cause of arrhythmia: abnormal arithmetic of the pacemaker, tachycardia, bradycardia, and sinus arrhythmia. Shift of the pacemaker from the sinus to the another plane of the heart. Cause of arrhythmia: abnormal arrhythmia of the heart. Then is a disturbance of the electrical active heart. Arrhythmia is simply the disturbance of tractus solitarius. Tractus is basically the disturbance of the electrical activity of the heart. Basically the disturbance of electrical activity of the heart. Disturbance of electrical activity of the heart. Disturbance of electrical activity of the heart. Basically the disturbance of electrical activity of the heart. Some abnormalities of the cardiac arrhythmia: ventricular fibrillation, atrial ventricular fibrillation. গেছে
30 জন 40 জন
তোদের ওখান থেকে মনে হয় 2 জন গেছে মনে হয়। আচ্ছা একজন গেছে মারুফ। ventricular fibrillation, atrial flutters, cardiac arrest. What is arrhythmia? Cardiac irregularities caused by the increased heart rate during inspiration and decreased heart rate during expiration. Sinus cardiac irregulations characterized by increased heart rate during inspiration, decreased heart rate during expiration. This arrhythmia has no clinical significance except in older patients. Sinus arrhythmia, when they are characterized by the increased heart rate during inspiration and decreased heart rate during expiration. Arrhythmia is a normal phenomenon due to primary functions of the parasympathetic output of the heart. It increases when the heart rate decreases during expiration. Injuries of the upper limb. The human upper limb is meant for prehension, that is, grasping, and not for locomotion and transmission of weight. So, prehension. The mechanism of grasping is provided by the hand with 4 fingers. Therefore, right build there is bones are similar and weaker. Joints are smaller and less stable. Hence, it is more prone to injuries and dislocations and fractures. Dislocations. The common dislocations of the upper limb are the dislocations of the shoulder joint, most commonly dislocated joint of the body, elbow joint, and lunate bone of the hand. Fractures. The common fractures in the upper limb are the fractures of clavicle. Most commonly fractured bone is in the body. So the most common fracture of the upper limb are the fractures of the clavicle. Most commonly fractured bone of the body: humerus, radius, and scaphoid. The scaphoid is the most commonly fractured bone of the hand. Clinical correlation. Fracture of the clavicle. The clavicle is one of the most commonly fractured bones of the body. It commonly fractures at the junction of the lateral 1/3 and medial 2/3 due to the fall on the outstretched hand or shoulder. So lateral 1/3 and medial 2/3 commonly occurs in males in the age of 15 to 25 years. When fracture occurs, the lateral fragment is displaced downward by the weight of the upper limb because the trapezius alone is unable to support the weight of the upper limb. In addition, the lateral fragment is drawn medially by shoulder adductors, namely the teres major. The median fragment is slightly elevated by the sternocleidomastoid muscle. Medially elevated by the sternocleidomastoid muscle. The characteristic clinical picture of the patient with the fractured clavicle is that of a man or woman supporting his sagging upper limb with the opposite hand. The fractures at the junction of the lateral 1/3 and the medial 2/3 occurs because it is the weakest side due to its curves at the clavicle meet at this site. Transmission of forces from the scapula to the clavicle at this site through the coracoclavicular ligament. Transmission of the forces from the scapula to the clavicle at this site through the coracoclavicular ligament. Recently, clinicians have found that commonest site of the fractured clavicle is the middle one-third, 80% at the thinnest part of the deltoid of the muscular and the ligamental attachments. It occurs due to fall on the lateral shoulder. The clavicle is absent in animals in which the upper limbs are used only for walking and weight transmission and not for grasping, such as horse. Clinical correlation: congenital anomalies, clavicle diastasis and cleidocranial diastasis. Clinical diastasis is a clinical condition in which the median and lateral parts of the clavicle remain separated due to non-union of two primary centers of ossification. Diastasis is a clinical condition in which the medial and the lateral parts of the clavicle remain separated due to the non-union of the two primary centers of ossification. Cleidocranial dysostosis. It is a clinical condition characterized by the partial or complete absence of clavicle due to defective intramembranous ossification. Intramuscular ossification. It is often associated with defective ossification of the skull and bones. In this condition, two shoulders can be approximated anteriorly in front of the chest. So it is a clinical condition characterized by the partial or the complete absence of clavicle due to defective intramembranous ossification. Intramembranous ossification. Two shoulders can be approximately anteriorly in front of the chest. Two shoulders can be approximated anteriorly in front of the chest when the cleidocranial diastasis occurs. Clavicular dysostosis, cleidocranial dysostosis. Sprangel's deformity of the scapula, congenital high scapula. Sprangel's deformity. The scapula develops in the neck region during IUL, intrauterine life, and then migrates downward as an adult person. The upper part of the back of the chest failure to descend leads to Sprangel's deformity of the scapula. Clinical correlation. Nerves directly related to the humerus. There are three nerves. Axillary, radial and ulnar are closely related to the back of the humerus. Axillary nerves around the cervical neck. Radial nerves in the radial spiral groove and ulnar nerve behind the medial epicondyle. Mnemonic. Anti reacts unnecessarily. Axillary, radial and ulnar. Therefore, the nerves are often involved in the fracture of the humerus at the common sites. Common sites of fracture of the humerus, there are surgical neck, midshaft and supracondylar region. Fracture of the surgical neck of the humerus is the most frequently fractured site of humerus, especially in elderly over 65 years due to osteoporosis. Midshaft fracture of the humerus. It occurs in 3% of cases due to fall or high energy injuries, motor vehicle collisions, etc. In older people, it occurs due to the weakening of bones from osteoporosis. Supracondylar fracture of the humerus. It is caused by the fall on the outstretched hand and commonly occurs at young age. Clinically, it presents backward displacement of the lower fragment of the elbow and unduly prominent elbow. However, the three bone points of the elbow, medial epicondyle, lateral epicondyle, olecranon process. Medial epicondyle, lateral epicondyle, olecranon process still form the usual equilateral triangle because the olecranon process always moves on the lower fragment. For details, see figure 10.9 and 1.36. The fracture may cause injury to the median nerve and occlusion of the brachial artery. The median nerve and occlusion to the brachial artery. The injury of the brachial artery may cause Volkmann's ischemic contracture. Volkmann's ischemic, ischemic contracture, and myostosis ossifications. The occlusion of the brachial artery causes ischemia of anterior or compartment of the forearm, leading to increased pressure and swelling within it. This results in shortening of muscle contracture due to hypoxia. Median nerve is the most commonly involved in the supracondylar fracture of the humerus. Median nerve is the most commonly involved in the supracondylar fracture of the humerus. So axillary nerve, radial nerve, and then ulnar nerve. And the kinking of the brachial artery, supracondylar upper fragment, lower fragment, line joining the humerus with ulna, electron process of ulna. Clinical correlation. The separate centers for the median epicondyle and its late union with the shaft may be mistaken for a fracture of the medial epicondyle of the humerus. The separate center for the medial epicondyle and its later union. Clinical correlation. Common fractures of the radius. The radius is a weight-bearing bone of the forearm, hence fractures of radius are more common than those of ulna. Fractures of the head of the radius characteristically occurs due to falling on the outstretched hand. The radial head is forced to capitulum to fracture. In the fracture shaft may be radius. In the fracture shaft of the radius, with the fracture line below the insertion of the biceps and above the insertion of the pronator teres. The upper fragment is supinated by the supinator, the lower fragment is pronated by the pronator teres. Fracture of the radius. Colles fracture. It is the most common fracture of the radius. It occurs due to fall on outstretched hand. Older people due to osteoporosis. The distal fragment is displaced backward and upward. The distal fragment is displaced backward and upward. This is backward and out distal fragment. The wrist shows a typical dinner fork deformity. The reverse Colles fracture is called Smith's fracture. It occurs due to fall on the back of the hand and distal fragment is displaced anteriorly. The radius is the most commonly fractured bone in people over 50 years of age. It is often fractured as a result of fall on the outstretched hand. Fracture of the stellar process of the radius is termed Schaufffer's fracture. Fracture in the stellar process of the hand is termed Schaufffer's fracture. Schaufffer's fracture. Clinical correlation. Madelung's deformity. It is a congenital anomaly of the radius that presents the following clinical features. The anterior bowing of the distal end of the radius due to the abnormal growth of the distal epiphysis. The anterior bowing of the distal end of the radius. The anterior, what is Madelung's deformity? The anterior bowing of the distal end of the radius due to abnormal growth of the distal epiphysis occurs between 10 to 14 years of age. There is permanent disappearance of distal epiphyseal line. There may be subluxations and dislocations of the distal end of the ulna due to the defective development of distal radial epiphysis. Clinical correlation. Ulna stabilizes the forearm by gripping the lower end of the humerus by its trochlear notch and provides foundation for the radia to produce supination and pronation at the superior and inferior radioulnar joints. Fracture of the olecranon process is fairly common and occurs due to direct fall on the point of the elbow. The fracture of the upper limb of the shaft of the ulna with the dislocation of the radial head of the superior joint is called Montagnier's fracture. Fracture of the upper third of the shaft of the ulna with the dislocation of the radial head of the superior joint, Montagnier's fracture. The fracture of the lower third of the shaft of the radius associated with the dislocation of the inferior radioulnar joint is called Galeazzi fracture dislocation. Montagne fracture and Galeazzi fracture on the lower part of the shaft and upper part of the shaft. The fracture of the shaft of the ulna due to direct injury when the night watchman reflexes arises is forearm inward of the blow of the stick is called nightstick fracture. Clicker correlation, scaphoid fracture. Fracture of the scaphoid is the most common fracture of the carpus. 60 to 70% are usually occurs due to fall on the outstretched hand. Fracture occurs due to the narrow waist of the scaphoid. Narrow waist of the scaphoid. Clinically, it presents with tenderness of the anatomical smallpox. Tenderness of the smallpox. Blood vessels mostly enter the scaphoid through the both ends, but 10 to 50% of the cases, all blood vessels, both ends. 10% of the cases, all blood vessels supplying the proximal segment center is through its distal pole. All blood vessels supply the proximal center enter it through its distal pole. Under this condition, when the waist is scaphoid fractured, the proximal segment is deprived of blood supply and may undergo avascular necrosis. Fracture of the scaphoid is often misdiagnosed as a sprained wrist. Dislocation of the lunate. Lunate is the most commonly dislocated bone of the carpus. It occurs due to fall on the acute dorsiflexed hand. Dorsally flexed hand. It undergoes necrosis due to the lack of blood supply, causes Kienblock's disease. Then the knowledge of clinical correlation. The knowledge of ossification of carpal bones is important to determine the bone age of the child. The pisiform bone was palpated in earlier days in some parts of India to see the level of maturity in girls before sending them to in-laws' house. The pisiform bone was palpated in earlier days in some parts of India to see the level of maturity of girls before sending them to the in-laws' house. Clicker correlation. Bennett's fracture. It is an oblique fracture on the base of the anterior part of the first metacarpal on the ulnar side. First metacarpal on the ulnar side. It is intra-articular and may be associated with subluxation of the dislocation of the metacarpal. Thumb cannot be exposed and fist cannot be made. It is most common fracture on the thumb. Bennett's fracture. Boxer's fracture. It is the most fracture of the neck of the metacarpal. Of the most commonly involves in the neck of the fifth metacarpal. So, Boxer's fracture and then Bennett's fracture. Boxer's fracture and the Bennett's fracture. Clinical correlation. Distal phalanges fracture. Distal phalanges at the middle finger is most commonly fractured, usually due to crush injury. Clinically, it presents a painful swollen fingertip. It displays fracture of the phalanx. Can be treated satisfactorily by trapping the fractured finger with the neighboring finger. This is called buddy finger splint. An undisplaced fracture phalanges can be treated satisfactorily by strapping the fractured finger with the neighboring finger, known as a buddy finger splint. Clinical correlation. Anomaly of the pectoralis major. Occasionally, the part of the pectoralis major, usually the sternocostal part, is absent at birth in children with Poland syndrome, which is cause weakness of the adduction. The adduction of the medial rotation, adduction and medial rotation of the forearm. The pectoralis major, usually the sternocostal part, sternum and costal part of the humerus absent. Clinical correlation. The subclavian vessels and division of the brachial plexus pass behind the medial 1/3 of the shaft of the clavicle, separated from it only by a small subclavius muscle that provides protection to the three structures. the subcortical structures. The fracture of the clavicle are common. Rarely, subclavian vessels are torn by fragments of the fractured clavicle that may lead even to death. For example, the deaths of Robert Peel, UK, Prime Minister of UK. The subclavian vessels and the division of the brachial plexus. The subclavian vessels and the division of the brachial plexus pass behind the middle one third of the shaft. Pass behind the middle one third of the shaft of the clavicle, separated by a small subclavian muscle. It provides protection to the structures. Paralysis of the serratus anterior. The paralysis of the serratus anterior muscle during the injury of the long thoracic nerve, stab injury, or during removal of the breast tumor leads to following effects. Pronation of the scapula for punching is weakened. Protraction of the scapula is weakened. Inferior angle of the medial border of the scapula become unduly prominent, partially when the patient pushes the hand against the wall, producing a clinical condition called winging of the scapula. Metastasis of the breast cancer to the brain. It occurs due to the following route: cancer cells from the breast, posterior intercostal veins, and then a vertebral venous plexus, vertebral venous plexus, intracranial dural venous sinus brain, vertebral venous plexus. Breast cancer. It is the most common cancer in females. It arises from the epithelial cells along the lactiferous duct, acne of the lobules. In common 60% cases occurs due to the upper lateral quadrant. Of the commonly affects females 40 to 60 years of age. Clinically, it presents a very serious problem with the following signs and symptoms: presence of painless hard lump, breast becomes fixed and immobile due to infiltration of the suspensory ligament of the cancer cells, retraction of the skin due to infiltrations of the sensory ligament of the cancer cells, retraction of the nipple due to infiltrations of the fibers of the lactiferous duct. Pleiad orange. Appearance of the skin. The skin gives rise to appearance like the skin of an orange, because pits of the hair follicles appear to be retracted beneath the level of the skin due to obstruction of the superficial limbs. And metastasis. The knowledge of the lymphatic drainage of the breast is of great clinical importance. It is high percentage occurs in cancer in the breast, and it is subsequent dissemination of the cancer cells, metastasis along the lymph vessels to the region of lymph nodes. Some lymphatic vessels from the inferomedial quadrant of the breast. Communicate with the subperitoneal lymph plexus and carry cancer cells to it. From here, cancer cells migrate transomalically to get deposited on the ovary, producing a secondary tumor called Krukenberg's tumor. So carrying from here, cancer cells migrate inferior quadrant of the breast, communicate with the subperitoneal lymph plexus. Carry cancer cells from here to migrate the transolomically to get deposited on the ovary, producing a secondary tumor called the Krukenberg's tumor. Early detections of breast cancer is a serious and often fatal disease to women. Breast cancer. The mammography and the regular self-examination of the breast help in the early detection of the breast cancer and defective treatments. Mammography. It is an X-ray examination of the breast to detect cancer. The mammogram is X-ray picture of breasts. It is looked by doctors to look for early signs of breast cancer. Self-examination of the breast. The 6 steps of breast self-examinations are as follows: stand on a line in the mirror and the breast, discharge the nipples, look at and earring, packing, and deepening of the skin. The 6 steps. Treatment. Surgical treatment of the breast cancer is the form of lumpectomy and mastectomy. Lumpectomy removal of the cancer, and mastectomy is the removal of one or both breasts. In classical operation of the radial mastectomy, the whole breast is removed along the axillary lymph nodes, pectoralis major and minor muscles. Developmental anomalies of the breasts. The following developmental anomalies of the breasts are encountered during the clinical practice. Polythelia or supernumerary nipple. It appears along the milk ridge and is often mistaken for moles. Polythelia. Retracted nipple or inverted nipple. It occurs in the nipple, fails to develop from the ectodermal pit. Retracted nipple. It is a condition when the sucking of the infant cannot take place and the nipple is prone to infection. Polymastia. So polythelia, polymastia, development of more than one breast along the milk line. Appears along milk ridge, often mistaken for moles. Are gynecomastia, developmental of breast in male, mainly at puberty. Usually it is bilateral and thought to occur due to hormonal imbalance. Gynecomastia. Clinical correlation. Collateral circulation through scapular anastomosis. If the subclavian and the axilla arteries are blocked anywhere between the first part and the subclavian artery and the third part of the axillary artery, the subscapular anastomosis serves as a potential pathway between the first part and the subclavian artery and the third part of the axillary artery. It ensures the adequate circulation of the upper limb. Axillary artery pulsations of compressions. Axillary artery pulsations can be felt in the lower part of the lateral wall of the axilla. Axillary artery can be effectively compressed against the lower part of the lateral wall of the axilla to control the bleeding from the distal part of the upper limb. So, axillary artery pulsations can be felt on the lower part of the lateral wall of the axilla, and the axillary artery can be defectively compressed against the lower part of the lateral wall. Axillary artery can be defectively compressed against the lower part of the lateral wall of the axilla to control the bleeding from the distal part of the upper limb. Clinical correlation. Spontaneous thrombosis of the axillary vein. Occasionally, a muscular band, the axillary arch, overlines the vein. It may compress the vein following the excessive and unaccustomed movements of the arm and the shoulder joint and cause a spontaneous thrombosis of the axillary vein. Clinical correlation. Enlargement of axillary lymph nodes. The axillary lymph nodes are enlarged due to the infection of other inflammatory process of upper, middle or other drainage areas. For example, breast wall of the thorax and upper abdominal wall above umbilicus. Palpitation of the axillary lymph nodes. Palpitation of the axillary lymph nodes is a part of the clinical examination of the breast due to the involvement of the breast cancer. Axillary clearance of the lymph nodes. The breast cancer surgery. Axillary lymph nodes are sometimes cleared. While doing this procedure, utmost care should be taken to avoid inversion damage to the long thoracic, thoracodorsal and intercostal brachial nerves. Long thoracic, thoracodorsal and intercostal brachial nerves to avoid postoperative complications. For example, ligament of the scapula, pain and paresthesia of the region. Axillary abscess. An abscess in the axilla arising from the infection of the suppression of the axillary lymph nodes. The abscess may undergo a considerable size before the patient feels pain. The pus of the axillary abscess may tract up to the neck and down to the forearm, down to the arm, enter into the axillary sheath between the pectoralis muscle and its breast through the clavipectoral fossa. The axillary abscess is drained by giving an incision in the floor of the axilla, base of the axilla, and it being the most dependent part midway between the anterior and the posterior axillary folds, nearer to the median wall to avoid injury to the main vessels running along the anterior, posterior and lateral walls of the axilla. Boils of the axillary region. Boils are a small swollen painful red bumps which occur due to the infection of the hair follicles and sebaceous glands. The boils are commonly in the axillary region because its region has abundant axillary hair. If the hair are associated with hair follicles and sebaceous glands. Lesions of the brachial plexus. Lesions of the brachial plexus. For understanding the effects of the lesions of the brachial plexus, the student will find it helpful to know the spinal segments of the anterior control of the various movements of the upper limb. Adduction of the shoulder is controlled by C5 segments. C5 segments. Abduction of the shoulder is controlled by C6 and C7 segments. Flexions of the elbow is controlled by C5 and C6 segments. C5 and C6 segments. Extension of the elbow is controlled by C6 and C7. So 5, 6, 7, 5, 6, and then 6, 7. Flexions of the wrist joint is controlled by C8 and T1. C8 and T1. Important lesions of the brachial plexus are as follows. Erb's paralysis is caused by the excessive increase in the angle between the head of the shoulder, which may occur due to the fall on the back of the shoulder. Erb's paralysis between the head of the shoulder, which may occur due to the fall on the back of the horse riding a shoulder or traction of the arm during the birth of a child. This involves upper trunk and leads to typical deformity of the limb called policeman's stiff hand. Erb's paralysis. This deformity of the arm hangs by the side, adduction and medial rotated, and its forearm is extended and pronated. The detailed account of the clinical features of Erb's paralysis are as follows. Adduction of the arm due to paralysis of deltoid muscle. Adduction of the arm. Median rotation of due to paralysis of the supraspinatus, infraspinatus, and also teres minor muscles. Infraspinatus, teres minor muscles. Extension of the elbow due to the paralysis of the biceps brachii. Pronation of the forearm due to paralysis of the biceps brachii. So biceps brachii also does pronation. Sensor pronation. Extension of the elbow. Loss of sensation along the other aspects of the arm due to involvement of the root of the C5, C6 spinal nerves. Klumpke's paralysis. It is caused by the hyperabduction of the arm, which may occur when the fall of the outstretched hand on the arm is pulled to the machinery during delivery. Extended arm is beach in the injury are C8 and T1, sometimes C7. The clinical features of Klumpke's paralysis are as follows. Claw hand due to the paralysis of the flexor muscles, and finger in the intrinsic muscles of the hand. Flexors of the wrist and fingers and intrinsic muscles of the hand. Claw hand due to paralysis of the flexors. Loss of sensation along the medial border of the forearm and the hand. T1. Horner syndrome, characterized by partial ptosis, and then mitosis, ptosis, meiosis, and anhydrosis. Ptosis, meiosis, and anhydrosis of the enophthalmos due to the involvement of sympathetic nerve supply to the head and the neck, which leave the spinal cord at T1. Sympathetic nerve supply. Horner syndrome occurs only if T1 is injured proximal to the white ramus communicus of the first thoracic sympathetic ganglion. The important fractures of the Erb's and the Klumpke's paralysis are enumerated table 4.3. So, policeman's hands, claw hand difference. Outer aspect of the arm along the median border of the hand. Outer aspect of the arm. Autonomic signs absent, present. Autonomic signs. Important features of Erb's and Klumpke's paralysis are enumerated table. Surgical approach of axilla. The axilla is approached surgically through the skin of the floor of the axilla, but insert axillary lymph nodes outer tract breast cancer. The structures at risk during this procedure is intercostal nerves, long thoracic nerve, thoracodorsal nerve, and thoracodorsal artery. Effects sounds will be efforts should be made to safeguard the forementioned structures. Musculocutaneous flip of the latissimus. Musculocutaneous flip of the latissimus dorsi. The latissimus dorsi is supplied by a single dominant vasculopedicle formed by the thoracodorsal artery. The continuation of the subscapular artery. This artery and its accompanying vein communicates thoracodorsal nerve descend in the posterior wall of the axilla, enter the costal surface of the muscle and the single neurovascular hilum about 1 to 4 centimeters medial to the lateral border of the muscle. The presence of single dominant vascular pedicle provides anatomical basis for rising of the muscle alone or along with the overing skin of the forearm. Musculocutaneous flip. The musculocutaneous flip of latissimus dorsi is often used in reconstruction of the breast following mastectomy. Musculocutaneous latissimus dorsi is often used to reconstruction of the breast following a mastectomy. Conditioning of latissimus dorsi to act as a cardiac muscle. Latissimus dorsi, if conditioned with a pulsated electrical impulse, starts functioning like a cardiac muscle, that it will be non-fatigable and use oxygen at a steady pace. Thus, following conditioning, the latissimus dorsi can be used as a autotransplant to repair surgically remove portions of the heart. The procedure involves detaching the latissimus dorsi from the vertebral region, keeping the neurovascular pedicle intact and slipping it into pericardial cavity where it is wrapped around the heart like a towel. A pacemaker is required to provide the continuous rhythmic contractions. Triangle of auscultation. It is a small triangular gap in the musculature of the back of the thorax near the inferior angle and the scapula. The boundaries are superior horizontal border of the latissimus dorsi and then medial border of the scapula, superior horizontal border of the latissimus dorsi, medial border of the scapula, inferior border of the trapezius. Superior border of the latissimus dorsi, median border of the scapula, also inferior border of the inferior border of the trapezius. The floor of the triangle is formed by the 6-7 ribs and the first intercostal space. The upper part of the lobe is by lung lies deep to the triangle. When the scapula are drawn interiorly by folding the arm across the chest, the trunk is flexed. This is the triangle along that becomes the more subcutaneous. Now, the lower lobe of the lung can be auscultated, putting the stresses on the region. The sounds are not muffled by the muscles in the back of the area. So the latissimus dorsi and the median of the scapula and inferior border of the trapezius, and also rhomboides major. Triangle of auscultation. Anatomical basis of injury of axillary nerve during intramuscular injections of the deltoid. The intramuscular injection should be given in the thick middle part on the lateral aspect of the deltoid, 2.5 to 5 cm below the acromion process. To locate this area, lay 3 fingers across the deltoid muscle below the acromion process. This is essential to avoid injury of the axillary nerve, which winds around the surgical neck of the humerus deep to deltoid muscle. If intramuscular injection is given in the lower part of the deltoid, the axillary nerve may be damaged. Rupture of supraspinatus tendon. It is a common soft tissue injury in the shoulder region. The patient with the ruptured supraspinatus tendon, when asked to raise the hand above the affected area, he will first tilt his body on the affected side so the arm swings away from the body, abducted 15 degrees. Then he will slightly rearrange the hand of the healthy side, known as trick device. Learn to the patients with ruptured supraspinatus tendon. Injury of the axillary nerve. The axillary nerve is at risk to damage in inferior dislocation of the shoulder joint and fractures of the surgical neck of the humerus because of the close association of the structures. Axillary nerve. The damage of the axillary nerve presents the following clinical features: impaired abduction of the shoulder due to paralysis of the deltoid and teres minor muscle, loss of sensation of the lower half of the deltoid due to involuntary of the upper lateral cutaneous nerve of the arm, loss of shoulder countered with prominence of greater tubercle of the humerus due to the wasting of deltoid muscle. Greater tubercle humerus due to wasting of deltoid muscle. It happens on the axillary nerve, injury to the axillary nerve. So the tubercle becomes more prominent. Greater prominence of the tubercle of the humerus. Loss of sensation of the half of the deltoid. The dislocation of the shoulder joint. It is quite common due to the disproportionate size of the articular surface. Only 1/3 of the humerus head comes in contact with the glenoid fossa. Hence, head of the humerus often pops out of the shallow glenoid fossa. There are 3 types of shoulder dislocations: anterior dislocation, posterior dislocation, inferior dislocation. Anterior dislocation is the most common type of dislocation shoulder joint. Hence, the humerus often pops out under the shallow glenoid fossa. Most common dislocation 70%. This is the head of the humerus moves forward in front of the glenoid fossa. It is usually caused by the blow of abductor externally rotated and extended arm, for example, blocking a basketball shot. Anterior extended rotation of the forearm for block. It is usually caused by a blow on the abducted. Blow on the abducted. Posterior, it is less common, 3%. This head of the humerus moves behind above the glenoid cavity. It is causes by anterior direct shoulder trauma. For example, grabbing the dashboard in monitor vehicle collision. And inferior dislocation, this side of the humerus is pushed down and out of the socket towards the armpit. This is abducted downward head permanently. Infrequent occurs in patients fall of sudden gaps or objects above the head, results in abduction. It frequently occurs when patients fall and suddenly gaps hyperaggression. This type of injury is rare. Further, inferior, the joint is supposed to be inferior glenohumeral ligament along the head of the triceps. It often injures the axillary nerve because of close relation to the inferior part of the joint capsule. Clinical reports as hollow, rounded the conical shoulder and prominent shoulder grip. Note where earlier it was thought that dislocation of the shoulder joint mostly occurs frequently because the joint is less supported on this aspect. Frozen shoulder. It is a clinical condition characterized by the pain and the uniform limitations of all movements of the shoulder joint. There are no radiological changes on this joint. It occurs due to the shrinkage of the joint capsule, hence the name adhesive capsulitis. This condition is generally seen in individuals in 40 to 60 years of age. Adhesive capsulitis. Rotation cuff dislocation. The most common disorders of rotator cuff include calcific supraspinatus tendinitis and subacromial bursitis. The rotator cuff injury represents overtore cuff and commonly injures during repetitive use of the upper limb above the horizontal level. The throwing, sports, swimming, and weightlifting. The deposition of the calcium of the supraspinatus tendon is common. The calcium deposition irritates the overlying the subacromial bursa, causing subacromial bursitis. Conspicuously, when the arm is abducted, an inflamed bursa is thought between the tendon acromion, the subacromial impingement, which causes severe pain. The most people pain occurs due to 60 to 103 degrees adduction, painful syndrome. Rotation cuff disorders usually occur in males after 50 years of age. Deltoid is pressed just below the acromion. When the arm is abducted, the pain cannot be elicited of the pressure at the same point the arm abducted because the bursa disappears under the acromion process. Dorbern's sign. The pain cannot be elicited by the pressure on the same point when the arm is adducted because the bursa disappears under the acromion process. Aspiration of the shoulder joint. The synovial fluid aspiration analyzes different inflammatory arthritis. Because non-inflammatory arthritis, the anterior approach the needle is inserted into the median to the humeral head, lateral to the coracoid process. Median to the humeral head, lateral to the coracoid process. Humeral head to the coracoid process. Exclusion of the shoulder joint. The common symptoms and signs of the shoulder joint are shoulder pain, tenderness, joint stiffness, decreased range of movements, cracking sounds of the joint. For example, during routine examination, shoulder joint disease is excluded if the patient cannot raise his arm above the head and bring down the palms together. Dislocation of the sternoclavicular joint. It is rare because the sternocleidomastoid joint is extremely strong. However, dislocation of this joint in people 25 years of age may result from fracture through the epiphyseal plate. Because epiphysis at the sternal end of the clavicle does not unite until 25 to 25 years of age, the medial end is usually dislocated anteriorly. Backward dislocation is prevented by costoclavicular ligament. Transmission of weight of the upper limb. The weight of the upper limb is transmitted from the scapula to the clavicle through coracoclavicular ligament, then the clavicle to sternum through the sternoclavicular joint. Some of the weight is transmitted to the first rib through the costoclavicular ligament. Dislocation of the acromioclavicular joint. It may occur following a severe blow on the sternosupralateral part of the shoulder. In severe form, both acromioclavicular and coracoclavicular ligaments are torn. Acromioclavicular and coracoclavicular ligaments are torn. Consequently, the shoulder separates from the clavicle and falls because of the weight of the thumb. The acromioclavicular joint dislocation is often named a shoulder separation. Significance of dermatome. As discussed in the beginning, the understanding the dermatome arranged of the upper limb is clinically important because of physicians commonly test the integrity of the spinal cord segments from C3 to C2 by performing sensory examinations for touch, pain and temperature. This is also because the sensory loss of the skin following injuries to the cord conforms to the dermatome. Venipuncture of the cubital fossa. The veins in front of the elbow explain medial vein, cephalic vein and basilic vein, routinely used for giving intravenous injections and withdrawing of blood from the donors. The medial cubital vein is mostly preferred for venipuncture due to the following reasons. It is the most superficially vein in the body, hence access is easy. It is well supported by underlying bicipital aponeurosis, and it is well arched deep vein, performic vein, hence it does not slip and procedure. Bicipital aponeurosis, the underlying bicipital aponeurosis. Hemodialysis. The cephalic vein is preferred for hemodialysis in patients with chronic renal failure to remove the products from blood. Hemodialysis, cephalic vein. Cephalic vein catheterization. The basilic vein is performed for cardiac catheterization for the following reasons. The diameter of the basilic vein increases as the ascends from the cubital fossa to the axillary vein. It is in direct line with the axillary vein. To enter the right atrium, the catheter passes in succession as follows: basilic vein, axillary vein, subclavicular vein, basilic vein, basilic vein, axillary vein, subclavian vein, brachiocephalic vein, superior vena cava, right atrium of the heart. The cephalic vein is not preferred for cardiac catheterization due to the following reasons. The diameter does not increase as it ascends. Does not increase. It joins the axillary vein at the right angle, hence it is difficult to the axillary vein. The cephalic vein is not preferred for cardiac catheterization due to the cephalic vein. The cephalic vein is not preferred for cardiac catheterization due to the diameter of the does not increase, so basilic vein is preferred. Join the axillary vein at the right angle, hence it is difficult to maneuver the catheter around the sharp cephalo-axillary angle. The deltopectoral groove is frequently divided into smaller branches. One of these branches ascends the clavicle, joins the sternocjugular vein. Cephalojugular communications. Here, cephalic vein communicates with the external jugular vein small through a small communicating veins which cross the front of the clavicle. When the segment of the axillary vein is removed during the clearance of the axillary lymph nodes in breast cancer, these communicating veins enlarged considerably to help the drain venous from the upper limb. It is often ruptured in fracture, clavicular cause bleeding. Lymphatics and lymphedema. The inflammations of the lymph vessels is termed lymphangitis. It usually follows trival injuries for following cuts and pinpricks. Any part of the upper limb in acute lymphangitis, the lymph vessels may see underneath the skin in red streaks, which tender painful touch. Lymphangitis. Lymphedema. The obstruction of the lymph vessel may cause edema in area of drainage due to the occlusion of the colloidal tissue fluid. It often occurs due to surgical removal of lymph nodes in cancer surgery. The axillary lymph nodes are enlarged and become painful following the infection in any part of the upper limb. Lymphadenopathy. The infection affects the medial side of the hand and forearm. Supratrochlear lymph node becomes enlarged and tender. Supratrochlear lymph node. Bicep flexion. It is tested during physical examination by tapping the tendon of the biceps brachii by the flexor hammer with the forearm pronated and partially extended in the elbow. The forearm reflex is brief jerk-like reflex on the elbow. The normal reflex confirms the integrity of the musculocutaneous nerve, C5 and C6 spinal segments. Popeye's deformity. The long head of the biceps brachii ruptured due to attrition. The belly of the muscle bunched up and resembling the arm of a famous cartoon character Mr. Popeye in the 1930s. Hence, it is termed Popeye's deformity. Clinical correlation. Injury of the musculocutaneous nerve. Throughout, it is rare if occurs the lead of the humerus to symptoms: loss of strong flexion and supination, loss of biceps tendon reflex, supination, biceps tendon reflex, loss of sensation along the lateral aspect of the forearm. Lateral aspect of the forearm. Clinical correlation. Brachial pulse. The brachial pulse is commonly felt on the cubital fossa median to tendon of the biceps, and its pulsations are accosted for reading the blood pressure. The biceps tendon is easily palpable for the flexion of the elbow. The method of taking blood pressure is taught in physiological practice in practical class. Compression of the brachial artery. The brachial artery can be effectively compressed against the shaft of the humerus at the level of the insertion of the coracobrachialis to stop the hemorrhage in the upper limb occurs from any artery distal to the compression of the branch artery. For example, bleeding wounds of the palmar artery arches. Bachmann's ischemic contracture, sudden complete occlusions of the brachial artery due to tight pulse, cast or its laceration due to the supracondylar fracture of the humerus, can cause fibrosis of the muscle to form due to the near ischemic and necrosis within a few hours. Bachmann's ischemic contracture. The muscles can tolerate ischemic up to 6 hours only. Thereafter, they undergo necrosis, 6 hours only, and the fibrous tissue replace the necrosis tissue. As a result, fibrosis muscles shorten permanently and produce a flexor deformity. Tissue as a result, fibrous tissue shorten permanently and produce a flexor deformity. Claw hand characterized by flexion of the wrist, extension of the MP joints and flexions of the interphalangeal joints, which lead to loss of hand power. Clinical correlation. Funny bone. It is neither funny nor a bone, but the name gives the ulnar nerve behind the medial epicondylar of the humerus. This is because when the medial epicondylar humerus is knocked bumped against a hard object, there is a feeling of tingling of the numbness along the medial side of the forearm of the hand. Funny bone is a nickname of the ulnar nerve behind the medial epicondyle of the humerus because of funny feeling one gets after median epicondyle hit against the hard object. The radial nerve is commonly injured in the radial groove due to various reasons. Fractures shaft of the humerus. 4 leads to wrist drop, sensory loss of a narrow strip to the skin, loss of the forearm, and tingling or burning sensation on the back of the forearm involving thumb, index finger, and middle finger. Clinical significance of the cubital fossa. The knowledge of anatomy of the cubital fossa is clinically important for the following reasons. Venipuncture of the cubital vein. The venipuncture of the clinical methods of pierce vein needle for either intravenous injections or removal of blood. Clinical most common style venipuncture is the cubital fossa, cephalic, medial, and cubital vein. On the medial cubital vein is most preferred. The middle cubital vein is the vein of choice because prominent vein of the body tends to remain stationary for being connected with the deep veins. The perforating vein does not usually collapse during shock, lies more superficially and not accompanied by a nerve. Hence, the skin over it is less sensitive. Hence, venipuncture is less painful. Underlying bicipital aponeurosis acts as a hard platform when the elbow is extended and protects the underlying medial nerve and brachial artery from injury. So, loss of bicipital aponeurosis, medial brain and brachial artery, and then median nerve. The brachial artery in this region is easily located median to the bicipital tendon. The brachial artery is easily located in this region because it is median to the biceps tendon. The auscultated universally for hearing the croak of sounds of recording of the blood pressure manually. To deal with fractures around the elbow, for example, supracondylar fracture of the humerus, the contents of the cubital fossa, usually the brachial artery and the median nerves are vulnerable in supracondylar fracture of the humerus. The contents of the cubital fossa, particularly median nerve and brachial artery, are likely to get injured in supracondylar fracture of the humerus. Injury to the radial nerve of the radial groove. If the radial nerve is damaged in the radial groove, the extension of the radial nerve of the elbow and triceps flex is not completely lost, but the nerve to the long head of the arises from the radial nerve of the axilla. If the radial nerve is damaged, the radial groove, the extension of the elbow and the triceps is not completely lost because the nerve to the long head arises from the radial nerve in the axilla. Apparent ulnar artery. About 3% of individuals, the brachial artery divides into terminal branches high up in the arm. Therefore, the ulnar artery may arise higher in the arm and pass superficially to the flexor muscles of the forearm, termed as superficial ulnar artery. The variations should always be kept in mind. Withdrawing blood samples or giving intravenous injections because of supracondylar ulnar artery is mistaken for a vein. Supracondylar artery is mistaken for a vein. It may damage the produce bleeding. Further irritating drugs injected in this brachial artery results may be fatal. An irritating drug injected in the brachial artery. Radial artery is normally used to take pulse. In increase being in main portal of the interventricular radiology. Examination of the radial pulse felt on the radial side of the wrist, where the radial artery is on the flat anterior surface of dorsal end of the radius and covered by the skin of the fossa. At this side, the radial artery lies between the tendon of flexor carpi radialis medially and brachialis laterally. Tendon of brachioradialis laterally. Flexor carpi radialis and brachioradialis. While examining the radial pulse, the thumb should not be used because of its own pulse should be mistaken for the patient's pulse. The radial pulse is commonly used for examination of the pulse rate. Surgical safe side of the forearm. The lateral side of the anterior aspect of the forearm is considered to be the safe side. The surgical branches of the median the main nerves of the front of the forearm are mostly directed medially to supply the muscles in front of the forearm. The major nerve lateral side of the superficial radial nerve. It is only sensory because of the radial branch and runs deep to the brachioradialis muscle, the proximal forearm. suicidal cuts of the wrist. A deep laceration of the radial side of the wrist is a suicidal attempt by cut following the structures from the lateral to the medial side. Radial artery and tendon of flexor carpi radialis, median nerve, tendons of the palmaris longus and tendon of flexor digitorum superficialis. A deep laceration in the ulnar side of the wrist, as in suicide attempt, may cut the following structures from the median to the lateral side: tendon of flexor carpi ulnaris, ulnar nerve, and ulnar artery. Posterior interosseous nerve syndrome. It occurs when posterior interosseous nerve is entrapped in the arcade of Frost. Arcade of Frost, a fibrous between the two heads of the supinator muscle. Arcade of Frost. Arcade. R-C-A-D-E. Arcade of Frost. F-R-O-H-S-E. Arcade of Frost. A-R-R of supinator muscle. Clinically, it presents a pain and the weakness of the forearm, causing difficulty in pulling, pushing, and grabbing. The posterior interosseous nerve, a deep terminal branch of the radial nerve, may be damaged during the surgical exposure of the head of the radius. In the fracture proximal to the end of the radius, the posterior interosseous nerve may be damaged during the surgical exposure of the head of the radius. In the fracture of the radius, since external carpi radialis longus is a spread risk does not occur. No. Some authorities think that deep terminal branch of the radial nerve is termed as the posterior interosseous nerve only after emerging the supinator muscle. Aspiration of the elbow effusion. The distension elbow joint and effusion cavity posterior. Dislocation of the elbow. And the nursemaid's elbow, pulled elbow, or head of the radius. And then Goldberg's elbow and student's elbow, nerve entrapment syndrome around the elbow. Aspiration of the elbow effusion. The distension of the elbow joint due to effusion within the cavity occurs posteriorly because capsule of the joint is thin posteriorly, and with effusion the capsule bulges on the either side to triceps tendon. The joint is aspirated by inserting a needle on the posterolateral side just above the head of the radius in the forward direction, which elbow right angle. Dislocation of the elbow. Posterior dislocation of the elbow are more common, are often associated with fractures on the olecranon process. The dislocation invariably occurs by the falling on the outstretched hand. The triangular relation between the olecranon and the epicondyle of the humerus is lost. Note the normal flexed elbow tip the olecranon process and two epicondyles of the humerus form an equilateral triangle. The reduction is achieved fairly easily by first giving traction to overcome spasm and then flexion of the overcome the lower joints of the back of the place. Nursemaid's elbow, pulled elbow. So, a full elbow, subluxation of the nerves of the radius. It occurs at preschool children 1 to 3 years of old because of their radial head is still cylindrical and annular ligament is lax. It usually happens when the forearm is suddenly pulled in pronation. The head of the radius comes out of the annular ligament and the elbow is kept slightly flexed and pronated. For example, when nursemaid brings the child home from a school by holding the thumb in a way, she suddenly pulls the forearm in a jerk to save the child from a speeding car. An attempt to supinate the forearm causes severe pain. Supinate the forearm because the radial head of the cylindrical annular ligament is lax. It usually happens when the forearm is suddenly pulled in pronation. The head of the radius comes out of the ulnar ligament. An elbow is kept flexed and pronated. For example, when nursemaid brings the child home from school by holding the thumb in a way, she suddenly pulls the forearm and saves the child from a speeding car. Tennis elbow. It is a clinical condition characterized by pain and tenderness over the lateral epicondyle of the humerus during abrupt pronation and extension of the wrist. It occurs due to sprain of the lateral collateral ligament of the elbow joint, tear and the fibrous in extensor carpi radialis brevis and inflammation of the bursa underneath the extensor carpi radialis brevis. Stain on the near the tear common flexor origin. Golfer's elbow. It is a clinical condition characterized by pain and tenderness over the median epicondyle of the humerus due to stain tear flexion common origin subcutaneous inflammation of the medial epicondyle following repetitive use of superficial flexor or forearm as during playing golf. A student's elbow are characterized by round flex swelling of the tip of the elbow. Occurs due to inflammation of the subcutaneous olecranon bursa overlying the cutaneous triangle area of the posterior aspect of the olecranon process. Nerve entrapment syndrome around the elbow. The nerve entrapment syndrome around the elbow are fairly common and cause pain, muscle atrophy, and weakness of the area supplied by entrapped nerve. Median nerve entrapment. The median nerve may be compressed by hypertrophied pronator teres muscles where it passes between the two heads of the pronator teres. Pronator teres has abnormally dense apneurotic edge where it passes deep to the fibers of the elbow, humerus, and radial head of the digitorum superficialis. Ulnar nerve entrapment. The ulnar nerve may be compressed where it passes posterior to the medial epicondyle of the humerus, where it passes through the cubital formed by tendinous arch joining the humerus and the ulnar head of the flexor carpi, leading to cubital tunnel syndrome. Posterior interosseous nerve entrapment. The posterior interosseous nerve may be compressed where the passes deep to the posterior arcade of Frost. A musculocutaneous structure of the proximal edge of the supinator muscle or where it passes through the subcutaneous supinator muscle. The person with Down syndrome usually has only one transverse palmar crease of the seminal crease. Since the fingerprints are identical to any two individuals, including individual identical twins, they are used in criminal and investigational to identify criminals. Dupois trans contracture. It is a progressive fibrosis of interstitial increased fibrous tissue in the median part of the palmar aponeurosis. Consequently, the median part of the aponeurosis may undergo progressive thickening and form permanent contracture, resulting in the flexion deformity of the two fingers. The ring finger is the most commonly affected. The proximal and the mid phalanges are acutely flexed, but distal phalanges remain unaffected. A surgical fascectomy is required of the hand. Function is grossly impaired. Trigger finger. It is a clinical condition in which a finger gets locked in a full extension, can be extended only after excessive voluntary effort. Suddenly a click, and this is known as a trigger finger. Condition is caused by localized thickening of the fibrous tissues. Clinical condition. Tenosynovitis of the synovial sheaths of the flexor tendonis. It is an infection in the inflammation in the synovial sheaths of the long flexor tendons, which post result from a small penetrating wounds caused by the pin prick in the results from the distension of the sheath with pus. The digit gets swollen and becomes very painful due to stretching of the synovial pus. And then space of palmar infection. In this case of infection, digital synovial sheaths of the line fingers and the thumb. Due to continuity, these bursa are involved and neglected. The proximal ends of this bursa may be burst and may pass enter into the facial space of the forearm between the flexor digitorum profundus and the anterocellus membrane of the pronator teres quadratus. Claw hand. It is a deformity of the hand in which fingers are bent in such a position that the hand looks like a claw. Clinical features: hyperextension of the metacarpals joints, flexion or proximal and distal interphalangeal joints, flexion of the proximal or distal interphalangeal joints, loss of abduction, adduction of fingers, flattening of the arch of the hand, cause of loss of the median nerves, lesions of the median and ulnar nerve leading to paralysis of flexor of the wrist, metacarpophalangeal, phalangeal, proximal, interphalangeal, and distal interphalangeal joints. Clinical correlation: laceration of the palmar arterial arch. The lacerated wounds of the palmar arterial arch usually cause profuse and uncontrollable bleeding. The compression of the brachial artery against the humerus on radial side of the mid-arm most affected of the control of the bleeding. So the compression of the brachial artery against the humerus, brachial artery, and mid-arm is the compression of the brachial artery against the humerus. Ulnar canal syndrome, Guyon's tunnel syndrome. It is a clinical condition which occurs due to the compression of the ulnar nerve, Guyon's canal at the wrist. Clinically, it presents with hypoesthesia on the middle half of the fingers, weakness of the intrinsic muscles of the hand. Guyon's tunnel syndrome, ulnar tunnel syndrome, Guyon's tunnel syndrome, which occurs due to compression of the ulnar nerve, the Guyon's canal. Ulnar tunnel canal is an ossifibrous tunnel formed by the pisiform ligament bridge and connective between the pisiform bone and the hook of the hamate. Infection of the facial aspects of the palm, infection of the mid-palmar space, infection of the thinner space, palmar space infections of the digits. Being the most exposed part of the digits, the palm space prone for infection and abscess in the palm space is called the Whitlaw or Fallon. The rising tension in the palmar space causes severe stabbing pain. The pus from the pulp scene is drained by a lateral incision, opening all lacunae and avoid tactile skin sensations of the forearm and finger. If neglected, the Whitlaw may lead to avascular necrosis. So this is Whitlaw or Fallon. Neglected operation of the proximal 1/5 of digital artery as a result of pressure. The proximal 1/4 phalanges are not affected because the branch of the digital artery supply does not traverse the pulp space. The proximal 1/5 is not affected. The forearm peroneal space becomes infected from ulnar bursa, pus collected behind the long flexor tendons. Mallet or finger or baseball finger, cricketer's finger. The insertion of extensor tendon into the base of the terminal phalanges may be torn by a forceful blow of tip of the hand. Sudden and strong flex of the phalanx. Occasionally, small flexes of the bone may be avulsed. Consequently, the digital phalanges assume a flexion position with the swan neck. Deformity and voluntary extension are possible. This condition commonly occurs in cricketers and baseball players. Boutonniere's buttonhole deformity. It is opposite to the mallet finger deformity. It is characterized by flexion of proximal interphalangeal joint, hyperextension proximal interphalangeal joint. It is the flexion. It is opposite to the mallet finger deformity. It occurs when the fixed proximal interphalangeal joint pokes through the central position of the digital extremity due to direct end of the trauma of the finger. Clinical significance of anatomical snub box. The pulsation of the radial pulse can be felt in the anatomical snub box. The tenderness of the anatomical snub box indicates fracture of the scaphoid bone. Cephalic vein is the site for giving for intravenous fluids. The superficial branch of the radial nerve can be rolled over the tendon of the extensor pollicis longus. And now, infection of the subcutaneous space. Infection of the space is uncommon but sometimes may get infected injury of the knuckle. space due to the loss of the skin and given posterior side. Infection of the supranephrotic side. The septic infection of the subepineuritic space is generally primary, following the wounds of the dorsum of the hand. It may, however, get involved secondarily to the infection of the metacarpal space. The pus collected in the subepineuritic space is limited proximally at the base of the metacarpal bones and distal at the metapharyngeal bones. On the other side, is limited opposite at the borders of the metacarpal space to drain the pus from the alternately along the exoesophageal tendons. Pollice fracture. Distal end of the radius and superficial position nerves, vessels, or tendons. Wrist may be excessively vulnerable to injury. Ganglion. It is a non-tender cystic swelling which sometimes appears on the wrist, most commonly on the dorsal aspect. Its size varies from a small grape to a pulp. It occasionally occurs due to mucoid degeneration of the synovial sheath around the tendon. The cyst is thin-walled and contains clear mucus fluid. The flexion of the wrist may enlarge and may become painful. It is usually done by introducing a needle posteriorly immediately below aspiration of the wrist joint. Immediately below the styloid process of the radial between the tendon of extensor pollicis longus and extensor index. Extensor pollicis longus and extensor index. Styloid process of the radial. Styloid process of radius between the tendon. Extensor process. Styloid process of radius. Immobilization of the wrist joint is immobilized in its optimum position of 30-degree dorsiflexion. Osteoarthritis and dorsiflexion commonly involved wrist and interphalangeal joints. They are in the common cause of pain and swelling in the hand. Clinical correlation. Abnormalities on the arch of the hand. The disturbance of the palmar arches result in flat hand with impaired grip power. The flattening of the carpal arch seriously affects the gripping power of the thumb. It occurs due to surgical division of the flexor reticulum or injury to the carpus. Position and immobilization. Position of immobilization. The collateral ligament of metaphalangeal interphalangeal extend on the side of the head of the proximal bone on the side of the base of the distal bone. The ligament of metaphalangeal joints are full stretch when the joint is fully flexed at 90 degrees. On the other hand, ligament of interphalangeal joints are stretched taut when the joint fully flexed. This knowledge of vital importance when immobilization hand because contracture of the joints occurs within 2 weeks. If the joints are immobilized when the ligaments are lax and set, when the shortening of the ligaments will cause irreversible joint contraction. Therefore, the position of immobilization in the hand should be such that metaphalangeal joints are fully flexed and interphalangeal joints are fully extended. Fully flexed and extended. Position of the arthrodesis. The position of the arthrodesis in moderate dorsiflex 15-20 degrees. Metaphalangeal interphalangeal joints are set in natural position. Arthrodesis is a surgical procedure consisting of obliteration of the joint space by doing bony fusion of the that no movement can occur on this point. Orthodosis. The position of orthodosis is one in which joint is moderately dorsiflexed in natural position. Now, injuries of the radial nerve. Radial nerve may be injured in their three sides: in the axilla, in the spinal group, and in the elbow. Radial nerve can be injured in the axilla, in the radial, in the spinal group, and the elbow. Injuries of the radial nerve at the axilla. The axillary radial nerve may be injured by pressure of the upper end of the crutch. Characteristic features of such as follows: motor loss, loss of sensation of the elbow due to paralysis of triceps, loss of extension of the wrist due to paralysis of the wrist joint. This causes wrist drop due to unexposed action of the flexor muscle of the forearm, loss of extension of digits due to paralysis of extensor digitorum, extensor index, extensor digitorum minimi, and extensor pollicis longus. Loss of supination in the extended elbow because supinator and brachioradialis are paralyzed, but the supinator becomes possible in flexed elbow. The action of the principle of the biceps brachii. Sensory loss. Sensory loss of the small area of the skin over posterior surface of the lower part of the arm. Sensory loss along the narrow strip on the back of the forearm. Sensory loss on the lateral part of the dorsal of the hand, or the base of the thumb in the dorsal surface lateral digits of the phalanges. More often, there is an isolated sensory loss on the digitorum hand of the base of the thumb. Injury of the radial nerve and the radial spiral groove. In the radial groove, the radial nerve may be injured due to wrongly placed intramuscular injection. Direct pressure on the radial nerve by drunk falling asleep with the arm and back of the chair. Saturday night paralysis. So radial nerve can be paralyzed in that way. Injury in the radial nerve occurs most commonly in the dorsal part of the groove beyond the origin of the nerves and triceps and cutaneous nerves. Characteristic clinical features in such a way that will motor loss, loss of extension of the wrist and the fingers, wrist drop, loss of supination when the arm is extended. It is restriction only in the variable small area over the dorsum of the hand between the first and the second metacarpals. Extension of the elbow is possible in above leisure, but may be little weak because nerve to long heads of the triceps arises in the axilla, that is before the site of the lesion. Isolated sensory loss. Injury of the radial nerve on the elbow, radial tunnel syndrome. It is entrapment of the atrophy of the deep branch of the radial nerve of the elbow. Compression of the radial nerve at the elbow may be caused by the following four structures: fibrous hand, which can tighten the radial nerve on the rhinoidal femur joint; sharp, tendinous margins of the extensor carpi radialis brevis; less vessels from the recurrent artery arcade of Frost; a fibrous epiuretic superficial part of the supinator muscle. A fibrous as of the part of the supinator muscle. Loss clinical features: loss of extension in the wrist and the finger, but not wrist drop. Clinical features: loss of but not wrist drop. Pain in the extensor carpi of the forearm. Injury of the radial nerve at the elbow. Pain over the extensor aspect of the forearm. Injuries of the median nerve. Lesion of the may occur at the following force: at the elbow, at the mid forearm, and at the wrist, and the carpal tunnel. Injury of the median nerve of the elbow. Median nerve may be injured due to supracondylar fracture of the humerus, application of the tight truncated during venipuncture, and entrapment of the nerve between the two heads of the pronator teres under the fibrous arch connecting the two heads of the flexor digitorum superficialis. Characteristic clinical features in such cases will be as follows: forearm kept in supine position, loss of supination due to paralysis of pronator teres and pronator quadratus. Wrist flexion is weak due to paralysis of all the flexor of the flexor except the median half of the flexor digitorum profundus and flexor carpi ulnaris. Adduction of the wrist due to paralysis of flexor carpi ulnaris and unopposed action of the flexor carpi radialis and median half of the flexor digitorum profundus. No flexion is possible at the interphalangeal joints. Extensor of type of deformity of the hand. That is when patient takes first middle finger of the straight due to paralysis of both superficial and flexor. These fingers lead to loss flexion after proximal interphalangeal and distal interphalangeal joints. The ring and the lost little finger is kept flexed during the position into intact nerve supply of the medial half of the flexor profundus. The Benedict deformity is classically an ulnar claw hand. radial claw hand, ulnar claw hand, where the medial two fingers are extended in the metacarpopharyngeal joints of flexor and due to paralysis of the median two lambricals. Interosseous due to injury of the ulnar nerve because it resembles the hand gesture of a pope, a Christian priest giving blessings, a papal benediction. Historian Peter Saint had suffered from the ulnar claw hand, but he continued to give his blessings to his followers by his stretched ulnar claw hand. Hence the name Benedict's hand. Benedict's hand. His hand. Loss of flexion of terminal phalanx of the thumb due to paralysis of flexor palmaris longus. 8th thumb deformity, which the thinner eminence is flattened and the thumb lies at the adductor, and the paralysis of the muscles with thinner eminence as normal adductor pollicis respectively. Loss of sensations of the lateral half of the palm and the lateral half of the also dorsal aspects of some disease. Injury of the median nerve of some at the midforearm. The injury of the median nerve at the midforearm results in point index finger midforearm. Due to the parallel radial nerve flexor disturbs superficialis muscle that continues as the tendon of index finger. Other signs and symptoms will be same as those which occur in lesion at the distal forearm of the wrist. Wrist median nerve of the palmar cutaneous branch may be injured just proximal to the flexor reticulum by deep lacerated wounds. For example, suicidal cuts. Median nerve characteristic clinical features are usually follows: 8th thumb deformity, paralysis of the ulnar nerve, loss of sensation lateral part of the palm, 3.5 disease including the sensation of the dorsal aspect of the disease, and median nerve of the injury of the carpal tunnel compression produced clinical condition called carpal tunnel syndrome. It is formed by the anterior concavity of the carpus flexor reticulum. The gland is slightly packed with 9 long flexor tendons and their surrounding sits the median nerve. The median nerve gets compressed in a tunnel due to the narrowing of the following chambers. Pathological conditions such as tenosynovitis flexor tendons, myxedema, retention of the fluid of pregnancy, retention of fluid during pregnancy, myxedema, also tenosynovitis of the tenosynovitis, fracture of the dislocated tunnel bone and osteoarthritis of the wrist, pregnancy retention and myxedema, deficiency of thyroxine, idiopathic arthritis, fracture of the lunate bone, etc., osteoarthritis of the wrist. Characteristics, clinical features. The carpal tunnel syndrome are as follows: feeling of burning pain and the pins of the needles along the sensation tributaries of the median nerve aspect of the especially at night. There is no sensory loss over the thinner eminence because skin over the thinner is supplied by the palmar cutaneous branch of the median nerve. A loss of superficial and flexor reticulum. Weakness of thinner muscles. 8th thumb deformity and in left underrated due to paralysis in the thinner muscles. Signs of symptoms of carpal tunnel syndrome are dramatically relieved by decompression of the tunnel by removing a longitudinal incision through flexor reticulum. Injuries of the ulnar nerve commonly injured on two sides, on the elbow and on the wrist. Ulnar nerve injury of the elbow may due to fracture, dislocation of the medial epicondyle, thickening of the fibrous of the cubital tunnel syndrome, compression between the two heads of the flexor carpi ulnaris muscle, valgus deformity of the elbow, and atrophy flattening thinner muscles, ulnar claw deformity affecting the ring finger and the little finger. The first phalanx of the fingers are extended at the middle and distal phalanges are flexed. It is not a true claw hand. Loss of abduction and adduction of the fingers, flattened of the hypophyseal eminence of the interosseous of the loss of abduction of the thumb, loss of sensation of the thumb dorsal aspect on the medial 1/3 of the fingers, middle half of the fingers, 1.5 of the fingers, card test and formats sign of positive. Injury of the ulnar nerve at the wrist. Ulnar nerve is due to superficial position of the ulnar nerve at the site of the vulnerable cuts and wounds, compression of the Guyon's canal, Characteristic features: claw hand deformity, affected ring, little finger gear, but it's more prominent in the flexor digitorum profunda is paralyzed. There are 3 marked flexor digitorum intermediate. Flexor the distal intermediate phalanges. Atrophy of the flattening of the hypereminence, loss of adduction of fingers. Card test and Foreman's sign is positive. Card test for Palmer interocyte. Asks card test for Palmer interocyte. Doctor puts the paper and some resistance to film withdrawal. Former sign test. Foreman's sign test. This test is done as paralysis of the adductor pollicis. Give the thin book and give the thumb of the muscles. Paralyzed thumb will be flexed at the pollicis longest at the side of the superficially with the median nerve. The complete claw hand, combination of median and ulnar nerve claw hand deformity. The characteristic clinical features of a true claw hand are as follows: hypertension of the wrist and the metacarpophalangeal joints, flexion of the interphalangeal joints.